Everyone. And I welcome you all to the second day of the International Multidisciplinary Rehab Econ 2022 on Neuroscience and Neurology, organized by MGM School of Physiotherapy, Aurangabad, Maharashtra, and Association for Clinical Neurology and Mental Health. I would like to welcome all our honorable dignitaries and the eminent keynote speakers. I would like to invite Dr. N.S. Senthilkumar Sir, Chief of Operations Officers and Executive Director, the Association of People with Disability India. Next, I would like to welcome Kenwa Sir, Head of Research and Development, Kenwa Neurophysics Therapy Institute, Australia. Next, I would like to welcome Dr. Snehal Dharmayat, Associate Professor and Head of Department of Community Physiotherapy, Kahir Institute of Physiotherapy, India. Next, I would like to invite Dr. K. Vaidvelan, Associate Professor of Physiotherapy, SRM College of Physiotherapy, SRM University, India. I would also like to invite Dr. Diksha Singh, Women's Health Physiotherapist and PFM Specialist, Perfect 10 Maternity Rehab and Pelvic Floor Physiotherapy Clinic, India. Also, I would like to welcome Dr. Raj Kumar Yadav, Associate Professor, Department of Physical Medicine and Rehabilitation, PMR, All India Institute of Medical Sciences, India. Lastly, I'm glad to invite all the session chairs for the day, Dr. N. Ramesh, Dr. Shamit Kumar Katila, Dr. Zubair, Dr. Sugasri Suresh Kumar, Dr. Basavraj Motimat, Dr. Sarfarnaz F. Shah, Dr. Jyoti Parle, Dr. Bringiro, Dr. T.S. Muthukumar. I welcome all once again to the International Multidisciplinary Rehab Econ 2022, and I hope you all will have a great day with us. Now, I would request Dr. N.S. Senthilkumar Sir, the first keynote speaker. Dr. N.S. Senthilkumar Sir is Chief of Operations and Executive Director at the Association of People with Disability. He is having 21 years of clinical experience in academics research field of rehabilitation. He is also having experience in successful patent and copyright document writing. He is an international peer review journal holder and supervised with 13 research projects. He is having 2 patents and 2 copyrights. He is having additional qualifications in biostatics, physiology, and yoga. Now, I would like to hand over the dais to Senthilkumar Sir. Sir, you are muted.
Yeah, thank you. The host was not allowing to mute, that's why. Okay, great. Thank you. So can I share my screen? I'm allowed to share my screen?
Yes, sir.
Okay, great. Yeah, thank you. I hope the screen is visible for everyone.
Yes, sir.
Great. So thank you once again for the opportunity. The presentation for today from my end is it visible?
Yes, sir.
Screen is visible, everyone?
Yes, sir. Yes, sir.
Okay, fine. So we are going to talk about disability, a community-based rehabilitation perspective from my end today.
Sorry to interrupt.
Yeah.
The
Yes,
screen
yes.
is not visible now.
Is it visible?
Yes, sir. It is visible
Yes,
now.
sir.
Yeah. So let us touch about disability. I'm sure like people would have talked about in detail. So what is disability? It is a condition of the body or the mind, as we all know, which we usually call it as impairment, that makes it more difficult for a person with the conditions to do certain activities. It could be like buttoning a simple activity like buttoning a shirt or walking or any other activity limitation. And this limitation will not allow the person to interact with the external world, what we call it as a participation restriction. In older days, we call it as handicap. So that's what a disability is all about. And this is one of the flow chart which we normally come across, right? An impairment is nothing but a structural or a functional damage which actually leads to a disability. And disability, because of the restriction it leads to handicap, is what we all would have learned about. The same has been actually been modified in later context according to the WHO's model of functioning and disability, as we all call it as ICF framework. So it all remains the same almost. Only thing is more emphasis has been given on the environmental factors and the personal factors. So if you see that the body function and structure is what impairment is all about, and the activities, what we call it as disability, and the participation is handicap. So the most important thing which we all need to keep in mind, particularly the clinicians coming from the institution-based rehabilitation, is that the external environment or the personal factor, the conceptual factor, plays a significant role in actually rehabilitating a person with a disability, is a message I would like to give here. And I'm sure like all of us work in community-based rehabilitation. So the WHO's framework of community-based rehabilitation, which was enacted in the year 2010, which talks about CBR matrix, will have 5 verticals like health and rehabilitation, education vertical, livelihood, social, and empowerment. Most of us actually as professionals, if you see that we have a significant role in health initiative, in the health initiatives and the health delivery services. Whereas when it comes to education, livelihood, and social and empowerment, we have a less significant role to play. But moving forward, I would say that if you talk about enabling, equipping, as well as empowering a person with a disability, all these areas has to be touched in order to empower them. So that is where actually the CBR matrix plays a significant role of actually talking about these 5 areas. And as you could see that all the 5 areas and again divided into 5 other subdomains. So the second thing is most of the professionals, again, I have seen that they usually focus on the short-term outcomes. Like, for example, if somebody comes with a pain, I relieve the pain. If somebody actually like, so it should not stop there. If you really wanted a kind of an enabling, equipping, and empowering role in the community-based rehabilitation, we need to actually look into the intermittent and the long-term goals. If you want to do so, you need to actually think about how I can able to enable the person to reintegrate back into the community is a question we all need to ask. So that is how if you see that the outcomes of any kind of a community-based rehabilitation falls into short-term outcomes, intermittent outcomes, and long-term outcomes. And usually the long-term outcome is seen later in the later part of it life or a long-term, long period. It is mostly of quality of life of a person with disabilities, their family, and the community. So as we all know, again, when you talk about different conditions of disability, you can actually group everything into 5, like cognitive or mental and visual, auditory, motor or locomotor, and then speech. These are the 5 common disabilities which we all know. In the last census, 7 disability conditions has been covered. However, as we all know, yesterday also there was a talk about the Right of People with Disabilities Act 2016, which says that the disability condition from 7 has been increased to 21. And a clause is also been given very clearly that if more number of clinical condition results in disability, that could be added at any point of time. So hopefully the upcoming census will be able to give us more data on disability. So not only about the clinical condition, the RPD Act also talks about reservations in higher education, almost not less than 5%, reservations in government job for people with disabilities, reservations in multiple other schemes, and so on. And also it emphasizes about free education to 6 to 18 years children with disabilities, and it majorly emphasizes on guardianship, establishment of authorities of disability people in multiple roles, responsibilities is another area which it insists. It is not only just a kind of a guideline, but also it imposes some penalties for offenders who actually does so. However, if you look into it, in the reality, there are it is again the state which has to take it seriously and do it. Multiple areas there is an improvement has been seen, but some areas, if you look into it, this particular act talks about accessibility. So according to this act, by 2021, most of the places in India should be barrier-free. However, we are still lagging behind far when you talk about accessibility according to this law. And again, I'm sure this slide would have seen very frequently in the conference. So this particular slide on the left talks about the percentage of the disability population across the country in various different states. As you could see here, there are some states where actually the disability population is more. And unfortunately, in the northern places, we also understood that the number of NGOs are very less, and the healthcare facilities are far, infrastructure and other things are far less compared to the other places. And according to the census 2020, previous census of 2011, it captures only 2.21% of disability as disability, but the reality is a little different. If you could see on the right side, there was a data from the World Health Population, which says that 15% of the world population has disability, whereas in India, we talk about only 2.21%. It could be because that it is a kind of a subjective assessment what the census team would have done, or it is not very inclusive is a conclusion here. And another important reason for data not capturing well, it also could be in disability particularly, we call that it's a best example for an iceberg phenomena, that not many disabilities are seen outside visibly. There could be other reason, because when you go to census, it is not a kind of a medical diagnosis and a medical assessment. It is more of a subjective questioning, asking yes or no kind of a thing. That could also be a reason that the data is not captured well. However, if you look into it, as you said, there is a study which has been done, which says that mental disability was found to be the most common type of disability, almost 36%. We are talking about only 2%, whereas this new study talks about 36.7%. So there is a huge variation in terms of data capturing, which becomes a huge challenge at the national level and also for the community-based interactions. Where do we commonly see people with disabilities? This is a very important question. And why do you see them there? So you don't see them in restaurants next to us. You don't see them in the educational institutions where we studied, or you don't see them working as colleagues with us in the workplace. Why it is so, and what is the reason? If you look into it, the World Health Report as well as the World Bank data says that disability and poverty will go hand in hand. Either poverty, because of poverty, people get malnourished and they end up with some kind of an illness, impairment, disability, or disability by itself. If you look into it, when a person is having disability, there is a less opportunity for getting education or getting livelihood, which again leads to more and more aggravates the disability. So disability and poverty go hand in hand. When you talk about a medical model of rehabilitating only the pain and able to making the patient walk, is not going to help us. If you want to really get rid of this, you need to involve in a community-based practice where rehabilitation experts should actually have a holistic view of disability rather than having only the physical role of disability. That is a message I would like to give here. There are multiple challenges, as I mentioned. You see that if you want to make this change, you need to work on multiple areas, like why people with disabilities are not seen is because of inaccessible transportation, inaccessible information. The information, though it is a digital era, the information what is available in the net or in the applications are very much being designed for people, able-bodied people. It is not meant for people with a disability. So that could be a reason. Belief in the medical model. I will just come in the next slide. What is a medical model? Poverty, segregated services, discrimination in the employment, lack of useful education, inaccessible environment, devaluating even attitude and so on could actually result in challenging of integrating people with disabilities to the community. I'm sure all of you are aware of this medical model and the social model of disability. In a medical model of disability, impairment and chronic illness often has been seen as the main problem. So if you see that, as I put the cartoon here, the problem is seen, the person is seen as a problem rather than the society. Whereas in the social model, the person is not able to be mainstreamed or inclusive to the society because of the societal barriers. And as I mentioned in my previous slide, the barriers could be the environment, the transportation facility, inaccessible content, and so on. So this is the major difference between medical model and a social model of disability. And usually in a medical model, a child or the person with a disability is in fault, and the diagnosis is made and the child has been labeled saying that the child is a cerebral palsy child. So the child is not able to perform 1, 2, 3, 4 things. An impairment becomes the focus of attention. Assessment monitoring programs are this thing. So that is how actually is a major difference. If you want to really society to change, you need to actually look into the social model of rehabilitation. And also we need to have a participatory approach. Usually like when you talk about a medical model, it's more of a prescriptive based approach, where if a person comes to us, we prescribe aids and appliances, we prescribe what they have to take, what kind of an treatment or therapy should be given. Whereas in a social model of rehabilitation, the person with a disability, the family, the caregivers becomes a part of the treatment plan and execution. So there's another question which we again need to ask when it comes to disability and community. Why education is denied for a child with a disability? And as you all know that there is an act which has been enacted in the year 2009 called Right to Education Act. And very recently, the NEP, the National Education Policy, also been implemented. With all these things, why a child is denied or a child is not able to go to education, there are multiple reasons. One is that denial of enrollments happens in the school. Lack of assistive devices. If a person has to go, they have to actually have assistive aids and appliances. That is actually not available for everyone, not affordable, not accessible. And lack of accessible spaces. Again, you need to have a railing, ramp, a toilet modifications, everything is required in the school. That is not available in many schools. Transportation facilities, lack of transportation facilities. The teachers' skill and knowledge on disability, because when they actually do the B.Ed and D.Ed, they are actually been more the skill and knowledge has been imparted on handling an able-bodied rather than a child with a disability. The curriculum is not adaptable. The peers are not sensitized on disability. Many times you see that when a child has been admitted in the school, the peers don't understand disability and they tend to tease the child, and then that itself will put the child into not regularly going to school, and also the negative attitude of the community. These are some of the reasons for education denied for a child with a disability. And if you look into it, despite all these things, as I mentioned, these are all some of the data which talks about disability. A recent UNESCO report in 2019 talks that 1/4 of the children with disabilities between the age of 5 to 19 years are not enrolled in any common formal education. And there is another data which says that children with disabilities are able to go to school only during the primary period, whereas when it comes to secondary education, because when it comes to secondary education, they have to undergo a common exam, which actually puts them in threat. So many of them will drop out when they actually attend the 8th standard or 9th standard. So they may not be able to continue further. And again, if you look into it, at least some of the schools are accessible. When it comes to colleges, very, very few colleges are actually having accessibility. That could be another reason. So these are some of the reasons of educational challenges which actually a person with a disability undergoes. And there are multiple models, I'm sure like all of you are aware of, but just to touch with, if you look into it, exclusion model is nothing but education is denied for a child with a disability. We call it a segregation model. What is segregation is nothing but put the able-bodied child in one school and put the children with cerebral palsy in another school called the special schools. So as we all need to understand that special schools usually do not follow curriculums. They actually have their own curriculum. So in that case, the child may not be able to go to higher education. So that is the challenge in a special schools, though attention could be very well given on rehabilitation in special schools. There is another model of education called integrated school, where the child is, as you could see in the picture, it clearly depicts that a normal school where a group of children with a disability could be enrolled in the school. That is what is called as an integrated school. And finally, what actually the government wants and what is a recent model of education is the inclusion school or the universal education for all, as you could see at the top, where if you take a classroom, you may actually tend to see a child with a disability sitting along with the able-bodied children, where universal education for all is the future forward. What challenges in child with disabilities? National Education Policy 21-22 talks about. I'm not going to going into detail about it because I'm sure people would have touched this. I will focus more on the rehabilitation part. Second thing, as I mentioned, they are not able to be educable, and similarly, they are not able to go for employment also because of multiple barriers to employment. One, if you don't have an education, definitely in our culture, we all know very clearly that it's very competitive to get jobs. So in that case, the child will be left, the youth with the disability will be left out with employment. So there are multiple other reasons like social and the cultural exclusion and the stigma behind saying that people with the disabilities could not able to perform par with able-bodied is also a stigma or a kind of a attitude which is existing in the society. That could also be a reason. and reduced participation in decision making and denial of civil political rights. Because if you see that wherever the decision making is happening at the larger level, there is a very less participation happens from the people with a disability. So there will be, again, there is no kind of a rights or something comes out of disability. Deficiency in the economic and the social and cultural rights. So these are all multiple reasons for denial of employment. And again, what happens if there is no employment? They will be again remain with poverty. So this cycle of viscous cycle of poverty, disability, and vulnerability continues in people with disabilities at the community level. So again, accessibility, we all know about what is accessibility, but unfortunately, you see that many times the curriculum, and there is no much of an emphasis on accessibility at the college level. So when we don't study about it, it will be very hard for us to prescribe about. So that is where actually I feel like it is very important for us to actually learn about accessibility. When I talk about accessibility, it is again a design of a product, device, services, and environments for the people with a disability. As rehab experts, most of the physiotherapists and occupational therapists will tend to actually talk about accessibility only in designing the products and services. Whereas when it comes to environmental modification, accessibility plays a significant role. And as rehab experts, we play a significant role in building the environment for a person with a disability. So when I say accessibility, it could be buildings, it could be different signages, toilets, transport, communication materials, as well as technologies. So these are some of the common challenges when it comes to people with disabilities, particularly in a community-based approaches. One is that we all actually very well trained on institutional-based rehab, where a person comes and then gets into treatment and so on. But there is a lack of skill and knowledge on CBR exists across. And second is lack of data. The data is actually not being captured well at the government level or even at the institutional level. And the third, lack of human resources. Many of the human resources, when you talk about rehab experts, are confined or would like to actually work more in the urban setting and in an institutional based model. Not many people are coming forward to actually look into the rural setting. So there is a lack of human resource availability at the last mile, particularly in the communities. And fourth is the lack of infrastructure in the last mile, because you see that most of the hospitals, clinics, and so on are being concentrated more in the urban scenario, where there is a lack of training centers or rehabilitation institutes in the last mile. And when it comes to government, also like government follows a siloed approach. When I say that, for example, if you come to, they say that this particular thing has been handled by the maternity and the child welfare. This is handled by Department of Education. This is handled by Livelihood Mission. So that, there is no continuity or disintegration of different ministries also one of the reasons and the challenges in the community-based approach. And NGOs and healthcare institutions are again more confined into urban rather than a rural setting. And lack of awareness about disability in the community could also be a reason and a challenge in the community-based practice. So we have seen much about what are the challenges and the difficulties. What is the way forward? So the way forward is, first of all, like what are the different government initiatives? Do rehab professionals are aware of these policies, and do rehab professionals take part in decision making and policy making is a question I would like to reflect on. If you look into it, there are very good schemes in the government which actually like many of us are not aware of. Even that could be a reason that we are not able to actually make use of it. So yesterday there was a talk about right to people with a disability. But if you see that these are the 10 most important government initiative, I would say, like there is a scheme called Disha, which primarily focus on early intervention children between age 0 to 8 years, particularly children with the cerebral palsy, autism, multiple disabilities, and learning disabilities. And there is a scheme called Vikasa scheme, which primarily takes care of the daycare of these children. And Nerame has a very good scheme where actually government pays close to 1 lakh rupees for a child with a disability for health insurance as well as for therapy. So even if a child is not affordable for therapy, the parent can actually apply for a Nerame scheme and they can able to get insurance to actually give rehabilitation as well as for any kind of a medical support. Sahayogi is a caregiver training scheme where actually the caregivers are trained as therapists or to actually know how to manage a child with a disability or a person with a disability. Bhakte Kadam is again an awareness campaign. And NRLM, the National Rural Livelihood Mission, talks about 3% reservation for livelihood opportunities. Even if a person is finding difficult to get a wage-based employment, through the NRLM scheme, they can actually apply for a seed fund and they can able to start their own entrepreneur or a kind of a self-employment at the last mile. And again, the Solampana Yojana talks about giving concession in terms of loan again, And DDRS is a Dina Dayalan Disable Rehabilitation Scheme, which majorly talks about creating better environment, accessibility, homes, and so on. And ADIP scheme, I'm sure all of you are aware of, where actually the National Institute under the Ministry of Alimco and NGOs are able to give free aids and appliances for people with disabilities. So like that, again, the Sugamaya Bharat Abhiyan is again a universal accessibility campaign. So there are multiple things are there. Only thing is that these schemes are not known to professionals, and also like they're not been creating adequate awareness to the community could also be a reason for these schemes. They have a lot of money, but at the end of the year, if you look into that, it has not been completely been spent. And when it comes to rehabilitation initiative as institutions, these are some of the centers which are available. The state spinal cord injury center is again at the state level. Very few centers are available. Not every state is having this initiative. Composite rehabilitation centers, composite regional centers are supposed to be at every state level. There are 16 states have these composite rehab centers now. DDRC, District Disability Rehabilitation Centers, again focuses more on giving rehabilitation as well as aids and appliances. District Early Intervention Centers, DEIC, is again focuses on particularly on early intervention children between the age 0 to age 8, which primarily talks about 4 Ds, like defect in birth, disease in children, deficiency, as well as developmental delays. And we also have a district mental health centers, where actually government is investing close to 2 crore rupees every district mental health centers to make available medical resources for people with mental illness. And government also created a taluk and a block level BART centers, which is called Block Inclusive Education Resource Training Centers. These training centers also have an infrastructure and also have rehabilitation equipments like physio equipments, OT equipments, and speech equipments. And they have employed a block inclusive education resource teacher, who is a special educator to give education for these people. But if you ask me, these are all sparingly being used. And again, there is a lack of knowledge at professional level to refer people with disabilities to these centers. And these are different organizations under the disability division in the Ministry of Social Justice and Empowerment. And as you could see here, we have a national institutions, we have public sector undertakings, private sector undertakings, composite regional center, as I mentioned. So many initiatives have been there, but it is actually not well been used. Another important question to actually ask about community-based impact is about the different approaches which has been followed. So usually when it comes to institutional based rehabilitation, like an hospital or a clinic or a multidisciplinary hospitals, we normally follow a multidisciplinary approach, where actually, like, if a child, imagine a child with a disability comes to the place, an occupational therapist have his own plan, physiotherapists have their own plan, speech therapists have their own plan, and the child will be actually been moving to one place to the other place. I'm sure like all of us are aware of the interdisciplinary approach, where in a rehab setup, where cross-disciplinaries come together and have a common goal to address the issues of a person with a disability or a person who is coming for rehabilitation. There is a new thing, or again, a very well thing called community, is called a convergence approach. Okay, when I talk about a convergence approach, it is called as a transdisciplinary approach, where every field of practice, people, the parents or the caregivers, the policymakers, everyone come together and try to solve a common issue. So that is what is called as a transdisciplinary approach, which has been very well been welcomed and then played a significant role in actually creating impacts. If you talk about the leprosy eradication program of India or the polio eradication program, it is actually more of a transdisciplinary approach. And not only that, when you talk about the COVID initiative, which has been happening in the last 2 years, where different people are in the community, it's again a transdisciplinary approach, which has actually gained us very much confidence in terms of coming out of the COVID. And coming to assistive devices, I'm sure all of you are aware of, but mostly like most of the physiotherapists or rehab experts talk about assistive devices only at the product level, like an orthotic and prosthetics, but it should be going beyond that. So as you know, assistive devices is any item or a piece of equipment. It could be a product, it could be a modified or a customized thing, as we all know. So I'm sure, like, again, this is a very important thing which I would like to emphasize here. According to WHO, there is an 8-step protocol for providing assistive aids and appliances, prescriptions. One size never fit all. But unfortunately, in a clinical practice, we actually do a prescription of we say a wheelchair, but it will not actually help. There are different 8 steps are there before you give any aids and appliances to a person with a disability. I'm sure, like, moving forward, this should be part of the curriculum, and we need to emphasize this in clinical practice. When it comes to adaptive aids and appliances, there are multiple ways and means. One is called a remediation, augmentation, and substitution. For example, even a person, if without a glass, wearing a spectacle itself is an assistive device, which we never think about. We think that wheelchair is an assistive device, but even a spectacle is a assistive device. And augmentation is nothing but communication devices, and substitution is a processes. So high level of acceptance in community will happen only if the device is lightweight, portable, easy to use, cost effective, and also we need to design it in a universal design and perform effectively and reliably in all settings, not only in the urban setting but also in the rural setting. And improving the adherence will happen only if you actually involve the person or the user in the decision making of giving, rather than just prescribing the aids and appliances. And we also need to train them, install them, and provide them services and follow up after giving the AT to the person. And this again a last information, strengthening the ecosystem. There are beautiful systems in the government, like government has got multiple stakeholders like ASHA workers, Anganwadi workers, village rehabilitation workers, multidisciplinary rehabilitation workers, RBSK doctors, BRT teachers, and so on. But what we have understood in the last 62 years, I'm coming from an NGO background, where actually in the last 62 years, we understand that if you could work closely with these people, you can leverage this and strengthen this system. Just to give a simple example, like ASHA workers actually are responsible for the 1,000 houses, as we know. If you could capacitate an ASHA worker to identify a child with a disability, she can able to easily identify and she could refer the cases to you. Similarly, as you know, an Anganwadi is like a preschool in the last mile. If you could capacitate the Anganwadis, you can include the child. When the child attains 3 years, the child will get nutrition because Anganwadis give midday meal. And if the child is malnourished, Anganwadis refer the child to the nutritional rehabilitation center. Anganwadi provide education. So what happens, it could be a respite care center for the parents. So this is a simple example I would like to give. Strengthening the government stakeholders and strengthening the ecosystem is very much important, which can bring down the cost of the therapy what we are giving, and also like it will able to create an ecosystem which could be sustainable moving forward. And it is also very important at the community level to create grassroots level organization like self-help groups, disability people organization, community-based organization, federations, and so on. And as professionals, we need to represent in members in different states and national level forums and disability groups rather than confining only in the groups. So if you see that the Niti Aayog, there is a committee called Niti Aayog committee, which are think tankers of the country. There are committees for Mental Health Act, there are committees for Accessibility Act, and so on. But these are all usually not been represented by the professional group. And data is again a very important thing, which is important in order to strengthen the ecosystem. So the final take-home message: as rehab experts, we need to develop the skill and knowledge in a holistic rehabilitation practice, and we need to move out from a prescriptive-based approach to a participatory approach, where the family and the caregivers and the community should actually involve in the treatment planning and execution. And we need to follow holistic comprehensive rehabilitation, not only working only with the physical component, but also in other components like social, psychology, education, and livelihood, which could enable, equip, and empower a person with a disability. And we need to strengthen and also have some knowledge and advocacy and policies, which will help us to mainstream the system and services. And as I mentioned, rather than stopping only working with the beneficiary at the patient level, we need to move forward to work at the capacity of the different stakeholders of the government, which I mentioned in my previous slide. We need to develop cost-effective, community-based, replicable, and the scalable rehabilitation approaches to reach the last mile, because whatever we are touching in the urban is only 20%. 80% of the people are living in the rural area who has not been able to get rehabilitation at the last mile. Strengthening the data, measuring the outcomes and impacts of the rehabilitation becomes critical. Unless and until professionals comes in the last mile, it is not going to be possible. And finally, we need to strengthen and support research on disability, because most of the researches which has been done from rehab are all more of brain management and the clinical conditions. I'm sure like if you could able to strengthen this, a new way could actually happen for people with a disability. And this is a classic example I would like to say before I stop my presentation. So if you see that like an elephant, I'm sure like all of us know about the story of a blind man, where whatever we are touching, we feel that is what it is, but it is not so. We need to come together, the user, the patient, the community, rehab expert, and the technologists to come together if you want to really understand what the complete elephant is all about. So rehabilitation to all should be the goal moving forward. Alone, we can do so little. Together, we can do so much. With that, I would like to end and thank the organizing committee for giving me the opportunity to present here. Thank you. If there are any questions, I'm open to answer.
Thank you so much, sir. Now, I would like the audience, if they have any questions for sir. Thank you, sir.
Thank you, everyone.
Next, I would like to introduce our next keynote speaker, that is Mr. Ken Ware. He is the founder of Nutritional Science Private Limited and Neurophysics Therapy and Research. He had been in private practice for almost 30 years while doing independent and collaborative research. He also presented unique research at 10 major international science conferences, including neuroscience, physics, psychology, and life science, which covers a very broad scientific audience. Now, I would like to hand over the screen to Ken.
Thank you very much for this. Well, first I'd like to thank the organisers and welcome. Hi everybody from Australia, and certainly like to thank the organisers of this event for hosting it and allowing us to present our research under these challenging circumstances these days. So the presentation is on perception, action and cognition and the role chaos plays in the maintenance of our psychophysical health and well-being. So it is like two presentations. So first I'll focus on perception, action and cognition, and how we can sort of look at how a person is perceiving the environment, acting upon the environment, and cognitively being able to manipulate that. And certainly we're going to see where the areas occur that leading to complex disease and disorders. So for those of you who don't know much about neurophysics therapy, so neurophysics per se is a branch of medical physics and science, and it deals with the development and use of physical techniques to gain information about the nervous system. And that's usually done on a molecular scale, so neural networks and complexity science are just some of the tools utilised to make sense of the data and to develop theory. So using functional MRIs and PET scans and lights, and basically what they are studying is perception, action and cognition. And neurophysics therapy per se, I founded it more than 30 years ago, and we've earned our own footprint within that branch of science, I'm proud to say. We also develop techniques to be able to see how a person is perceiving the environment and how they're cognitively being able to control their circumstances within the environment. So certainly, interact with the environment through the expression of well-known aspects of network science and chaos theory and complexity. So we developed neurophysics therapy. It's a study in the functional and behaviour of the human nervous system and how it perceives and responds, interacts within the environment, and the development of specialised techniques to optimise the system's functional and behavioural potential to accomplish specific outcomes. So we've been quite successful over the years, and there's been lots of international and national media attention coming our way for it. So 60 Minutes, and the front page of the Daily Mirror down there was a victim of the Manchester bombing. Martin Hibbert, he came out, he had a complete spinal cord injury, a bolt had gone straight through his T10. So he came out for therapy, and it was quite successful within a couple of weeks of gaining a lot of function back. So there's been, a lot of other, like I said, other international and media attention there. And over the years, it's all accumulated in Stephen Pazlovsky's award-winning documentary Calibrate, which is it's won several awards in national film festivals. And if ever you get the chance to see it, it's a beautiful film. People telling their stories that come from all over the world for neurophysics therapy. So on to the talk. So perception, action and cognition, and the role players can in the maintenance of their psychophysical health and well-being. So a brief overview. The human central nervous system is by all definition a complex adaptive system. And complex adaptive systems are sensitive to their initial and external conditions. So internal and external initial conditions where tiny influences can have a major effect. And human beings, however, are extremely sensitive to initial conditions due to their higher order perception and emotional elaboration of the environment. So some of the initial conditions that our psychophysical systems are extremely sensitive to are environmental, they're deterministic and essential for our survival, gravity as an example, while other initial conditions our systems are extremely sensitive to have many more degrees of freedom and are deemed to be chaotic, being based upon the individual's moment-to-moment subjective experience of their world. Our individual perceptions, action and cognition are sensitive and vary considerably from one person to the next. So this is an example of deterministic chaos, which is a contradiction in terms. And however you consider the masses of starlings flying in unison, It is also what's called a deterministic chaotic system, but however, it's deterministic because we know what the rules are. So each bird is just communicating with its nearest neighbours across the electrical field. There, those nearest neighbours communicate with other nearest neighbours until the whole system behaves as one. So birds go from being an individual bird, grooming themselves, eating and having sex and all that type of thing, and then all of a sudden a predator comes along and they transition into the state where they do this beautiful behaviour. But it's chaotic because we don't know what it's going to do next. And so there's another example of a deterministic chaotic system. So we're going to focus on perception, action, cognition, and in that sense, it is chaotic because there's a lot of undeterministic values when it comes to individual perception and so forth. So a prominent theme to understanding the onset, incubation, and manifestation of complex psychophysical diseases and disorders is sensitively dependent upon an individual's perception, action, and cognition. So in other words, rogue errors in perception, action, and cognition create the sets of initial conditions that give rise to the onset, incubation, and manifestation of complex psychophysical diseases and disorders. And how we perceive our world is how we're going to respond to it. So we're developing a new lens, summary of a new lens to view the onset and incubation of disease and disorders through. So for the sake of viewing all these complex that we had to respect, we put aside all the existing medical research, information, and protocols presently available on several high-profile complex disorders and diseases. Then we ask the questions. So what are we actually looking at here? Why would a human complex adaptive system suddenly begin to display unexpected destructive rogue patterns of behaviour? What did these random systems-wide negative fluctuations inform us of in relation to the state of the system and its relationship with the environment? It's been truly undefined. We've identified that living complex adaptive systems are scale-free systems, so fractal physiology. So what occurs at one scale of the system occurs at all other scales of the system, from the macro through to the micro. And very much we look at how we're going to exploit that. If we can see a change taking place at some scale of the system, it means that there's a change taking place at all aspects of the system, all scales of the system. So complex adaptive systems are sensitive to the internal and external initial conditions, where tiny influences can have their major effect, and that's typically the butterfly effect, where they talk about, the theory was a tiny butterfly flapping its wings in Beijing could cause an earthquake at some other part of the world. So the influence here is that the onset and evolution of complex disease and disorders are the magnification of the system's underlying kinetics. And these are the sets of initial conditions that are giving rise to the macro psychophysical representation of these individuals. Unfortunately, in the case of patients harboring complex disease and disorders, an undesirable portion of their macro psychophysical representation is taken up with the emergence of their symptoms. So MND symptoms, for example, are emergent phenomena. And the simple beauty and elegance here is by altering the system's initial conditions in a prescribed manner, these modulated sets of initial conditions will enable for the emergence of more desirable patterns of psychophysical behaviour. And metaphorically speaking, it's like tweaking a slight alteration to a cellular automata algorithm that gives rise to a system structure and function. And we see Wolfram's Rule 30 over there, where Stephen Wolfram back in the early 80s was just running some programs, and he got to Rule 30 and he's wondering what would happen if you just let that play for a while. And as time went on, it developed all this, went into what he called a chaotic state. And he didn't quite understand what chaos was in those days, but he was actually correct. And of course, as he kept running that rule, then we started to see the patterns that we see in nature appear, like the patterns on shells and leaves and snowflakes and so forth. And Wolfram made the statement then and said, it seems that nature uses very simple rules to generate very complex patterns. And a lot of his peers sort of shunned him for that. And he was basically had to say, well, I'm not saying this is nature. I'm just saying we don't need to have complex rules to generate complex patterns. So some of the simple observations and baseline measurements of initial conditions of patients presenting with complex disease and disorders pre-neurophysics therapy. What we see is long-term posture neglect, and which is very important. So we've done a lot of studies with posture. So with a healthy person, we have EEGs, actually EMGs on their trapeze, abdominals and adductors. And when we look at how they're poised within that vertical constant that gravity supplies, we see that in that state, there's a nice good flow of intelligence through their system. If you move them away from that vertical constant, you can see the noise and the randomness start to build up in that system. And all biological systems have evolved with a physical structure to optimize its performance and functionality. So it's calibrated and measured against the only true constant there is in the natural world, and that is gravity. So it's inescapable. So we have apparatus, certainly in our system, that help us to maintain our optimum state at that level. So our studies have observed several patients who are treated with complex disease and disorders that each patient has maintained very long-term posture neglect. So we can sort of see how there's a lot of noise building up in the system over time. So compromised proprioception is another example of that. So proprioception, just where my body is in space-time and things that are distance from me. So proprioception is just nested within a perceptual landscape as to what we perceive to be our reality. So if we see errors in proprioception, and the simple task would be a person with their eyes closed, moving their fingers slowly across their body, not fast, having to do it nice and slow. So you can watch the activity taking place in both arms and compare both trajectories. And usually as they're coming across there, they don't really have much idea at all where their fingers are. But not only that, you'll see them quite off in terms of one arm might be higher than the other, or they'll twist off to one side. So as I said before, you can see errors in proprioception. There's errors across all levels of percepts. And it's that noise that builds up from those false sensory perceptual errors that generates this underlying turbulence within people's systems. So turbulence being the conflict between when two energies conflict with one another. So the innate nervous system knows exactly what our reality is, but it gets in conflict with our subjective version of that. So we do the finger to the nose and back to the finger again. And, so what we also see there is when persons experience a lot of uncertainty. And uncertainty, again, is a scale-free phenomenon. So if we're seeing that there's a lot of uncertainty about where their fingers are and so forth, if you had a healthy person and you all of a sudden created a lot of uncertainty for them in their future, that would start to create health problems as time went on. Some other things, we have the long-term activation of the sympathetic nervous system, that's that fight or flight. They've been accustomed to and perceived as their normal. So the trapeze group of muscles are very sensitive to hyperactivity of the sympathetic nervous system. So if a person tenses up in their trapeze muscles at all, it means that their sympathetic nervous system has been activated. And unfortunately, if you watch the behavior of a lot of children today, even when they're on their iPhones and their iPads and so forth, even though they appear to be having fun, and they're texting their friends and they're doing all those things, but you'll see what's their posture and you look at the tension that's in their trapeze. And basically it's information overload, where there's so much information coming into the system through their visual system, that the system is adopting that protective posture. And that stays activated for long periods of time. And eventually the parasympathetic nervous system, the interneurons that connect those two, just simply can't kick in anymore. So they have that long-term activation of that. So they have what we call hypervigilance. They have a lot of hypervigilance where by perturbing them, you see an image of there myself. I've just had a model to help me out here, but just by getting them to sit there and relax and close their eyes. And the idea is just to allow me to move their legs back and forwards freely. And of course, as soon as you start to do that, you'll start to see the tone will very quickly build up. They're trying their best to relax, but they just see that they can't do that. So their system basically is in a hyperprotective state. And what you'll also see is a lot of inconsistency between how one leg behaves and the other, which means one hemisphere has a different view of what's taking place to the other hemisphere. And that's very important, because when they're walking around and there's those hemisphere imbalances, every time they put their left foot on the ground, it tells a different story to the brain to what the right foot does. And because of that inconsistency, the body then naturally wants to adopt a more of a protective posture. So these are some simple things that any therapist could do to sort of start to help to calibrate a person and to get them some sense of self and teaching them to learn to relax. The point being is that whatever's going on in their system, good, bad, or indifferent, is very sensitive dependent to these initial conditions, how the person initially, what we'd see, getting as close to the initial conditions as possible. And the beauty and elegance of all this is if all of a sudden they start to detrain some of those vigilances and learn to get their proprioception right, all of a sudden we've got evidence that neurons in their brain are firing differently to how they were before. For the disease, disorder, or despair, whatever we'd like to term that to stay place, it would need all those neural networks to be communicated in exactly the same way and be able to maintain that. So as a therapist, if you're thinking that you're changing behavior of a person anyway, we sort of need some evidence that neurons in the brain are firing differently to how they were before to be able to justify that we have made it, to be able to validate we have made a change. So it's just very important, like we don't need to do sometimes big things to correct what some people might consider to be major problems. It's just getting all the simple things right first. Standing on one leg at a time, first with eyes open, and they find that that might be a little bit difficult and a bit noisy to begin with. And again, you'll see the differences between how they present on one, how they stand on one leg, but with left leg to the right leg often, and they get to the understanding that. And then we do it with their eyes closed, and that's when we see how visually dominant we become as a society. So it's not just relevant to any particular person we're looking at. It's when they close their eyes, all of a sudden we start to see, you know, that their system is way out of hello. They're way out of whack. So now, again, that can be quite intimidating. But if all of a sudden they just learn to relax and just let their system work it out, the laws of energy conservation would say that if I set a pendulum off swinging, that pendulum is going to keep losing energy until it finds its lowest energy state. And because that's the law, energy must be conserved. If the person just learns to relax, and they can rescue themselves whenever they need to, but just let themselves relax and let their system calibrate itself back to that vertical constant, which it knows how to do, which is self-organizing, it will go through all the conformational states until it stabilizes itself at its lowest energy state, which is when they're doing it correctly. Again, any disease, disorder, despair would be very sensitive, dependent upon the person's initial attempts at what they are doing. That's how the nervous system is communicating. And by altering that and changing that up, well, that's simply the math doesn't add up anymore, because the disease, disorder, despair would need the person to still be in that state where they're not being able to perform these duties, these tasks very well at all. So just acknowledging some of those simple rules, like primary rule here is to treat the person, not the disorder. This is a landscape where we do not really need to delve into people's medical records too much at all, because by simply having them to be able to do an assessment on them, and we can see that there's some type of errors, that all the different things I was talking about, we would be able to understand, okay, there's some type of disease, disruption or despair within this system operating at these, because of these initial conditions. And again, it's just a simple matter of you know, going through some different processes. And these are all just simple things that we do in preparation for proper neurophysics therapy, which involves a lot of the exercise machines, which we'll be going through later. And like I said, just by simply practicing these tasks and learning to prune all the possible journeys that the arms could take, and they're pruning it down into something where now there's reliability, there's certainty again, they've developed a degree of certainty. I know where my fingers are, I know where the tip of my nose is, I can relax and move my legs freely from one side to the other, all those type of things, where there's been a huge up change in the system, and the system is now operating at a much more optimum level to be able to navigate its environment. So noisy inputs always infers noisy outputs, and it's observed in these patients that increases in anxiety levels amplifies their symptoms. So it becomes like a positive feedback loop. The more anxious their symptoms might appear, they become anxious about that. The more anxious they become, the symptoms will increase, the symptoms will increase, and it just tends to go back and forth like that. So it's very important that we learn to detrain that anxiety. Some of them exercise machines, I'm just using one here as an example. So the pec flight, so the area is being targeted there. Basically, the input is coming through that pectoral area. Now, that is a highly sensitive area. So if something was to come fast into that space, we'd clutch ourselves to protect ourselves. If the same stressor came towards the shoulder, we'd probably use our shoulder to bump it away. But the machines are unilateral, so the handles work independently, so we can actually see with the person with their eyes closed, and you see how the person is gated on sitting there with their legs apart like that. Again, if I see their legs moving in towards one another as they're doing the movement, it would tell me that they're going into a protective posture. Now, the body doesn't assess, the system doesn't assess that it's sitting on a piece of gym equipment. It's just having a sensory experience of the world. So when that person is trying to relax as much as they can, and we have a very mild stimulus, so the weight is at the lowest setting, and they start to move those handles across their body very slowly, that's when you start to see the underlying anxieties and fears that will start to emerge. If they went quickly, you wouldn't see a thing. It's like watching a DVD and fast forward. You wouldn't be able to tell much of the story. But of course, that can be then quite confrontational for the person. Now, they're in a safe, supported environment. There's no lions running around the room. They have all the controls. So there's no reason why the machine can't make them anxious. There's no reason why that anxiety would be there. That is the person's, what we call their default. That's how they're experiencing their world all of the time. So it's a very rogue response to a very mild stimulus. However, by learning to go through that slowly and learning to, as when they start to feel anxious, to stop it, calm it down. So getting into that amygdala pathway, amygdala-fugal pathway, and just trying to take neurons that should be reporting safety and comfort have somehow crossed over and are reporting fear and anxiety. So all those things need to be detrained. And again, whatever was going on in the system, the good, bad, or indifferent, disease, disorder, it would need that person to maintain that background of anxiety and keep experiencing the world that they have been in order to maintain it. So by going through this, what we call a grid, where they work through this grid slowly and eventually get rid of all that noise and learn to prune all their emotional responses to that over time. And there's several machines then we go through that come in through different pathways that really help to develop what we call multi-stability. So the system becomes stable at several points. So out in the real world then, when they're navigating the real world, they have stable reference points. So if they take a perturbation, whether that be physically or emotionally, it doesn't take the system too long to be able to find one of these stable reference points again. And what we're really focusing on the person's sense of self. So our sense of self is everything really. So when the person gets that middle point, when the stress is on their system at that highest level, it's an opportunity then, regardless of what some of the initial sensations might have been of anxiety, it's the opportunity for the person then to start talking themselves up, feeling good about themselves, getting a great sense of control and flow through this system. So it's not just an arm thing, we're talking about something that's a whole body movement. So like I said, getting to that, really improving that sense of self. And then under those conditions, neurons are firing together really strongly. So that's when they start to develop associations. And so they've got new associated experiences that are overriding what the pre-existing experience was, and which is very, very important. So always trying, basically going over the same thing. So we see that it is a grid. We can take measurements at any point in space time, and to be able to monitor a person going through that. So we see every fluctuation in biology matters. So we don't forcing ourselves through that anxiety. It's an error. It's an error that shouldn't be happening under these conditions. So they've got to learn to stop and control it and increase that sense of self. So a typical perceptual error down the bottom there, a person might be veering off to one side, and that displays a hemisphere dominance. So whatever side they veer off on, it's actually that hemisphere that's causing the problem, because it's contralateral, so it's making the other arm be more dominant over the restraining one. So we're on to the second part of the talk now, and as I've got up the top there, chaos rules. So the underlying kinetics of our central nervous system is chaotic, and we can see that at many scales. And one of the earlier references to this was looking at Ari Goldberger's with his heart dynamics that he was taken right back in the early 90s. And if you ask the person, you look at these were time series that people were measured over lying down, measured over, monitored over a 30-minute period. And it was during that process that they started to see that all these nonlinear dynamics would appear in the healthy heart. But if you ask the person, so pick which one is the healthy heart, they most likely would try to pick C, because it looks nice and periodic and so forth. And of course, we say over there that's heart failure and pathological breathing. So down the bottom there, this arterial fibrillation, you see that it's lots of random. It doesn't have too much variability in there, so it's quite noisy. But when we see the healthy heart, there's lots of variability over time, and it needs to be in that way so we can respond to things very rapidly. So it's interesting dynamics, and we'll be looking at that and the role that the particular work we do. So the natural resting state of the healthy brain is chaotic, and due to their characteristics, self-organized criticality is intuitively attractive as a model for brain functions such as perception and action, because it would allow us to switch quickly between mental states in order to respond to changing environmental conditions. As complex pathologies emerge when the brain becomes less chaotic, so when areas of the brain begin to synchronize, that's when most likely a seizure is going to occur. So Lapomedes and co. back in the 90s, when they had these poor patients who were in hospital, and they had 5 probes at different locations of their brain, because they're trying to locate areas where a lesion to create a lesion to inhibit the seizures from occurring. And what they've seen that approximately 50 minutes before the seizure, that those areas of the brain would synchronize, and then then the person would have the seizure. At this point, the system would dispose of all that excess energy and over-oiliness, and then normalize itself to its best possible state after that. So it's that build-up of excessive energy that the system is obviously trying to dispose of. And what's really super interesting here is that seismologists see that the onset of a seizure and the onset of the beginning of an earthquake is that they follows the same power law distribution. So we see the seizure dynamics up the top up there and the earthquake dynamics there. And it's really interesting if you get to have a look at this, because it's very extensive studies and involved a lot of regions around the world, and thousands of patients with seizures. So we see that the frequency of seizures and the frequencies of earthquakes in certain areas of the world were the same. So it's really interesting to see again that nature tends to follow some simple rules. So over on the right there, one of the patients that we had who was suffering long-term from chronic epileptic seizures. So this data was pre and post 5 days of neurophysics therapy. So the top slide there, time series there, we see that the 4 EEG locations we had, these areas were very highly synchronized. And there was a song that was played to the person, and we've seen that under those conditions, the areas of the brain synchronized like that. When the same song was played 5 days later, we see down here now, it's not there's not a lot of synchronization at all. So that's getting more in towards the healthy brain. So just my long-term, we're going to see some interesting things here. My long-term history and study of the understanding exploiting chaos in the central nervous system. So when we experience our world, as we said, the underlying states of the system is chaotic, and it's not when we're experiencing our world, it's not that the body is eliminating that chaos, it's just controlling the chaos. So we have apparatus within our system that controls the background chaos. But when a person learns to transcend that under some prescribed conditions and via the stimulus, let's say the person is doing that particular exercise on the machine down there, if they learn to relax, a mild tremor will start to appear. And people have seen that in the past, and what they've tried to do is inhibit it. But the encouragement that I was giving people many, many years ago, because I found it was really interesting. I thought the tremor was telling a story about the state of the system. So I was encouraging the people just to let it go. So just to let that evolve. And we've seen that they went into a very high dimensional chaotic state. The person was perfectly coherent and could switch it off any time, but they learned to relax. And then we could see under those conditions how noisy that was. Did it display nice pink noise, which would be a healthy system where we'd see a nice flowing type of dynamic, or very, very noisy with lots of randomness and lots of velocity, not much velocity, lots of amplitude. So there'd be lots of hertz. If you looked at the hertz signal there, it was massive frequency but very low amplitude, sorry. So then we go into a Brownian state. And what was really interesting is that when a person presented with a disease or disorder and they display these type of dynamics, by allowing the system to just dispose of that excess energy, very similar to the fact that the person having a seizure will dispose of that excess energy, the system would then self-organize up to a higher state of complexity by getting rid of that. And they, in very, very small timescales, there's been some incredible things take place that have we've seen incredible relaxations of symptoms over time. But what's important is that they need to be able to go through what we call the grids of the machines first, so that there's some structure and there's some things for when these dynamics appear that it's got some reference, not just lying on the floor and dancing around on the floor. So I'm going to show you some footage now of a little bit of a segment from Calibrate, and just to give you a bit of an example of this. So take notice of the fellow in the blue shirt that you'll see on one of the machines. He was the victim of the Manchester bombing, and he had a complete spinal cord injury, T10. So he presented where his legs were flaccid, he couldn't self-support. So just take notice of that when you see this footage. Yeah, so it's pretty interesting, and it can be quite confrontational for a person to see. But like I said, there's something that the person is complete control of. They can switch it off. But the most important thing is then learning to let go. So it's when systems become over control, that's when a lot of problems emerge in terms of pathologies. So one of the more famous stories that relate to this, 2013, John McClane is a very well-known wheelchair athlete. He was the first person to swim the English Channel as a wheelchair athlete, and complete Kona, the Hawaiian Ironman, that grueling event in Hawaii each year. So John had simply came to me for some pain therapy. It had nothing to do with anything else except trying to help him deal with his pain. As I started to take John through the process with the machines, like we've seen before, as soon as he was starting to do that with movements with his upper body, I could see activity taking place within his legs that was very much in sync with his upper body. So we have a look at that footage now. It's quite interesting. So on the left-hand side there, you can see that the fluctuate, those tiny oscillations are starting to begin. And John's legs, of course, they've flopped out the side there, and straight away we started to see some bilateral activity. And I thought, wow, that's really, really interesting, because I'd never even actually worked with a person with a spinal cord injury before. Now, John couldn't control that movement at all. Now, it became so volatile that it actually, I shouldn't say volatile, but it's so intense that it actually blew the cable off that red machine. We had to get on another machine. But if you just watch his legs, and in particular, what happens when he abandons the movement, the leg will flop out to the side. And John has to then voluntarily bring it back. John has to then pull it back. So you can see the look on his face. He was quite stunned. And we asked me what was it. And I was explaining the role central pattern generators play, and the fact that somehow his system had learned to get around that lesion. It's just that his belief system, of course, and all the other types of things he'd been doing didn't allow him to actually experience that. So take his first system. Said some pretty, in 18 months after that, John went on and completed an able-bodied triathlon, and people were asking all sorts of questions. What about the atrophy? How can he could do that? But like I said, the system is just incredible and how fast he can respond. So John has a book out, How Far Can You Go? And that was the 60-minute story that was based around that. And as I said, he went on to complete an able-bodied triathlon 18 months later and crossed the line with his family. So, beautiful story. So one of the more significant things, this is a bit more graphic. Kylie, who had waited until this lesion had this tumor had a 2-litre blood supply before they thought it was suspicious. And of course, by the time we got to that, they ended up cutting out the whole, all her hamstring was gone, 3/4 of the adductor process, and of course the whole sciatic nerve was sacrificed. So it would be considered that there's no possible way that she's going to be able to bend her knee, voluntary, dorsiflex, do anything like that at all, and in particular, walk normally. So within the 2 months of neurophysics therapy, we see Kylie standing up there, performing some movements, very nice and bilateral. And it was the whole process of, not just trying to work on that leg, it was using the same stimulus coming in through both legs to inform the brain. So the right hemisphere needed to learn from her left hemisphere what it needed to do to make adjustments on the right-hand side of their body. So, I would be speculating that, some cells we had to differentiate and then convert into different cells to be able to do these jobs. So they might have been antagonistic, and now they've got to work and play in another role. So whatever the case was, it was pretty phenomenal that she was able to accomplish this, and to see some of them. Incredible lesions. So focus, keep sinking. So this is another lady. She was wheelchair bound. And, this is week 4, which she's able to walk. So pretty incredible. So there's one more slide I'd like to show. If I'm running over time, can somebody please pull me up, because I have other things I'd like to show you, but we'll. So this is Ned, who has a complete T10 lesion as well. And you see under these conditions, his system is should see that it's just no respect for that lesion. So how his body is moving. So there, as I said, there's lots of other little things, and this was a person with long-term muscular dystrophy. So we can certainly see that on the when we're working with a control here. So that's the control on the left-hand side. This was the initial pre-neurophysics therapy. We were looking at the GMI analysis of the EEG and the subject at rest, pre-neurophysics therapy, and the GMI results, the subject post day 4. So we start to looking into the control. A patient with MND, which is obviously a very serious disorder. So these, again, we have different channels. The top 2 channels are EMGs, left and right trapeze. The middle 2 are left and right abdominal wall, just adjacent to the navel. The next 2 are the adductor process, the inside of the thigh. You see the ECG, of course, and the EEG. So they can see various system over-orderliness, and they're highly synchronized events occurring through this patient system. However, we put up the data we're just looking at, and over on the right-hand side there, that is the control, the healthy control. So you can see how densely populated all those channels are in particular. And then we'd see down on the bottom left-hand side there, that was post day 1 of therapy at rest. So, and then over on the right-hand side, we see post day 4 of therapy. So we can start to see significant normalization of that patient's conditions across every scale there. So I'd like to sincerely thank the organisers again for hosting this event, and of course everyone who's persevered with me through my presentation. And my sincere thanks also go to thousands of patients who trusted in my method over the last 35 years or so, and for all those many assistants and neurophysics therapy practitioners who have helped evolve the international reputation of neurophysics therapy where it is today. Thank you very much, everybody.
Thank you so much, sir. Thank you so much, sir. Now, I would like to audience if they have any doubts regarding the neurophysics therapy. So now, thank you, sir. And now I would like to introduce our next keynote speaker, Dr. Snehal Dharmayat, ma'am. She is an associate professor and head of department of community physiotherapy at Kahir Institute of Physiotherapy. She did her master's in physiotherapy in the field of pediatrics physiotherapy at the Rajiv Gandhi Institute of Health Science, and she cracked it in her first attempt. She is having additional training in brain, HIT, MT2 blade, ISTM, NSS, PO training, and NSS ETI. Now, I would like to welcome you, ma'am, and I hand over the screen to you, ma'am.
Thank you so much. I hope I'm audible.
Yes, ma'am. Yes, ma'am, you are audible.
Good morning to all of you here. I thank the organizers for giving this opportunity, and I bring greetings from the Kahir Institute of Physiotherapy to all of you. This brief presentation of mine is on the outcome measures that can be used in disability research, because all of us are rehabilitation therapists. We do conduct research, but then we come to a standstill sometimes as to what measures to choose for what kind of evaluations. So I hope my presentation throws some light or clears a little doubt in the young researchers who are there present today. At the outset, to begin with, let's define disability. I think all of us know what disability is. It's basically something that makes a person's impairment interfere with his activities or his daily participations. It's a dynamic and a complex interaction of all these factors, which makes it all the more challenging to evaluate and to intervene also. So it's a multidimensional experience for a person who's actually living it, because it includes all the faculties. That's his sensory faculties, his physical, his mental, his social, all of them. So these are the multiple components that need to be evaluated when we are doing research on people with disability or trying to identify the causes or the impact of the impairment on his functioning. These are some facts from the WHO about disability. as it is saying that almost everyone is likely to experience some form of disability, either a temporary or a permanent disability at some point in life. So it makes all the more the research on disability all the more important and more pertinent for us as rehabilitation therapists. It is also useful for providing data to the policymakers so that they can create more policies, more opportunities for people with disability to towards a more inclusive society, so that these people become more productive members in the society. So all of us as rehabilitation therapists should work or do work to this end. Now, coming to the need for disability research, like I've already said, it is necessary to study the functional impairments and what effect that impairment has on the person's life, so that we will be in a position to help them better, become more productive, or achieve whatever are their goals and aspirations. This will also help us to determine the effectiveness of rehabilitation programs. It provides data to the policymakers, like I said, to help develop more policies which are taken into account for the different faculties that are affected also. It helps us in advocating equal rights for the persons with disability. There is a long-standing movement going on right from the 1800s for trying to create an inclusive society for people with disability because they have been badly marginalized. So all the research that we do adds to the data that is there, adds to the information that is already there to help make it a better society for people with disability. Now, defining disability studies or research, disability research is different from studies. Disability studies look at the more the sociological component which looks at the consequences of these physical, mental, and psychological impairments on an individual's other areas or other domains of functioning. That is mainly the mental and the social components. Whereas the disability research that we do is more like the clinical trials that we conduct. So this is usually done to find out or to determine the effectiveness of an intervention on an individual or the effectiveness of a rehabilitation program, whether it's community-based or institutional-based as a whole. So these are two different things. They are usually used synonymously or interchangeably, but that is not how it should be. So, because disability studies look at the other aspects, such as the medical, legal, and the cultural aspects, whereas disability research looks at the interventions or the effectiveness of those interventions. Now, when we conduct research, there are different types of measures which are used for disability research, as in any other research also. The most common used type of measures are the patient-reported or the self-reported measures. Now, these usually are more descriptive in nature. They help get an in-depth analysis or an in-depth view of the quality of life of an individual, where there are descriptors put up. The patient, they are more of open-ended, where their descriptions are written by the person who's affected to help us analyze the quality of life. The second kind of measures that can be used are the performance-based measures. These are generally used in clinical rehabilitation settings to evaluate change over time, where you're evaluating the performance at baseline and after a period of intervention. Then the next type is the condition-specific measures, which are related to the functional disability in a particular condition, like, for example, stroke, cerebral palsy, or multiple sclerosis. So they are looking at the disability or the functioning related to that particular condition, not an overall view of it. So these are basically used whenever the objective of the study is to study the condition-specific disability. There are certain considerations that we need to take into account when we are choosing a measure for evaluating disability or for conducting a research, like for any other kind of research. The main things are the conceptual considerations, whether the domains that are intended to be evaluated are evaluated by the particular tool that we want to use. So, like, for example, if we want to evaluate the quality of life, we would not be looking at the other aspects of it. So is that tool what we are using actually measure or actually quantify the quality of life? Then we have the measurement model, that is how deeply does it or how accurately does it measure what we are intending to measure. The respondent burden is another important component because most of these quality of life tools are a little lengthy to administer because they are more descriptive in nature. You need to give people time to speak out whatever is their opinion of it. So are they too long, or are they, there are many questions that are there. So those two factors will determine whether it is accepted by the evaluators themselves or by the respondents also. So we need to look at something which is a little in between, which is easy for us to administer and for the patients also to respond to. Then again, the reliability and the validity of any tool are important. If we are not using reliable or valid tools, the entire exercise becomes a total waste. Another thing to consider is the administrative burden. That is whether any training is required for administration of the tool, a formal training. How easy is it to administer, or what are the different ways that we can administer it? How do we score it and interpret it? The ease of scoring and interpretation becomes important when we are time bound in a research. If it takes too long to score, too long to interpret, or it's too complex, then it becomes a little more difficult to use that tool for research. Now, when we are dealing with people with disabilities, we need to have a tool which has an alternative form of administration also. Like, for example, the self-report measures, which are to be filled by the person with disability. Is it available in an alternate form where it is only audio, or it is in a braille form for people with visual impairment? So all these things also need to be considered. Another thing that is in an alternate form is what is called as a proxy administration, where if a person is not in a position to answer it by himself or herself, it can be read out to them, and the answers can be marked. The cultural adaptations that are there. There is a lot of cultural variation in a particular state itself from district to district, and there's going to be a big leap when we talk of countries across the globe. So has that tool, what we intend to use, been adopted to the culture and the language where we are intending to use it, whether it is available or not? Because not all countries are English-speaking countries. So has it been translated into other languages is an important component to consider. If it is not being translated, then we can look at the proxy administration, whether it can be done through a proxy administration. Now, looking at all of these considerations, we will go back to, we will continue with the scales that can be used. At the outset, before I actually begin to talk about the tools, let me make it clear that these are a few generic tools which I will be highlighting. There are a lot of condition-specific tools which would be an entire day's presentation. So I have not included the condition-specific tools. These are generic tools which can be used across disabilities because they are neutral to the health condition. To begin with, I would like to start with ICF, that is the International Classification of Functioning, Disability and Health, which is a part of the WHO FIC. Now, the general notion about ICF is that it's an evaluation tool. It is not. It's a classification system which helps categorize individuals based on their levels of functioning. That is the present level of functioning, using what are called as core sets and developing a functional profile. Now, these core sets have been developed for 31 health conditions so far, which have pertinent points related to that particular condition across the globe, which is being studied. And there's a set that has been placed, or it has been put in place, which we can use for our population, where whatever is pertinent to our patient which is being evaluated, develop a functional profile. These can be used for therapeutic goal setting as well as monitoring progress over a period of time following an intervention. This has been used in varied cultural settings and research settings, clinical settings, and has been found to be effective in evaluating the change. And there is work in progress to develop more core sets for other health conditions which are not present right now. Sadly, ICF is not used or not preferred by the clinicians because of the perceived notion that it takes a long time to administer. But like any other tool, it grows on you. The more you use it, the more you get used to it. But you need to understand it. So if you know what exactly to use, ICF is the best tool because it gives you a functional profile which you can use across disciplines, across health disciplines, across health conditions. So ICF is an important tool when we are talking of disability research or when we are talking of rehabilitation. The next scale that can be used is what is called as the WHO Disability Assessment Schedule, or the HODAS 2.0. This is a practical, a generic instrument for measuring health and disability, which can be used in field research or even in clinical settings. This is in accordance, or it is a direct correlation with the ICF components of activity limitation and participation restriction. This is again neutral to disabilities. So you can use it for varied health conditions. You can use it across age groups, across genders, and it has also been evaluated cross-culturally. So it has got a good cross-cultural comparability and good psychometric properties. It helps to evaluate the impact of the disability or the impairment on the functioning of an individual. So it has got a good reliability also, and it is easily available, freely downloadable. Anybody can use it. It doesn't require any kind of formal training. The scoring is also simple, and it has been translated and validated across the globe in many countries. The scoring for HODAS is a brief scoring. There are two different versions of the HODAS which are available. The long one is the 36-item one, and then there is another 12-item brief questionnaire. They all, both these versions look at the 6 domains that are mentioned here, that is cognition, ability, self-care, getting along, life activities, and participation. Each of these domains are scored separately, giving us what is called as a domain score. Now, this domain score is going to point us towards the focus of intervention. What is the focus of intervention that is going to be required? Now, if you're using it in a clinical setting, you have the simple scoring where it is 1, 2, 3, 4. You score it and you see the change over a period of time. If you're using it for research, then we need to follow what is called as the IRT, the item response therapy, where we are converting it into a metric score, because that has more validity in research settings. The metric scores range from 0, that is no disability, to 100, that is full disability, with also percentile values being provided at the 50th percentile, indicating that the person has with disability is in experiencing an average level of disability in comparison to people with the similar disability. So 50th percentile is like the midway. Anything higher than that indicates that the person is experiencing more difficulties. Lower than that, lesser the difficulty. Then another important aspect when we deal with people with disabilities is what is the quality of life. So the WHO defines quality of life as an individual's perception of what is their position in context to the value systems that they have been brought up with, and also in relation to their goals, expectations, and concerns. There are certain indicators for quality of life, which are the employment, the physical and mental health, education, and also security and freedom. Now, as healthcare professionals, the health-related quality of life becomes more pertinent for us. So we need to look at that component more, because that is going to affect all other components in an individual's life, all other domains in an individual's life. Because they say health is wealth. So if you're not healthy, not just physically or but also mentally, if those components are not looked into, then everything else becomes a little less relevant. So the measures that are available for evaluating quality of life, one of the best known measures is the WHO health-related quality of life. This has been adopted in more than 15 countries across the globe and has been translated in 40 plus languages. So you can understand how well it has been used for studying the quality of life. There are two versions again in the WHO QOL, that is the QOL 100 and the QOL brief. The QOL 100, as the name suggests, is a lengthy one, which has got 100 questions to be answered. So that was a little tedious for people to use. So that led to the need for developing a brief version, which could be used in busy clinical settings. That is the WHO QOL brief. Now, for an in-depth analysis, if you want it more detailed, if you want a more more descriptive analysis, then you can go in for the QOL 100. But if you want it for a brief study, then you can use the WHO QOL brief. It can be administered through the self-reported method or also through an interview. Now, this is useful in establishing baseline scores in a range of areas which look at the change in the quality of life over a period of time following an intervention. So even the quality of life also changes with intervention, not just the person's level of functioning. So they are all interlinked to each other. There's a dynamic interaction in all of these. Now, for clinical research, WHO QOL helps in making decisions regarding the treatment options and what are the areas of concern which need to be intervened in. Now, again, the QOL has got 4 domains with total 26 questions. Each of these domains has a Likert type response, that is from 1 to 5, which is completely agree or extremely. Now, each of these domain scores also gives us the areas of concern which need to be looked into, which need to be intervened. There are all these give us an overall perception of an individual's quality of life. Now, if you want to make the WHO QOL brief correlate with or validate with the QOL 100, it is divided by 4 in order to make it comparable with the QOL 100, because there are 26 or 25 divided by 4, multiplied by 4, sorry, which will make it comparable to the QOL 100. The items or the scores are positively scaled in an HR QOL. That means a higher score indicates a better quality of life, a better perception. So you can use the HR QOL for studying the quality of life in an individual. Now, another measure for studying the quality of life is what is called as the personal outcome measure. This was initially, this is more pertinent for people who receive long-term rehabilitation services or support services. Has been developed in the early 90s. A lot of variations, a lot of revisions have happened. This is a more individualized measure, whereas the WHO QOL, even though it is individualized, it doesn't look at the individual as a whole. This is a more personal. What are my dreams? What are my aspirations? What are my goals? What is my perception? Based on that, we develop an individualized intervention plan in the areas of concern. Now, initially, it had 3 categories of description, that is myself, my world, and my dreams. It has been revised, like I said, many times, and the latest version, which was developed in 2017, had 5 categories with the same 21 indicators. Those categories are over a lot of different areas, so which give us the areas of concern where a person needs help or needs support with. So these are administered through in-depth interviews. So it's a one-on-one interview with the evaluator and the person with the disability. The most important component of why we are doing all this, why we intervene for people with disabilities and all other things is, we want them to be participative members. We want them to be productive members in the community, what is called as community integration. So the ultimate goal of all our rehabilitation services is getting these people back into the mainstream. So that is community integration. Community integration, as defined by people, is the full participation of all people in community life, in all walks of life, which includes independent living, being productive, and having a good social activity as well. Now, community integration, it can be evaluated through what is called as a community integration questionnaire, which is a brief, reliable measure, which was initially developed for evaluating community integration of persons with traumatic brain injuries. But over a period of time, seeing its applicability, it has been adopted and validated for many other health conditions. And it is quite widely used in the Western countries for evaluating the community integration or reintegration of people with disabilities. It is administered via an interview, either in person or even through telephonically. It has 15 items which are spread across 3 domains. Each of these is scored in a generic way. There are scores which are ranging from 0 to 29. Again, higher scores indicating higher or greater independence and better community integration. So to summarize, we looked at some generic measures which can be used in conducting disability research, that is clinical research in disability. Like I've already mentioned at the beginning, I have not included the condition-specific disability scales because they are too vast in number, because each single health condition has got like 5 to 10, and stroke has got the maximum number of functional scales or disability scales. So depending on what is the condition and the disability that is going to be studied, you can use those condition-specific scales along with these generic measures that we have seen so far, which will help get an overall picture of an individual or a person with disability. To conclude, I thank the organizing committee members, especially Dr. Rinkle Manalni and Dr. Pooja, for giving me this opportunity to put forth my views and sharing the platform with such an international faculty. I would also like to thank my principal and management at the university for all their support. Thank you.
Thank you, ma'am. Now I would like to ask the audience if they have any question for ma'am.
Thank you so much, ma'am, for such a wonderful session.
Thank you.
Thank you, ma'am. Now I would like to introduce our next keynote speaker, Dr. Vadilim sir. He is an associate professor at SRM College of Physiotherapy, SRM Institute of Science and Technology. He did his master's in the field of sports physiotherapy at Wells College of Physiotherapy. His research interests are oral therapy, pediatric neurology, rehabilitation, fine motor skills using iPads. He is having more than 10 publications. He is having a private clinical practice since 2002. I welcome you, sir, and I hand over the screen to you, sir.
Thank you. Thank you for your introduction. I thank the management, entire management, for giving this platform to present my topic. Just share the screen. I think it is visible. Yeah, I'm audible and visible.
Yes, sir. You're audible and visible.
Yeah, thank you. Thank you. Thank you for your concern. Right. Okay. So today my topic is oral therapy intervention, the current evidence and future perspectives. I think it is in past 3 decades, people are not much aware about the oral therapy, but still we are using and listening music at a different cost, and but we are not entering into the research perspectives as well. So first of all, I just want to say that is what is oral therapy, how it is works behind, and then what are types that should be encounters with the vestibular systems to reach to the higher centers. There should be an monooral or else bioral therapy, and it is going to be how it is going to be syncs the systems as well as to produce and executing a fine coordinated movement as well. And then finally, I'm going to say about what is the current evidence as of now, and then the future perspectives for this oral therapy. The oral therapy has been as successful as a therapeutic interventions for persons with a disability, and you have know that, and some may know, some may not know about this. What is that, and how it is going to be have an effect of the child with disabilities as well as other neurological conditions. And it has been, this therapy has been used for this preschool to late adults, as well as because of in case of a learning disability, as well as in case of an attention deficit hyperactive disorders and other congenital adventures. And it is important role in developing and maintaining restoring physical functioning actually, and they're going to be reinforced. We are listening music, right? When we are listening music, definitely what will happen, because you are regenerate and you are going to be very much energetic and doing certain things. And without you are listening music during that period also, you have to nod your head, and your all systems gets work appropriately, and focus on keen on the music as well. So the same motivate the movements as well as it gets structures, exercises which prescribed in physical rehabilitation. We have to make such things in that representation of the beat frequencies with a kind of protocol to enhance the patient to get a better outcome with the therapy, right? And it is involved, I said, it is going to be involved with the beat frequencies. I think you know about how the beat frequencies works in interventional therapy, right? How much hertz, based on 4,000 hertz and 3,900 hertz, and the remaining that the beat frequency is going to be on 100 hertz, right? The same way that you're going to fix the hertz as well as to stimulating your nerve systems using your brain waves, the alpha, beta, gamma, delta, and to executing the proper execution of the movement. So this frequency, this involvement in beat frequencies may provide distractions from the pain, discomfort, anxiety, and some associated physical disabilities also. And it is going to be very effective in achieving a variety of physical, emotional, social goals relevant to the individual's need, the capabilities, and preferences. It is used actually, I think more often people are using to maintain the joint range as well as the muscle functions, to increase the fine and gross motor coordinations, and increase the strength, as well as increase the range of motion, improve the cardiovascular, cardiopulmonary, and the respiratory functioning, improve the oral motor skills, and facilitate relaxations. All these things is a good source actually. That I think most of them are things about that oral rehabilitation is works only for the those who are having a hearing impairment. In people are handling only in the speech and language pathology, not at all, because we are also use that kind of beat frequencies to enhance as well as to get a good results with the patient with some chronic conditions in stroke as well as Parkinson's disease as well as cerebral palsy. And this is going to be have incorporated in different musical medias as well as a rhythm, beat frequencies with the rhythm. There is an individualized treatment goals we are going to set up exactly and to find out good things, right? So this is going to be flexible and adaptable to match with the physical movements that should be elicited with the clients also. And what is the science? What is the science behind the functional outcomes of rhythms and vestibular systems? You all know that in default, when you're in jogging, when you're in walking, and either you're entering the temple also, there will be a mantras and chanting will be there. That soothing effect, as well as the in Maharishi Yoga centers, all these Isha Yoga centers, it have a wide that is in meditation centers that encompasses integrating such things into the body part and mind and soul to be relaxed and come across with a better mind. So that should be the same kind of inference that can be found in this science that is going to be a inception of therapeutic listenings, right? That have a multiple conversations with therapists, and parents are like questioning how it is possible that filtered music can enter the widespread impact of the functional outcomes. So you know that, right? So a small rhythm that inculcate your brain to act accordingly. And if you've seen certain things, certain movies as well as certain things, and you have to be that energy as well as a level, and then things has to be come across with the functional outcomes of your the based on the music rhythm and the inner ear. And this possible, I think how it is possible, the filtered music, I think, because it is a very, very clear statement in sensory integration by the IRS in 1972. The neural processing of the sound can be classified as one of the primal forms of sensory integration, because it has a long been has a major source of information regarding the basics of it, right? So we use, because in always using that auditory cues to the patients, as well as when we are in the exercise therapy, or as well as in doing certain exercises, as well as in suspensions, we are giving some auditory command and tapping the shoulder and encouraging the persons to do that. The same way that the person cannot, because with the disabled people, it's not possible, that we have to enhance with this oral therapy, have a better good effect. Actually, this is how it is influencing the perception of rhythm. Studies has been proved that there is an intersection with the auditory and vestibular systems influence of rhythms. That should be that research has been carried out and clarifying the neuroanatomical connections between the inner ear and the processing of the rhythms. You know that because it enters the ear pad, right? The vestibular, it has been received in the inner ear of the cochlea. It has reaches the eardrum and executing the tapping to sound tympanic membrane is going to be act process. So because these are the interconnecting things that should be passed through. Several research has been studied and examined the interrelationship of vestibular and auditory systems, and they have concluded that vestibular system is a primal to the rhythm perception. Okay, so when we're going to stimulate the vestibular, right, so we have to encompass this with the oral based auditory stimulus and rhythm that should be very useful, and then integrating such things in the higher, right. And the Phillips and Silver and Tyner in 2005 conducted a study where the babies were bounced on every seconds or every third beat of indistinct rhythmical pattern. Following this movement pattern, right, infants are sitting passively, listen longer to the music. So we are. I think you have an idea that the pregnant women, the trimesters of 30 and above, then they are supposed to use this a kind of auditory impulses that should be that the child can be able to listen appropriately, as well as the movement can influence because of the perception of the rhythm also. That should be done, and this has been conducted. A good trial has been it has been encompasses with the ultrasonographic evidence has been proved actually. In addition, the latest advance of neuroanalytical imaging have an overlap of this brain as well as associated with the both rhythm and the vestibular processing. And even in Todd and Lee also, a strong musical rhythms shows and evoke in the same brain associated area with the motor timing to execute and explain the movement actually. And talking about that, commonality in processing of the rhythm, how it is, and integrating with the vestibular, it is a process of rhythm actually. Vestibular systems in certain areas, the brain can associate it with the postural activations, right, and orientations of moving our bodies in organized fashion through the space that should be executing with the thalamus, and you know that basal ganglion, cerebellum, and the vestibulospinal and reticulospinal pathways, and the motor and motor areas of the cortex, it all get integrated with the central pattern generator. Okay, because of this, right, the rhythm that should be in encompasses, that should be in stimulus that reaches we can able to correct as well as activating your postures and then maintaining and then body postures and active enough, as well as orienting then an organized fashions. All these things can be encompasses with this central pattern. And then this oral therapy, how it is works with the person with the disabilities. And then first is it facilitates the relaxations and increases the motor coordination and reinforce the provide motivation for physical exercises. Facilitate relaxation. I think you have an idea, right? So that whenever we're supposed to have certain music or hearing certain things or a good rhythm tone or something like that, definitely what will happen, because whenever either in clinic also, either in the waiting area also, the patient is not distracted well, as well as the patient enters the department with kind of a good music, with the background music, with a small BGM, with a mild sound, right, helps the patient gets relaxed. And then whatever treatment you are going to give, right, it is going to be that the patient does not have a repulsion effect, right. It's going to be very smooth enough, and to have a good the pain perception. The pain has been dissolved, as well as with the muscle is relaxed, with the conditions the muscle is relaxed, right. The same way, that's increase of motor coordinations, as well as and again we have to reinforce provide the motivation for the physical exercises, because we have an app based oriented mobile applications. And now there are enormous things are there using with the audio and taking that instructions and it is going to be integrated the Wi-Fi and using with the command, as well as to reinforce providing the motivation for the physical exercises. And then foster independence, right. They have to be very independent, and then self-confidence, because most of the time what ages enters into degenerative stages, right. So that cases also people are more frequent fall will be there. That will be there. We are giving certain exercises as well that we are going to be incorporated with oral based therapies that will be more beneficial for the patient also, and have a self confidence and self esteem also. Developing functional speech and communication abilities also. I think because it is still that the hearing impairment here department as well as the PSLP department, they are more focusing on the speech and communication abilities. This helps a lot actually. They have been proven so much of papers, and even the same kind of protocols has been adapted with the learning disability as well as and attention deficit hyperactive disorders also. It is a good result actually came with that. Okay, and then motivate interactions with others also, that kind of things there. So these are the help. The oral therapy can help with physical disabilities, person with physical disabilities. Facilitate relaxation, I said no, is an important component in achieving increased range of motion as well flexibility as well. That is important when working with a person who have difficulties with the spasticity also. So you know that it is a continuous firing, because when we want to have an impulse, that impulse is going to be act through the sensory and act accordingly whatever the motor is going to be executed. The same way that the impulses has been passing through because of the synergy was in higher centers, there is no looping mechanism. Because of this continuous firing of the muscle may leads to this synergy pattern as well. That because if this you have to be that severity effect of the beat frequencies, and definitely the patient will get relaxed. Okay, and then there is no such tightness and contractures cannot able to form this case, right? And we have there's some cases, some studies have been in the 1882 itself, scatterly they have been done with that compared to the EMG biofeedback also with the spastic cerebral palsy has a good results in campuses, right? So this music experiences that can promote relaxation, including the listening to careful chosen music and instrument improvisations as well. The match it can be matched with the guide physiological responses that you are in, that is going to be that respiratory rhythm, pulmonary rhythm towards achieve the more relaxed state actually. So that's good things that facilitate relaxations with the person with the disabilities also, because it works with the spasticity also, and even it works with the other Parkinson's disease also, improving the gait speed as gait and then cadence. First initially they have a number of cadence will be there, and then slowly it is going to be come across with the control of the beat. The person can able to achieve the task as well. And increase the motor coordination that encompasses with this beat frequencies. So I'm saying the beat frequency again and again. So what is beat frequency? I'll demonstrate next upcoming slides. And this select instruments can improve the fine as well as the gross motor also, and even have an eye-hand coordinations. And then this rhythm auditory has been having even control of ambulations with individuals with an uneven or arrhythmic gait pattern. That's what I said. No, in Parkinson's, it's worked well actually. In Stratum in 1983, they have been demonstrated to have a good effect actually, because some evidences, current evidences have a good effect, but if we are not following it. But in future perspectives, if you are incorporate with your that is a visual reality program, and then this kind of we can encompasses with this oral rehabilitation. So have a good effect when compared, right? So, and reinforce, I said, is a provide motivation for physical exercises. The use of this oral provides a positive, enjoyable atmosphere with a person with physical disabilities, right? We have to reinforce again and again, because with the careful choosing of because just like that we cannot able to give certain things, right? So that we have to be carefully have to choose in the background music, enhance the physical exercises. That rhythm and frequency enables the patient, enables the person with older age or else any chronic or any other disabilities also, they can able to encompass, because they are giving some guidance also with the frequencies along with the communications. Along with the communication, the person can able to execute the careful. That is what we have to choose very careful on backgrounds on the music to enhance the regular physical exercises. This is going to be adapt and then flexible and maintain match the individual motor motion tempo, right? So the whatever the background music, the BGM, right? So that should be incorporated with this motion in tempo, right? The style and rhythm pattern. they can able to execute the movement, right? Initially, there is some disturbances and they cannot able to come and control. The initial step, what we have to practice is we have to give for the session for give the session for more than a week or 15 days. They have to be follow the frequencies first and to relax the mindset first, and then go for the session to be have a good effect actually, and help to provide and distractions and diversions from exercises, and just maintain the participations with regular exercises routine, less tedious also, right? So that it is works in group therapy also as well as an individual. That too have a ritual also, because now it has came with this lots of upcoming technologies. People are more on with virtual, and then start the therapist also using the virtual program through that mobile applications and giving that frequencies, and they are going to encourage accordingly. And if there is an error corrections also, that should be also regulated with this machine, right? That should be also possible, and for the reinforcement for the physical exercises, and as well as foster the independence of self-confidence and self-esteem. So, and this it is going to be that acquiring the new skills now first initially, foster independence and self-confidence and self-esteem. They are going to acquire the new skills and abilities and independence to be that follow the next step of the positive image and self-concept, right? And in Brodsky in 1986, oral therapy activities has been adapted according to individual needs and capabilities. Yeah, we have to assess appropriately, as well as it can be enforced as to the next level of things to develop in the positive attitude actually. And then develop the functional speech and common communication abilities, right? So I think because of this, I think there are lots of research in this communication disabilities. They have been used as an what to say, that is singing and speech have many commodities will be there. There's a very common issues has been there for the people have an hearing impairment. It doesn't use this vocal exercises, right? We are supposed to encourage as well as to have articulations and oral skill activations, and then vocal intensity used with the vocal intensity to pronounce certain things, right? Even we are having certain cases if the child with have a multiple fractures, or else they are being admitted in the hospital for using as a tracheostomy for a period of more than a period of 6 months or 1 year. Then after remove the tracheostomy, then because there will be that much of communication is not going to be there with this child, and we are the persons, we are going to stimulate the muscle to act the muscle accordingly to go for the next level, right? So those through manipulation, this kind of tempo and rhythm have a clarity speech and come to the modified to provide increased communication abilities in the individuals, as well as this rhythmic training also. It will be more effective in treating and then aphasic conditions. It will be more effective in treating the aphasic conditions, and then and develop this and then do you know that melodic intonation therapy, right? That is involves sung intonations of proportional sentences because of the language issues, right? They have an intoned pattern and natural proboscis patterns of sentence which has been spoken. They are using the languages, sign languages, right? So we are not supposed to write. We have to encourage in intonation therapy. This techniques has also have an effective improving in more word movement, performance level, sentence lengthening, and then improve the articulation skills as well as the intelligibility for the language delayed in apraxic children. Why I'm using this always in 1980s or 1970s, right? Because there are good research there, but after some decades, there is no such thing. The research has been developed for this because it has been changed and shifted to the next mode of kind of treatment approaches. Music is also a stimulus, promote spontaneous speech as well as promote in case of non-verbal communication through the plus symbols as well as the sign language they have been used, right? So for this, right? And then and to motivate to interactions with others also. The person with the disabilities also have we can motivate through having social interactions and shared experiences with the peer groups, and it is going to be very helpful when they are going to be in a group therapy, right? The group enables opportunities to develop a peer relationships, because that once it becomes people are become elder, and they will going to be adapt with this centers. Even nobody is taking care, then they are going to be adapt centers as well. The group therapies as a good working together to have a common goal, actually, right? And the see all these things, right? Saying about that, what are all that kind of oral rehabilitation come across. There is a rhythmic auditory stimulations, as well as a music supported therapy, as well as a therapeutic instrument performance, and then patterned sensory enhancement also will be there. So in this each and every descriptions of intervention, these are the descriptions of the interventions, how outcomes. Sorry. This should be understood. That is this RAS, right? Is a rhythm-based rehabilitation techniques designed to facilitate intrinsically rhythmic movement pattern through the auditory cues, such as a metronome beats. Actually, they have been used. What kind of outcome, right? Sorry. So what is the outcome, actually, that this therapy has been through the modes of regulations, improve the concentrations, promote changes in the brain, improve the function, as well as known as the neural organizations. How it is works, right? Imagine that rhythmic auditory stimulations using the metronome, right? So it's going to be reorganized structures in the neural, right? As well, and the therapeutic applications of a pulse rhythmic and musical stimulations also improve the gait and related aspects of the movements. This kind of rhythms has been, right, and metronome adjust the patient cadence also. We are going to be inbuilt with a biomedical device as well. We are going to give some such input over there for the metronome also. It's going to be that this stimulus is applied, and it is going to be synchronized with the 4 steps of the rhythm. Once the synchronization is achieved, the necessary adjustment in the metronome frequency can be made. So how it is going to be works appropriately with this based on oral, right? that is also comes along with the what is the pattern sensory enhancement. That is also developed with the tempo, rhythm, and dynamics. And how this auditory beat stimulation works. First of all, this auditory beat processing is an auditory pathway through the ears and cochlea to the inner hair cells. Whenever we are supposed to pursue certain music or audible things, right? It has been enters in the ear as well as the cochlea as well as the inner ear cells, and converts the pressure waves into the neutral action potential via the mechano-electrical transductions will be done here. This is the first order of auditory processing prior to the sound have been encoded, and if it is not, rather re-encoded by the primary auditory cortex, because this lymphatic print is going to be stimulated again and again. The same kind of reflex also in primitive reflex also. Their reflex is going to be again. They are going to give such reflexes. If it is not going to be achieved appropriately, then the child may go for any pathological reasons maybe. So that the same kind of auditory information is further processed in the the number of subcortical structures, and how this auditory processing will occur in the auditory, because in the first thing that it enters into the ear and then inner ear, as well as the that should be the cochlea, as well as the transduction takes place, and then this auditory nerve fibers leaving to the cochlea converge, and then the vestibular nerve and enter into the cochlear nucleus in the brainstem and to bifurcate. As the nerve enters the branch, the synapse of different subtypes will be there. That is, you have seen that because in the auditory system there will be a spherical, a bushy cells will be there, and globular bushy cells and satellite cells, each of which have been a different and temporal as well as the spectral response properties will be there. That gives a spatial and temporal relationship to reach us to the higher centers. So this is a kind of stimulus. It's having a neuroprocessing going to be happen when we are going to give an auditory beat frequencies. What's the difference actually? Because I said in the first step itself, there be an monaural as well as a binaural beats actually. This monaural you are going to use it as a single earbuds as well as the earphones, right? And in as a binaural beats that you're going to be used it for both the ears together. In case if you are going to use it as a monaural, thing is to be that this is also have a good effect only in peripheral, not in central actually. In monaural, it is going to works in peripheral, not in a central, but in a binaural it works in central actually, and it is going to be executing the central pattern generator with all these the medulla as well as the that is in basal ganglia and cerebral not to be integrated and to executing the movement across, and then that should be have a good effect when comparatively with the compared with the binaural to than the monaural. This binaural beat is as a listening at two tones actually with a slight difference of frequency at the same time. Okay, this is you have to listen the tone of the music. Slight difference of frequencies will be there at the same time. So your brain is going to be interpreted with the two tones or the beats at its own, right? These two tones are aligned with the brain waves to produce a beat with a different frequencies. Okay, you have find a tempo in the movies as well as in the music also. One small music will rise and come in between, but you can able to sync the music along with your way of singing, right? That will be there, right? Same kind of things. So it's going to be have a two tones with slight different frequencies at the same time. It is going to be have an interpret and to align your brain waves to produce the beat with the different frequencies. So that is going to be have a heads in between the frequency of two tones actually. The same how we are following with the interferential therapy. The same how the history came in the bio. This is first reported by H.V. Down in 1839. It outlined the Foster over the 5 decades ago. And he reported that binaural beats were detected only the carrier frequencies was below 1000 hertz, and confirmed earlier with the linkages. This indicates the beat frequencies carries have a sufficient low enough to temporal coded in the cortex, and they have been adapted with the history and then they checked and analyzed with the biofeedback and applied the certain things, beat frequencies to the patients, and have a positive results we have found with it. So this binaural, how I said no, there is a two frequencies to produce a beat frequency effect, right? The same way that binaural auditory illusion pursued when the two different pure tone sine wave, both with the frequencies lower than 1500 hertz, with a less than of 40 hertz difference between them, a presented is going to be having 1 year to each, one through each year. Dichotically. For example, 530 hertz pure tone is presented to the subject to the right ear, and while 520 hertz pure tone is presented to the subject to left ear, the listener will perceive the auditory illusion of the third tone is called as the two pure tones presented to each other. The third sound is called as the binaural beat frequency. This is a classical example that should be pitch correlated with the frequency of 10, because here in the country it was clear that, for example, a right side here 530 hertz, and then the left side here is in 520 hertz, and then the beat frequency is going to be the third. The sound is going to be have a binaural effect and have a good pitch correlation frequency of 10 hertz actually. So that's going to be have a difference between of 530 to 520 hertz. This originates from because how it is going to be the what's of the neurophysiology behind with that, right? This binaural beat frequencies have been a perception to originates to the inferior colliculus to the midbrain and superior olivary complex to the brainstem, where the auditory signals from each ear are integrated and precipitate the electrical impulses along the neural pathway through the reticular formations up to the midbrain and thalamus, auditory cortex, and other cortical regions. Because see that how it is going to be indulging and incorporating that the beat frequencies of perception. So that this is the neurophysiology behind how this works in the using the electrical impulses. As well as you can able to see here, there is a sum of two waves, two sine waves are there, right? So there is a blue waves, two sine waves that is going to be have, and this two sine waves executing with the red and green shown in the one wave, right? In center. These waves also have some frequencies. You can able to see the picture in the green and as well as the red. There will be a constrictions as well as the restrictions of interference can be there. That is around, if I give an example of 520 and 530, right side and left side, the beat frequency of 10 hertz is going to be stimulated accordingly to have constrictions and that's distractions influence in the waves. You can able to, that is called as a beat frequency. The two as an identical, the frequency of green waves is gradually decreases 25%. Okay. For example, I given again one more example for the 440 hertz of the left ear and then 440 hertz for the right ear to be hearing a 4 hertz tone. That should be that the binaural, and this means that entrain your mind to reach certain mental state, because brain have certain waves. I said in the beginning itself, have to be a delta, beta, gamma, and theta. These waves have a different state of physiological response will be there to we can able to impose, right? So that's that's how I said in the previous slide, that should be that this is how it is going to be the superior olivary, right? So that the previous slide itself I said it is on how the physiology behind that this brief frequencies perception is going to be originates in the inferior colliculus, the superior olivary complex, right? So this superior olivary complex and binaural beats, how it is going to be, because located in the brainstem, and the first part of the brain that process the sound input from both ears, and the superior olivary complex synchronize the various activities in the brain. This complex hears two frequencies, creates a binaural beat, and this synchronization of this neural activity crosses the brain is called as entertainment. This entertainment have a binaural beats have the good brain function according to some researchers they found, and increases or hold back different brain functions, can control thinking and feeling also. And there's a new I don't know, because I just moved to the next. So 5 types of brain waves I said that affects the binaural effects. That is there's electrical signals that should be controls your emotions and behavior. Imagine all these things, whatever the time itself, you have to react according to the music, right? The same way that your signal has been, the electrical signal has been passed through, right? The same that the measured technique called as an AEG. This techniques can be recorded in the scalp of record electronic signals, how it works accordingly. This brain waves can be have a low frequency of high amplitude and high frequency of low amplitude. Okay, this creates a binaural effects. That's the things, right? It can be done with this with the EEG, brain EEG, right? And this is how the beat works here, right? The 200 hertz tone, the left ear, and the right ear of 210, the 10 hertz is going to be have a binaural effects. The major types of the waves are beta, alpha, theta, and delta, and 15 to 30, as well as alpha is 19. I'm going to be say one by one in this sessions, right? So in this theta waves before and after a synchronization, because that should be totally distracted. This picture shows that at encompasses how it going to be syncing over to the after 25 minutes, right? So that there's a harmonizing balance of the hemisphere, allows the brain to work syncing and making the communication, thought process effect, all these things come across when we supposed to go in this. Okay, there are 5 different waves that I said. That is, a delta is going to be have 1 to 4, that should be stated as a deep sleep. So when we most of them are using this delta as a healing and pain relief. There should be a mild BGM, right? 1 to 4 hertz. And even you can able to see in the Isha yoga meditation centers, and most of the yoga centers, they are adapted this technique for reducing all such things, all such tension, relax. It helps to have a deep sleep, as well as healing the pain, as well as have a good meditation effect to control the mind, body, and soul together. Okay, as well as the theta is going to be have 4 to 8 hertz. That should be that includes the meditation, as well as creativity and deep relaxation. And then alpha is also There is a state of mind that is focused in production of alpha brain waves to help to relax and focus, and then reduce the stress and maintaining the positive thinking. And that is what from the beginning I said, for a person with a disability, for reinforcing certain things, right? So that helps maintaining the positive thinking, as well as increases your learning capabilities, as well easily engages in activities and environment because the state of flow actually. So this beat next is and last is beta, that is 14 to 30 hertz, is a high frequency. Higher the frequency of this brain waves helps in keeping your attention focused and analytical thinking and problem solving, and stimulating the energy and action, high level cognition skills. It has been stimulated. Once you are going to stimulate with the beat frequency, have this for 14 to 30 hertz, the BEG has shows that it has to have a good keep your attention and focused. That's what we are. Some people has been adapted this technique as to for the learning disability, as well attention deficit hyperactive disorders, and even for the autistic kid also. So this might be helpful for analytical thinking and then problem solving, as well as stimulating the energy into the action and the high level cognition. And the gamma is 30 to 100 is more higher frequencies of beta, and it is going to have increased cognitive enhancement for articulation and speech productions, all these things, because we have to clear the sine wave actually that the people have an hearing impairment as well, and attention to the memory recall, as well as thinking and recreativity, that will be there in the frequency of 30 to 100 hertz in gamma. So the benefits is there are some lack of clinical research in binaural effects, because I have found, because the last 2 decades, and benefits are increase in cognitive enhancement, reduces the anxiety, and improve the mood state. And elders, once they cross the age of 50 to 60, there will be encompasses a lot of stress will be there, because of negligence, as well as not at all taking care of the persons, as well as in case of hormonal disturbances. All these influences, the people have a kind of a depression and anxiety, right? So these kind of oral therapy have a better recovery for the patient, and improve, as well as the focus, attention, and memory retention will be there for this case. So current evidences and future perspectives, I said in the beginning itself, there are to date a significant number of clinical and experimental studies have tested in oral rehabilitation and improve the nervous system, central nervous systems, and have degenerations, motor functions following. And so many articles has been apprised the current state of knowledge, interventions, rhythm, and modulate movement. This spatiotemporal patterns restore motor functions. That is a current state of evidence we have found. And I just give us some small example that how the research has shown proven has the effect. The Todd et al. At 2015 and Dam et al. At 2020, that is synchronization of the body movements, and used with the external auditory stimuli, a metronome, and then even this metronome also they have been modified with devices to give some instructions along with the beats and regular rhythmic structures, and they have a precise detect of auditory systems, including the motor brain, and have a good involvement of rhythm perception, and movement productions will be there. So this definitely helps the patient actually. In the beginning I said there is 4 things that should be there: rhythmic auditory, as well as music supported therapy, as well as the therapeutic instrument performance, as well as the patterned sensory enhancement, right? 5 to 10% has been found in this increasing number of studies. There is a robust of experimentals and clinical evidence of applications of rhythmic auditory systems as a rehabilitation tool for the gait for the Parkinson's disorders. Imagine the recent article Gay et al. In 2018, as well as Guy, and he did again in stroke patients the same kind of frequencies, and traumatic brain injury and spinal cord injury. And it is a Maggie et al. At 2017, and they have been adapted in multiple sclerosis also, and even in cerebral palsy in other older adults. So that's what it is. It starts from the childhood, as well as to that whatever adventures rates goes. We are going to supposed to use this kind of an auditory response, auditory stimulation have a good effect comparatively, as well as this a consistent evidence has been proven with acute stroke patients with a significant improvement in gait spatiotemporal parameters of velocity, cadence, and stride length also, because have a good effect actually. It is consistent effect with this rhythmic auditory stimulations. As well as in Parkinson's disease, I said the positive effects of this balance, freezing of gait will be there. Overall motor functions, the fear of falls and number of falls will be there. And they have been used this metronome techniques, and it has a good effect comparatively with the other common protocol what we are following with the patients with the Parkinson's disease, as well as the positives as well as randomized control studies has been done with this RAS, with this gait impairment and acute stroke, and traumatic brain injury, multiple sclerosis, SCP, dementia, Alzheimer's disease, and other. Because you know that Alzheimer's disease, because age progresses, because you have a lacunar infarctions will be there whenever reaches the persons of 60 and above. When we're supposed to take an MRI, right? So that there is no such attention, and they cannot able to focus, and the frontal atrophied people will be there, Alzheimer's, schizophrenia. So such things are there. And if you are going to have this kind of stimulation, have better results, and limited research is available effectiveness and in the children actually, so that now they are practicing and they are following, because most of the time they have been used for I said in speech language department, the hearing impairment department, they have been adapted the techniques, and but in 2008 actually they have been done the studies with spastic cerebral palsy children also, because we have a little limited evidence research is there, and we can come across with that. And then I said as a music supported theory, and this is also a rehabilitation tool for train the fine and gross motor actually. To train the fine and gross motor, this techniques especially training the sessions consisting of the electronic keyboard and exercises involve a melodic sequence when we supposed to say, when we incorporate this binaural beat with the melodic sequences and number of tones, and the movement we have to find the movement velocity and type of movement to be there. And they have concluded there is a strong body of research of effectiveness in music supported therapy to improve that functional movement in paratic upper extremities and subacute, acute and subacute stroke. However, there is no clinical studies in other population. If you want, you can continue actually, because some people are very much interested, and because of further research is also needed in this case also. So in this relation, this practice, because it's not that example of drumming or something, keyboard or lessons. See, you have to incorporate with the sequence and the melody sequences with the frequency effect of your both the ears, and then as the people to coordinate the movement. That helps the people have a fine and gross motor skills, not only for this older age people of the stroke or other children with the multiple disabilities also, we can able to focus with it, right? So this next is called, as I said, is a therapeutic instrumental music performance. This is also emerging evidence of the benefit of TIMP for upper extremity rehabilitation in stroke, and suggested a significant improvement in fine and gross motor studies. This technique is a pattern. The same thing that should be that endurance strength, the functional hand movement, and cueing the frequencies, and functioning the hand movement skills, all these things. And recent evidence has also indicates that the feasibility of TIM-based interventions of CP and the potential applications in the populations also. That should be very useful. And last is that a patterned sensory enhancement. There is a growing evidence of this beneficial of rhythmically cued this pattern sensory enhancement exercises to improve that upper extremity functions in stroke, and we have associated with the function of better regulations of muscle activation pattern in the paratic limb. So there are no studies are yet available in other clinical populations. So we are trying to adapt this techniques that will definitely have a good results. It will be there. Right? And the initial findings was demonstrated effectiveness of this in the gross motor capacity that for sit to stand movement in a CP child, and the child has been enforced. They have a good result actually, because they have not have distractions, because when we supposed to fix that in the earbuds with the or else fixed core is the overhead, and there is no such distractions. Only the way they have to communicate as well as to go further, because this enhances the child to overcome from the physical disabilities with the children. So that the underlying mechanism that is how it is works, because you have lots of confusions how it is. Rhythmic auditory interventions as a multimodal rehabilitation techniques include multiple active therapeutic elements in the context, and don't focus in one single rhythm or something like that. You have to research the rhythm pattern which is going to be execute certain things for the patient. This kind of research is going to be helpful in future upcoming people that should be have a talented job and have a good result also. And you have to fix it as a tailor-made and then specific goals and challenges. Definitely have a good results we can able to expect from this oral rehabilitation. And this is going to have a research evidence also says that this external or stimuli is based on neural entrainment, synchronize the rhythm in predictable events. And even in dopaminergic systems, this dopamine is going to release and give the reward rhythm perception productions will be there. That is also act with the midbrain striatal dopamine systems. The key role of a benefit of rhythm and oral based therapies according to the neurogenic results actually. There is a recent studies that have been mentioned over here. A pleasant music have a modulate activity in reward motivation brain network and stimulate the dopamine release in striatum system. That should be done in blood and bronze in 2001, and the same has been incorporated with other researchers also, Ferrari et al. And then Costa et al. In 2019, and have a good quality of life and engage in positive rewarding experiences associated with oral interventions. So, and also it works with the neuroplasticity. This oral training, have a significant functional anatomical changes in the brain. And for example, that learning to play short piano sequences affects the particle representation of a flexor extensor muscle. So both the things, because reciprocally you have to work together, right? The primary cortex is going to considerably good. The same way that we are going to incorporate the oral, and definitely have a good improvement, because of this active rhythm-based therapies, acquisition of motor skills and sensory motor integrations and multimodal stimulations considerably a good training, good neuroplasticity is going to be there. The future perspectives, there are studies reviewed on offer encouraging behavior data of lab, the background of futures in this locomotion, posture, balance. Still because we are giving some coordination exercises and cues and few other things, and either group therapy activities also try to go in the incorporate with this kind of an oral beat frequency kind of exercises, helps the patient and recover the patient, and there will be a good results actually. The more studies is needed in standardized protocol. That is going to be because auditory cueing, right? Because of this therapy intensity and duration of appropriate clinical stage has been present in the neurological disorders. So try to adapt these things. As I said, there are 4 component. There have been recent systematic review and meta-analysis says that all are having a separate sets of protocols in Parkinson's and stroke and all these things. I just share this content with Ms. Pooja. I think it will be beneficial to you in this session, end of the session, right? So these are the references, because that's all. Thank you for listening for more than half an hour. Sorry for the extending time. Thank you for giving opportunity to the entire team. Thank you one and all.
Thank you so much, sir, for presenting today as a keynote speaker. It is an honor to have you here in this conference, sir. And I'm always blessed to have you as a guidance in SRM. Thank you so much, sir.
Thank you so much.
Now I would like to welcome our next keynote speaker, Dr. Rajkumar Yadav. He is currently working as an associate professor in the Department of Physical Medicine and Rehabilitation at the All India Institute of Medical Sciences, Rishikesh, India. He did his MD in Physical Medicine and Rehabilitation. He did his special training on robotic rehabilitation therapy with Locomot and Acneo by Hokomo in Switzerland. He is holding many publications, including some RCTs in index peer-reviewed journals, acted as peer reviewer for renowned journals. He acted as resource faculty, presented papers on pain management, rehabilitation, and disability management in several international, national, and state conferences. I welcome you, sir, and I would request you to take over the screen.
Kindly unmute Rajkumar sir.
Okay, thank you, organizer. Good morning, all. I am Dr. Rajkumar Yadav. Please allow me to share my screen. Okay, my slides are visible.
Yes, sir. They are visible.
So, good morning, all. I'm Dr. Rajkumar Yadav, Associate Professor in PMR Department at AIMS Rishikesh. I'll be speaking on the role of robotics in the field of rehabilitation. As we all know, stroke, traumatic brain injury, that is TBI, and spinal cord injury are some common causes of death worldwide. And they also lead to various impairments, which can lead to permanent disabilities. And it is very critical that these patients should receive rehabilitation in early phase of recovery, when the brain is most neuroplastic, and the therapy should be repetitive of high intensity to achieve the sustainable long-term outcomes. Conventional therapy and training is highly demanding to skilled therapists, as it requires focus and long duration of manual training. In this aspect, robotic assisted rehabilitation devices are available in the market, which are a promising approach for improving gross motor functions in these patients. So what is rehabilitation robotics? It is a field of research dedicated to understanding and augmenting the rehabilitation through the application of robotic devices. In this, the electronic computerized control systems are applied to mechanical devices which are designed to perform human functions. Nowadays, these are generally well tolerated by patients, and so they have become an effective adjunct to therapy in individuals suffering from motor impairments. What is the pathological basis of improvement and recovery in these patients after the application of robotics? The phenomenon is neuroplasticity. The recovery of functional movements following injury to the central nervous system is multifaceted and is accompanied by processes occurring in the injured as well as non-injured hemispheres of the brain, above or below spinal cord lesion in case of spinal cord injury. These changes in the CNS are the consequences of functional and structural process, which are collectively known as neuroplasticity. They may occur spontaneously or can be induced by the movement practice. In this aspect, robotics open up a wider choice of options for delivering movement rehabilitation grounded on the principles of neuroplasticity in the human CNS. The advantages of robotic devices are they are consistent, precise, non-fatigable, easily programmable, and they have ability to measure and record in parallel with the therapy delivery. Also, we can monitor their functioning at sites remote from our center. Thus, it can enable the tele-rehabilitation. These robotic devices have been used in cases of stroke, traumatic brain injury, spinal cord injury, multiple sclerosis, cerebral palsy, patients on the follow-up after brain tumor surgery, follow-up care for elbow and shoulder endoprosthesis, muscular atrophy, and in some cases of patients having muscular weakness due to lack of mobility. There are some conditions in which we cannot use robotic devices for the purpose of motor recovery, as if the orthosis cannot be fitted to the relevant extremity, or the patient is having contractures, or they are having bone instability like non-consolidated fractures, unstable spinal column, and severe osteoporosis. The patient is having open skin lesions in the area of upper and lower limbs or on the back. The vitals are unstable, having severe pulmonary or cardiopulmonary problems. The patient is having severe shoulder joint subluxation, or having severe spasticity, cognitive deficits. Other persons having involuntary movements like ataxia, dyskinesia, myoclonic jaws, and cases of severe vascular disorders. In these cases, it is difficult to apply robotics in patients. For the purpose of usage, there are three types of robotic devices: passive, active assisted, and active constrained. The passive devices, in passive application of robots, the patients do not have power to move, and only robot is moving the full arm or leg. This can be used for preventing muscle contractures and improving range of motion, but its effectiveness in stimulating motor recovery is doubtful. Active assisted robots, they partially assist the patient's movement. In cases when patients are unable to initiate movements but have difficulty in completing the full movement, robot assists them in their functioning. Active constrained robots, they are applied to more active patients in the advanced stages of recovery. They are particularly used for strengthening the different muscle groups and improve the specific coordination patterns. The upper limb robotic devices have evolved over the years from MIT-MANUS, that is Massachusetts Institutes of Technology, BioManuTrack, Arm Trainer, MIME, Mirror Image Movement Enabler, Knee Robot, Neuro Rehabilitation Robot, Backtrack, Bilateral Arm Training with Rhythmic Auditory Cueing, In Motion Shoulder Elbow Robot, Gentle Haptic Master, Ryogo, Reharob Arm Guide, and Armio are being used nowadays in the market. The Armio is a device which are present at many centers for the purpose of upper limb rehabilitation. It is of three types: Armio Spring, Armio Power, and Armio Boom. Armio Power is a fully robotic device which can be used for a person having nil power. Armio Boom is a device which are to be used for on the OPD basis for those patients which have in the late phases of recovery, which have sufficient power for managing their functions. At our center, we have Armio Spring. It has components like arm exoskeleton with integrated springs. It embarrasses the whole arm from shoulder to the hand. The exoskeleton counterbalances the weakened part of the patient's arm, thus assisting active movements across a large 3D workspace, and thus enhances any residual function and neuromuscular control. Around the hand, there is pressure-sensitive hand grip, which is not only an input device for exercises, but also provide a computer interface for the software and the computer games. Lastly, there is augmented performance feedback for Armio Spring, which contains an extensive library of game-like movement exercises supported by a virtual reality training environment. Most of the exercises are like grasp and release exercises for facilitating the self-initiated movements. Ultimately, there will increase in active ROM, strength and endurance will increase, selective control and coordination will increase. There are different assessment tools which can objectively quantify the improvement at the robotic device. There are many, similarly, there are many lower limb robotic devices which are available in the world. Locomat is a common one. Others are Gait Trainer, PAM Pogo, MITS Ankle Bot, Auto Ambulator, Tibion Bionic Leg, Barkley Bionic Legs, E-Legs, that is exoskeleton lower extremity gait system, Myomo Neuro Robotic System, and Rewalk. At our centers, we have Locomat for the lower limb gait management, lower limb training. It combines the motorized body weight supported treadmill with a robotic gait orthosis and an augmented biofeedback system. In this, the patients on a wheelchair are escorted easily over a ramp into the treadmill and fitted into the Locomat. Now, next, the patient is suspended with a harness. The suspension is a dynamic low inertia system, which allows a precise unloading of the patient and promotes a more physiological gait for optimized sensory stimulation. My slides are not moving. As the Locomat provides biofeedback and current gait activity of the patient, and as we all know, motivation is crucial for good therapy outcome, and feedback is important for motor learning. The Locomat also has the augmented biofeedback. Furthermore, the patients obtain natural sensory information through the feet while stepping on the treadmill, which is an important contributor to motor relearning. We can provide higher training intensities at the Locomat that can be induced with these devices and lead to faster therapy progress. There are different measurement tools in the Locomat like L-Walk, L-Stiff, L-Force, L-ROM. L-Walk records the patient's gait performance or every step. L-Stiff measures the stiffness of the patient's hip and knee joints. L-Force measures the isometric force generated by the patient, while L-ROM accurately measures the patient's and hip and knee passive range of motion without support of Locomat drives. Now, there are certain advantages of the Locomat-based therapy, like the robotic gait orthosis guides the patient's legs on a treadmill, offering a wide range of training possibilities. On these devices, we can progress faster through longer and more intensive functional training session compared to the conventional training at the manual treadmill. There are less physical strain on the therapist, and a single therapist can monitor the whole session. Patient walking activity is easily supervised and assessed. Gait pattern and guidance force are individually adjustable to the patient's needs to optimize the functional training. And there are improved patient motivation through visualized performance feedback. Different assessment tools are present which allow easy and reproducible measurements of the patient progress. And if needed in the advanced stage, we can move easily from automated to the manual mode of therapy. Locomat and other devices which were present in the past are basically therapy tools at the hospitals. But now there are devices available which we can use, which the patients can use for their personal purposes, like E-Legs and Rewalk. These are externally powered exoskeleton system and have computer interface which uses force and motion sensors to monitor the user's gestures and motion, and then they translate it into appropriate action. So they are very beneficial to the patient. They allow paraplegics to put on and take off the devices by themselves, as well as walk, turn, sit down, and stand up unaided. Now, the robotic techniques have also been used in the field of prosthetics. Like there are robotic arms available. The first one is the Luke arm. It was inspired by the arm the Luke Skywalker has in Star Wars. It has 18 degrees of motion and gives feedback to the user for grip pressure control, so that a precise pressure is put on the object which the person wants to hold. There are different bionic hands available in the field, which have separate motors in each fingers. That means that each finger can work independently and can articulate for different purposes. Like the human thumb, the electronic thumb in these devices can also rotate to 90 degrees. Then there is mind control robotic arm, in which the pulses of electricity generated in the brain cells are picked up by the implants in the motor cortex and then translated into commands to move the prosthetic arm. The arm can bend at elbow, wrist, and could grab an object. But for now, due to the bulkiness of setup and these devices are in the only till now in the research field, not in the commercial available market. And what are the recommendations for these devices in different studies? There was one systematic review in 2020 by Mehrol, J, Pola K, and Paul and M et al. For the use of robotic assisted arm training in improving activities of daily living and upper limb function after a stroke. The author concluded that the outcomes of robotic assisted arm training were comparable with conventional therapy, and also the indirect comparison suggests that no one type of robotic device is any better or worse than any other device. In Cochrane review for the upper limb by Merrill, Paul, Platts, Kugler, Elsner in 2018, they concluded that electromechanical and robot-assisted arm training improved ADL in people after stroke and function and muscle strength of the affected arm. And the adverse events like injuries and pain were seldom described. So they recommend that these devices can be applied as a rehabilitation tool, but we need to develop protocols for when or how often they should be used. The timings are still to be developed. For lower limb, there was a Cochrane review in 2020 by Merrill J, Thomas S, Kugler J, Paul M, Elsner B, in stroke patients. They concluded that people who receive electromechanical assisted gait training in combination with physiotherapy after stroke are more likely to achieve independent walking than people who receive gait training without D devices. Especially patients in the early stage, that is in the first 3 months after stroke, and those who are not able to walk seem to benefit most from these type of intervention. But the role of the type of device is still not clear, and they recommend further research for the most effective frequency and duration of electromechanical assisted gait training, as well as how long any benefit may last. So on concluding, what are the usability in the present scenario for these devices? We can use these devices for optimizing the human resources. That is, if the centers have higher patient load and we have less number of therapies, there are space constraint, then we can definitely use these devices, robotic devices, for the recovery and rehabilitation of patients. There are certain advantages of these devices over conventional therapy, like they can be used in the very early stage of the disease. They provide motivation through augmented biofeedback. We can also have objective assessment, which we can use in our research tools. And they also provide automatic reporting and documentation, thus minimizing our required labor. So, this was my presentation. Thank you. I'm very thankful to the organizers for giving this opportunity. Okay, Dr. Vishal, thank you.
Thank you so much, sir. Now I would like to ask the audience if they have any questions for you. Thank you, sir. Thank you so much for such a wonderful lecture. Now I would like to request. Now I would like to request all the participants to turn on their camera for a group photo. Am I audible?
Yes, Dr. Vishal, you are.
Thank you. I would like to request all the participants to turn on their camera for a group photo.
The participants are not able to start their video, sir. It is restricted by the host.
I would request all the remaining participants to turn on their camera for the group photo. Okay, thank you everyone. Now I would request you all to join your particular breakout room as the room 1 or the main hall. This should be the for the musculoskeletal and sports conditions group. The breakout room 2 is for the cardiopulmonary disease students. Breakout room 3 is cerebrospinal disorder. Breakout room 4 is integrated category, and breakout room 5 is community wellness students. So I would like you all to join your room so that we can proceed with the presentation part. This is the main room. The musculoskeletal and sports students should remain in this room. Others can proceed to their particular room.
Hello, good morning.
Yes, sir.
Yeah, do we have a separate link for the this paper presentation?
Yes, sir. We have different breakout rooms for that. You have to join your in which category you are presenting. You have to join.
I'm going to present in cardiopulmonary.
So you have to join breakout room 1. So it's written over there. You can click on the breakout room option. Over there, you can
from the agenda that I have received, from that only the link has been provided?
No, sir. It's in the same room. You'll see an option on your screen. An option named Breakout Rooms. If you are able to see.
I got it. Yeah. Okay, thank you.
On that. Hello, everyone. So now the room in which we are is for the musculoskeletal and sports condition. So now I request Gauri Malode for her oral presentation on comparative effect of Pilates and Burgess exercise in conjunction with low-level laser therapy for individual with forward head posture associated with temporomandibular joint dysfunction, a 2-arm parallel study from Kahir Institute of Physiotherapy, India. Gauri Malode.
Yes, sir.
Yeah, Gauri, you can start with your presentation.
Yes, sir.
Let me just remind you, you have a 10-minute timer. You have
10-minute timer. Okay, sure, sir.
Whenever you are ready, I'll just start with the time.
Is my screen visible?
Yeah, it's visible.
Okay, just a second. Yes, I'm ready.
Yeah, you can start, Gauri.
Yes. Good afternoon, one and all. Topic for my today's paper presentation is comparative effect of Pilates and Bruger's exercise in conjunction with low-level laser therapy for individuals with forward head posture associated temporomandibular joint dysfunction, a 2-arm parallel study. So coming to the temporomandibular joint, it is one of the most complex and used joint in the human body with important functions like chewing and speaking. So evidences suggest that there is a relationship between craniomandibular region and forward head posture. So what happens is when there is forward head posture, there is posterior cranial rotation, which leads to such position of mandible that mandible is pulled back and down. So this leads to disturbance in alignment of the condylar head and articular disc. So when this posture is maintained for a longer period of time, the muscle imbalance comes into picture. There is tightness of the cervical extensors and weakness of the deep neck flexors. So this further leads to malalignment of the temporomandibular joint, which is responsible for our symptoms like pain, limited mouth opening, and click noise in the temporomandibular joint dysfunction. So the treatment available usually helps in decreasing musculoskeletal load, reduces pain by decreasing inflammation, but there is very less literature available on treatment of temporomandibular joint dysfunction by using correction of forward head posture. So Pilates and Bruger's exercises are important and for treatment, are appropriate for treatment methods for correcting and preventing forward head posture. Therefore, the purpose of this study was to determine and compare the effect of Pilates and Bruger's exercises with low-level laser therapy with patients with temporomandibular joint dysfunction. So it was a single-blinded 2-arm parallel study was conducted over the period of 12 months The study was approved by Ethical Institutional Committee and was registered in CTRI. 30 participants were selected using non-probability sampling and were divided into 2 groups using envelope method. All the COVID-19 precautions based on ICMR guidelines were followed. In inclusion criteria, there were patients with both genders who were between the age of 20 to 40 with a craniovertebral angle more than 45 degrees and who reported myofascial pain with RCD TMD axis 1. And those who were excluded had neck injuries, who were under different type of treatment for temporomandibular joint dysfunction, and who had neurological or psychiatric type of temporomandibular joint dysfunction, which is assessed by axis 2 of RCD TMD. Outcome measures were visual analog scale, which was used for pain assessment. Craniovertebral angle was measured using on protractor application, and the range of motion of temporomandibular joint was measured using standard ruler. Mandibular function impairment questionnaire was used for assessment of functional impairment. In intervention for Group A received Pilates plus low-level laser therapy, and Group B received Bruger's exercises plus low-level laser therapy for 3 times a week for 3 weeks of period. 5 sessions of low-level laser therapy was given. This is how the low-level laser therapy application was done for the tender points. This is the Bruger's exercises, which was given using therabands. These are the Pilates exercises. This is a beginners, which was progress over the period of 3 weeks into intermediate and the advanced level. So coming to the results, the table 1 and table 2 shows distribution of group, gender, demographic characteristics of participants. The participants were homogeneously distributed for both the groups. So when the statistical analysis of inter and intra-group statistical analysis was done, both groups show statistically significant improvement in VAS, craniovertebral angle, range of motion, and the functional impairment. When the means of both Group A is Pilates, Group B is Bruger's exercises. So when the means were compared, the Group A showed improvement superior to that Group B in terms of craniovertebral angle, ranges, and the functional impairment. So coming to the discussion, our current study showed improvement in forward head posture, range of motion, functional impairment in both the groups. So the results of current study are in accordance with the previous literature given by these authors, where low-level laser therapy showed improvement in pain and function via the mechanism of biostimulation, where it acts at the cellular level and causes increase in serotonin and endorphin levels and decrease in intraleukins and bradykinin levels, which results in decrease in pain and decrease in inflammation. The improvement in Bruger's and Pilates exercises is supported by these articles which are given by these authors, and this improvement is caused because both acts on the same mechanism, that is stretching of pectorals and tight extensors of neck and strengthening of scapular retractors and deep cervical flexors. The additional effect of Pilates could be because the Pilates acts on activation and strengthening of core along with all the stretching and strengthening of the scapular and pectoral muscles. It acts on core, which causes improvement in spinal alignment and overall improvement in posture. Conclusion, the study concluded that Pilates and Bruger's exercises in conjunction with laser is effective for TMJ dysfunction, whereas Pilates with low-level laser therapy is superior in terms of improving posture, range of motion, and mandibular function. Limitation, it was single-blinded, there was no control group, and the factors could not be controlled. And this is my future scope of study, where we can add control groups for generalization of study findings, along with the long-term follow-ups can be done, and added assessment of carrier effects can be done to consolidate the result. Efficacy of variant postural correction in improving temporomandibular dysfunction can also be carried out. There was no source of funding for the study, and these are my references. Thank you so much.
Thank you, Gauri. Now, I would like to ask the session chair if they have any questions regarding the concerned study. questions, sir, ma'am? Thank you, Gauri.
Thank you so much, sir.
Now, I would like to invite the next author, that is Sharon, for her oral presentation on ego skew versus lumbar stabilization exercise in individuals with lower cross syndrome on pain, posture, stability, and hyperlordosis, a randomized controlled trial from Kahir Institute of Physiotherapy. Sharon?
Good afternoon, sir. Am I audible?
Yeah.
Is the screen visible?
Yeah, it's visible.
Okay. Good afternoon, everyone. The title of my study is ego skew versus lumbar stabilization exercises in individuals with lower cross syndrome on pain, postural stability, and hyperlordosis, a randomized control trial. Okay, so lower cross syndrome is characterized by the imbalance of tight and short hip flexors, lumbar extensors, and inhibited and weakened gluteus maximus and abdominal muscles, which leads to specific postural changes in the body that include increased lumbar lordosis, lateral lumbar shift, anterior pelvic tilt, and slightly flexed position of the hips, leading to postural instability. So ego skew exercises, it is a method developed by Pete Egoscue, which is theorized to bring out your posture back into balance. So ego skew method uses corrective exercises designed to improve whole body postural alignment and reduce musculoskeletal pain by increasing joint mobility and stability. And lumbar stabilization exercises provide internal stabilization, which can be achieved by abdominal muscles being contracted isometrically along with the lumbar muscles in order to provide stability at the spine. So there is a paucity of control trials where these new forms of ego skew exercises has been compared with the conventional lumbar stabilization exercises. So methodology, it was a single blinded parallel group randomized clinical trial of 30 subjects, which was conducted with convenient sampling method. The intervention of the two groups were ego skew exercises and lumbar stabilization exercises. The duration of the study was 12 months. The study was approved by the Institutional Ethical Committee and was registered in CTRI. 30 patients diagnosed with low cross syndrome having lower back pain were selected using probability sampling, which were divided into two groups using SCHIT method. All COVID-19 precautions were followed. Inclusion criteria for the study was subjects diagnosed with low back pain, having low cross syndrome, both male and female of age 18 to 60 years, pain without radiculopathy, and subjects willing to participate in the study. The exclusion criteria involved any neurological symptoms involving PIVD, radiculopathy, history of recent abdominal spinal injuries, trauma and fracture, practice any kind of exercises for sports activity during last 6 months, subjects who are unable to comprehend the exercise protocol, or pregnant women. So the outcome measures used in this study was functional disability, which was the modified oscillatory disability questionnaire, and the degree of lumbar lordosis was checked using index of lumbar lordosis by a flexi curve. And postural stability for risk of fall, stability index, AP and lateral sway was assessed by using a Tetrax machine, Tetrax software. So the dosage of this exercises were both A and group, which received 1 to 3 sessions, were 5 repetitions with hold time of 30 seconds, and the 4 to 6 sessions with the 10 repetitions with hold time of 30 seconds, and 7 to 10 sessions with 15 repetitions with hold time of 30 seconds. Each exercise sessions will be were performed with the aim of alternate days for 10 sessions. And there was a warm-up as well, warm-up exercises, which consisted of whole body general mobility exercises for 10 minutes and cool-down exercises for 5 minutes after each session. So these were the some of the exercises. Coming to results, the demographic data in terms of age, height, weight, and BMI and gender distribution, they were normally distributed for group A and B. Within group pre and post test using t-test for group A and B. So in terms of all the outcome measures were all significant, they had significant difference except for group A in AP and lateral sway. And between group and independent sample test for between group analysis showed no significant difference, which says that both the groups had equal effects in they had similar effects in all the outcome measures. Discussion. The current study showed significant improvement in lumbar lordosis angle, pain, postural stability in terms of risk of fall, AP sway, lateral sway, and overall patient satisfaction towards the treatment. So the result of this present study are in consensus with the past researches done by Gayatri Kudichatkur, Zachary Burst et al., where ergoski exercises as well as lumbar stabilization exercises showed significant improvement in hyperlordosis and low back pain. And also the improvement in postural stability is supported by the RCTs done by SM Dusin Chelly et al., Kang et al., where stability index and risk of fall was improved. So the conclusion was, thus the present study concluded that in ergoski exercises and lumbar stabilization exercises are equally effective in correcting lumbar lordosis angle, improving low back pain and postural stability in individuals with the lower cross syndrome. Limitations of the study had a smaller sample size and no follow-up assessment. Future scope, as there is paucity of literature in ergoski exercises, so further studies can be done, conducted on different patient population. Acknowledgement, I would like to thank my participants for their time and effort. Source of funding, nil. These are the references. Thank you.
Thank you, Sharon. Before we go with the question and answers, I apologize and I would like to introduce the senior chairperson, Dr. Shamit Kumar Katila sir. He is General Secretary of PRAN and Executive Director at Orthoplast Rehab India. Welcome you, sir. So we would like to ask if you have any questions regarding the current study. You have muted yourself.
Okay, sorry, the mic was muted. So my question is, as I could see the doses of the exercise that she has given to a patient, so I would like to ask, what are the references of doses of the exercise prescription that they did?
I've taken this exercise protocol from a parent article which have been used, where they have used the same protocol for hyperlordosis in low back pain. So these were the exercises. So I've used it in patients diagnosed with lower cross syndrome.
So those are already researched before?
Yes, sir, yes. Hello?
Sir?
So now is it time for the third participant?
Yes, sir. I was just asking you, are you satisfied with the answer? Or should I proceed with the next participant? Next, I would like to invite Namrata Gadekar for her oral presentation on comparative effect of Pilates and ego cues exercise on pain function, proprioception, and peak muscle torque in subjects with knee osteoarthritis, a randomized parallel study. from Kahir Institute of Physiotherapy, India. Namrata Gadekar. Hello, am I audible to everyone?
Yes, sir, you are audible.
Yeah. Namrata? Namrata, can you hear me? Hello, Namrata, can you hear me? Hello, Namrata, we are not able to hear you. Are you able to hear us, Namrata? Namrata? Namrata, are you able to hear me?
Yes, sir.
Yeah, you can start with your presentation.
Okay, sir. Thank you, sir. Good afternoon. Title of my study is title of my study is Comparative Effect of Pilates and Egoscue exercise on pain, function, proprioception and peak muscle torque in subjects with knee osteoarthritis, a randomized parallel group study. Osteoarthritis being a common progressive joint disease characterized by pain, impaired function, and reduced quality of life, the EGOSQ uses corrective exercises designed to improve body posture alignment and reduces musculoskeletal pain by improving joint mobility and stability. A study found that EGOSQ exercises significantly reduced knee pain and improves the function and improves the functions. Pilates exercises focuses on core stabilization and strengthening. A study found that which shown a patient with knee OA had improved knee function, strength, flexibility, balance, proprioception. The literature suggested that the patient with knee OA had reduced muscle strength, functional capacity, and peak torque of quadriceps and hamstring in knee OA when assessed with isokinetic testing device. There are no studies done to see the comparative effects of EGOSQ exercises and Pilates in knee OA. Hence, the present study intends to compare the effect of Pilates and EGOSQ exercises on pain, function, proprioception, and peak muscle torque in knee osteoarthritis. Methodology: a randomized parallel group study for 30 subjects was conducted with convenient sampling method. A random allocation of the subjects was done using envelope method, and the subjects were divided into 2 groups, 15 in each group, and the treatment was given and analysis was done. Inclusion criteria involved individuals of both genders of age group 40 to 65 years who are diagnosed with OA knee of grade 2 and 3 according to Kellgren and Laurin classification of knee osteoarthritis. Exclusion criteria was clinically diagnosed participants having any systemic joint pathology, inflammatory joint disease, etc. Any history of surgery related to lower limb. The participants on medications like corticosteroids, antidepressant, anti-inflammatory medications during the study. The outcome measures used here were to assess pain, visual analog scale was used. To assess function, Womack scale was used. To assess peak muscle torque ratio, extension to flexion, maximum power extension to flexion, endurance index percentage extension to flexion, flexion to extension ratio percentage using an isokinetic device was done. Then to assess knee joint proprioception, joint position sense test was used. So in procedure, there were 2 groups. Group A involved Pilates and conventional physiotherapy. The conventional physiotherapy involved ultrasound, IFT, and stretching exercises. And in Pilates, all these Pilates exercises were given for 3 weeks. The dosage was 5 sessions per week for 3 weeks. And for group B, EGOSQ exercises plus conventional physiotherapy was given. These were the EGOSQ exercises with a dosage of 5 sessions per week for 3 weeks. So these are the Pilates exercises. This is the 100 and this is shoulder bridge. This is EGOSQ exercises, that is pillow press, and this is back press. Next, coming to results. Table 1 shows demographic data, that is general characteristics of participants. In this, no significant differences were found in all the participant characteristics of age, height, weight, and BMI because the p-value was more than 0.05. The table 2 shows within group pre and post using t-test for Pilates. Here, significant reduction in the VAS score of Womack score, proprioception at 30 degrees, and improvement in maximum power, endurance index, and flexion to extension ratio was confirmed from pre and post treatment values. Table 3 shows within group pre and post test using t-test for EGOSQ group. Here, a significant reduction in the VAS score, Womack score, proprioception at 30 degrees, 45 degrees, 60 degrees, and improvement in peak torque ratio was there. Maximum power, endurance index, and flexion to extension ratio. So almost all the outcome measures were significantly reduced. Then Table 4 shows between group pre and post scores using independent sample t-test. Here, Womack score, peak torque, flexion, endurance index, flexion percentage showed significant scores as compared with the other outcome measures. Discussion. The present study was done to compare the effect of Pilates exercises and EGOSQ exercises in patient with knee osteoarthritis. It can be interpreted from the results that the EGOSQ along with the conventional physiotherapy were shown to be more effective than Pilates group in terms of all the outcome measures. A previous study was done by Madhura Zadav, which concluded that Pilates exercises were effective in patients with OA knee, with reduction in pain and improvement in functional activities. Also, a study done by Zachary Weiss showed that ergonomic corrective exercises significantly reduce knee pain and improved function, as both the exercises are effective in treating knee osteoarthritis. But when compared, ergonomic exercises showed significant results in terms of pain reduction, improvement of function, proprioception, and peak muscle torque. Conclusion: the study concludes that ergonomic corrective exercises is more effective than Pilates exercise in reducing pain, improve function, proprioception, and peak muscle torque in the treatment of patients with knee osteoarthritis. Limitation and future scope of the study: no follow-up assessment was done in order to understand the carryover effect of the Pilates and ergonomic exercise on knee osteoarthritis. So long-term follow-up studies are warranted to address this question. Then future scope was future studies are needed with larger patient sample size and longer intervention periods in order to validate our results. Acknowledgement: we would like to thank all our participants for their time and efforts. Source of funding: nil. And here are the references. Thank you.
Thank you, Namrata. Now I would like to ask Shamat sir if sir has any questions.
Am I audible?
Yes, sir, you're audible.
So, what was your outcome measure for the pain? Was it VAS?
Yes, sir. It was visual analog scale.
Okay, so you said that you also use the conventional therapies for the osteoarthritis knee, and as your inclusion criteria says that there are all cases of osteoarthritis knee apart from those who have done surgeries of the lower leg. So how do you quantified your VAS scale as significant improvement, as you said that the exercise has been given only for 5 weeks, right?
Sir, it was 3 weeks.
3 weeks. So the total intervention of Pilates plus conventional exercise or the EGOS exercise is for 3 weeks?
So Pilates plus conventional and ergonomic plus conventional, both are for 3 weeks, sir. And it is done and it is randomized for 30 patients, 15 in each group.
Okay. So what was the the result between comparing of both the group, because you have used conventional exercise in both the group, right?
Yes, sir.
So what was the you said there is significant reduce in the pain. So in VAS scale, what was the average kind of reduce in the scale, if you have to quantify that?
Yes, sir.
I mean to say that how much do you quantify as significant reduce in pain scale with the outcome measures of VAS?
So with outcome measures, there was when I quantified, it was around 4 to 5, like in 0 to 10 scale. It was average was 4 to 5 points reduction in the pain, sir.
Okay, thank you. Did you also use isometric exercise in both the groups?
No, sir. Stretching exercises was used as this conventional physiotherapy. Stretching, ultrasound, and IFT. It was conventional.
Thank you.
Yes. Thank you, sir.
Thank you, Namrata.
Yes. Thank you.
Invite the next participant, that is Madhura Joshi, for her oral presentation on effectiveness of task specific exercise training versus graded motor imaginary in subjects with knee osteoarthritis, a randomized clinical trial from Kaya Institute of Physiotherapy, India.
Good afternoon, sir.
Good afternoon, Madhura.
So the title of my study is Effectiveness of Task-Specific Exercise Training versus Graded Motor Imagery in Subjects with Knee Osteoarthritis, a randomized clinical trial. So knee osteoarthritis is the most common degenerative disorder which is seen as the age progresses. So it is characterized by pain, muscle weakness, difficulty in movement, and restricted range of motion. And the most problematic tasks faced by the patients are sit to stand transfer, ascending and descending stairs, and the floor transfers. So the traditional impairment-based exercise training will help in improving these parameters, but the task-specific exercise training will help even more to improve the activity limitation and participation restriction, and thus it will correlate with the functional improvement. So my first group has received task-specific exercise training, and the other intervention given was graded motor imagery. So graded motor imagery is the cognitive process of imagining the movement of the body without actually moving the body. It has been proven for improving the pain and the movement problems. So, however, both the techniques have been proven to be effective individually in patients with knee OA when they were used along with the conventional physiotherapy. So, this study intends to compare the effect of task-specific exercise training and graded motor imagery in patients with knee osteoarthritis. So the methodology used was a clinical trial of 32 subjects was conducted with convenient sampling method. Random allocation of the subjects was done into two groups, 16 in each. The intervention for two groups was task-specific exercise training and graded motor imagery. Both male-female having age group 40 to 65 years with grade 2 on Kellgren and Lawrence scale with the radiological evidence was included, having unilateral involvement and the patients marking pain severity on the score of 3 to 7 on NPRS, marking moderate difficulty on COOS were included. So the outcome measures used were isokinetic testing systems, knee injury and osteoarthritis outcome score, universal goniometer, numerical pain rating scale, and the 3 performance-based tasks, 30-second chair rise test, time stair climb test, and the floor transfer test. All the COVID-19 precautions were done. The study was approved by ethical committee, and then the pre-assessment was done. The individual group was given their intervention along with the conventional physiotherapy treatment. 9 sessions were given for each session was lasting for 45 minutes. The post-assessment was done followed by. So the picture one is the 30-second chair rise test, which is a performance-based task, which will where the task was breakdown into the components and thus giving the task-specific exercise training. Picture two shows the mirror therapy, which is one of the component of graded motor imagery amongst the three. The picture three is isokinetic testing system, which was my outcome measure for peak muscle torque, and the hamstring quadricep ratio. And picture 4 shows the isometric exercises, which was included in my conventional treatment. So the result of the study shows the graph 1 and table 1 shows the demographic data, where the data was homogeneously distributed. The comparative analysis was done for both the groups, group 1 and 2, of the pre and post scores using the paired sample t-test. So within group analysis shows the significant improvement in the all the outcome parameters. Between group analysis of both the groups were done, and the results showed the results came not significant. That means both the groups were found to be equally effective. Both the groups were found to be equally effective in improving all the parameters. So the discussion, the positive results of the present study are in accordance to many prior studies. The effect of TACT has been found on the chronic knee pain and the knee osteoarthritis. A case series was done for chronic knee pain, and a clinical trial was done for the knee osteoarthritis and were found to be more effective than the impairment-based training program. So focusing on training a specific task rather than treating the impairment in isolation. So this approach maximizes the relevance of the prescribed exercises and helps the patient in modifying their activities of daily living. Whereas the graded motor imagery has already been proven to be effective for improving the kinesophobia, pain and disabilities. The studies were done on causalgia, knee osteoarthritis, also the phantom limb pain. So it has already been proven to be effective for improving the quality of life. So it can be interpreted from the results that both the TACT and GMI were beneficial to treat the osteoarthritis in terms of all the outcome parameters when it was applied with the conventional physiotherapy treatment. So conclusion is, the study concludes that both TACT and GMI are effective in treating knee osteoarthritis with respect to reduction in pain, improving the quality of life and functional abilities, range of motion, peak torque and ratio of the hamstring and quadriceps, and dealing with the problematic tasks. There were few limitations noted. So the no follow-up assessment was taken in order to understand the carryover effect of both. Duration of the symptoms was not noted. Also, the large sample size could have been taken, and longer intervention period is needed. So, future scope is all the long-term follow-up studies, whichever will be done, will be warranted here to address these questions. Also, the TACT needs to be explored in other musculoskeletal conditions in order to improve the strength of the literature. Acknowledgement. I would like to thank all my participants for their cooperation, and the current study was not funded. These are the references. Thank you.
Thank you, Madhura. Now I would request Shamat sir if he has any questions.
Can you briefly tell about what are the task-specific exercises that you give to your patient?
Sir, in knee osteoarthritis, the patient will complain most commonly about the most common problems are sit to stand transfer. So if we want to teach the patient about the sit to stand, so firstly we will use a high level like sitting arrangement, so that or the any of the stool and all, so that patient will gain the confidence. Later then we will use the chair, and then the short height. So again, regarding the ascending and descending stairs, we will teach the patient about the ergonomic advice, like the strengthening will be done for the ascending and descending. So how to ascend and how to descend. Regarding the floor transfer, the component was broken. So in that also, the patient once the patient has gained the confidence regarding the sit to stand, the patient will be able to perform the floor transfers also. Also, the ergonomic exercises were given.
So this group didn't receive any other exercise, right? Apart from task-specific training?
Task-specific and conventional exercise program, sir. In that, the stretching and stretching and strengthening program was given, VMO strengthening and other. Also, IFT to reduce the pain, and ultrasound was given, and hot mush pack, hydrocollateral pack.
So this also, this task-specific training also had some weight-bearing exercises. Sit to stand mean like you just kept them in high sitting position, or you asked them to walk?
Sir, firstly, I have made them. I have kept them in high sitting position, so that like how we perform the dynamic quads and all. So like that, first I have taught them about the high sitting position and progressing to the little lower height.
So you graded the weight bearing, right?
Yeah. Yes, sir. Because
sir,
few patients I have noted that considering the toilet facilities and all, so considering the Indian toilet facility, they might have to squat down, so they need weight bearing. So considering that approach, I have taught them the sit to stand transfer and the task specific exercise training. So this is necessary.
Thank you very much.
Thank you, Madhura. Now I would ask the next participant, that is Malaika Mahapatra, for her oral presentation on prevalence and awareness of musculoskeletal disorders in biopharma sales and marketing individuals from DY Patil University, India. Malaika Mahapatra. Hello, am I audible? Malaika Mahapatra from DY Patil University, India. Malaika Mahapatra.
Hello, sir. Am I audible?
Yeah.
Sorry, I was not able to unmute myself.
Yes, okay, fine. You can start with your presentation.
Yes, sir. Can I just allow me to share my screen? Just a second. Can you see my screen, sir?
Yeah.
All right. Good afternoon to one and all. Today I will be presenting a research conducted by us on the topic of prevalence and awareness of musculoskeletal disorders among biopharma sales and marketing representatives. It is known that musculoskeletal disorders are the leading cause of work-related ill health. They are injuries of muscles, tendons, joints, cartilages, nerves, and other structures which develop due to the repetitive pathological wear and tear of these structures. Work-related musculoskeletal disorders are conditions which develop due to improper work conditions and/or poor ergonomical knowledge and can cause and produce or exacerbate MSD and its symptoms. This is important to know because work conditions of biopharma sales and marketing representatives are harsh, often involving working remotely, prolonged driving, walking, inadequate breaks, sitting for long durations, working from car and cab, and manual handling. This complicates the availability of healthcare services to this working community and limits their access to occupational health services. Purpose of the study is that there is limited knowledge about the prevalence of MSD in biopharma sales and marketing representatives, and we are unaware regarding their knowledge and awareness about the same. Also, this working community comes under a great amount of stress because they bear the weight of the company on their shoulders. A cross-section study was conducted to understand the prevalence of MSD and its awareness among biopharma sales and marketing representatives. The above stated parameters were compared and correlated with other variables such as BMI, lifestyle, and postural differences. 100 study samples were chosen between the age group of 30 to 50 with at least 2 years of experience in biopharma industry and excluding the ones having comorbidities. A self-made questionnaire which was validated was used and collected demographic data along with information about lifestyle comorbidities and awareness about various aspects of work. A standard model questionnaire was also used. This is a screening tool which allows us to collect data regarding general complaints of individuals with respect to physical concerns, both chronic and acute problems, and affection of ADLs also. This questionnaire is useful for defining annual and weekly prevalence of an individual's problems. Evidence suggests that it is a reliable, sensitive, and useful screening and surveillance tool. The data collected was analyzed according to aims and objectives which were presented earlier. Now coming to data analysis results and discussion. Here we understand that the majority of the population belongs to the age group of 30 to 35 and the BMI is between 22 to 28. The age group helps us to understand that this population is relatively younger and will not be affected with comorbidities that they may have developed due to their working lifestyle. Also, the BMI suggests that they are belonging to the category of healthy and overweight both. So we can understand that even though there is a large amount of physical activity involved, they are still belonging to the overweight category. This is due to the constant need to travel, and this will lead to unhealthy food habits. From the task analysis table, we can understand that the work hours per day are more, work days per week are also more. So this tells us that they are required to travel for long durations of time. And this population prefers to travel by public transport. Now, public transport is not ergonomically designed for each and every one, like considering their individual needs. Hence, this will give rise to a greater chance of MSDs. The number of days spent at the office are also more, so they are at a risk of developing MSD due to poor ergonomical knowledge. Now coming to the prevalence analysis, here we can see that the total prevalence of any sort of musculoskeletal disorders is 87%, which is high. I'm defining high by saying that it is more than 50%. Prevalence of chronic problems includes 27% of low back pain. Chronic problems that impede on ADLs includes 19% of low back pain. Chronic problems are defined by problems that last for 12 months or more. Chronic problems requiring medical attention includes 19% of low back pain. Acute problems include 26%. Now, acute problems are defined by problems that last for 7 days or less. They include low back pain, that is 26%, and 25% of upper back pain. Acute problems impeding on ADLs include 21% of low back pain and 20% of upper back pain. Awareness analysis. Here we can understand that Again, high and low is defined by 50%. So if it is above 50%, it is good. Below 50%, it is poor. So effects of prolonged driving, ill effects of walking from car or cab, ill effects of carrying heavy loads, and ill effects of prolonged standing are relatively well known to this population. Sorry, ill effects of walking from car or cab are not well known. Whereas faulty posture, effects of work environment on posture, and ill effects of working from car or cab are relatively not well known to this population. Whereas effects of prolonged driving, ill effects of carrying heavy loads, ill effects of prolonged standing are well known to this population. This is because this population has developed MSDs due to these work conditions. Maximum number of participants is trouble in their shoulders, lower back and knees. This is due to the work conditions of these individuals. They are required to stand for longer periods of time, to sit in front of a desk for longer periods of time, and also long duration of travel. They are required to see a physician in the last 12 months due to troubles in their hips, thighs, and knees. This is also because of the work conditions, and also the severity of problem keeps increasing as MSD develops due to repetitive movement, and it adds up as the pathomechanical movement keeps on increasing. Participants face trouble in upper back and lower back during the last 7 days. This is also due to the work condition. They have been prevented from carrying out normal activities of daily living during the last 7 days due to trouble in upper back and lower back. Now coming to analysis between the parameters, individuals with a lower BMI, that is 18 and below, face maximum problems in their neck, shoulders, and knees, while individuals with a higher BMI face maximum problems in their knees, ankle, and feet. Individuals who do not exercise regularly complain of lower back, neck, and feet pain, while individuals who exercise regularly complain of shoulder and knee pain. Postural differences, the individuals who are standing for a longer duration of time usually complain of lower back and heel pain. Individuals who are sitting for a long duration usually complain of upper back, neck, and buttock pain. Individuals who are walking for a long duration usually complain of calf and heel pain. Maximum participants are unaware regarding faulty posture during work, and their work environment can have an effect on posture, and that working from car or cab can cause MSDs. Now, working from car and cab is not well known as these individuals are forced to perform this activity due to their work requirements. They are relatively aware due to the following given parameters because they are subjected to MSD due to these. Limitations of the study was that a wide range of population was not present, details of job stress was not taken into account, a few questions were biased, and no quantification of prevalence and awareness was given. To scope of the study, I feel that this study can be expanded to analyze regional trends occurring with respect to the variables. Here are the references. Thank you so much for your time.
Thank you, Malaika.
Thank you, sir.
Shamath sir, any questions, sir?
Just a quick question. Why do you think there was problem in the knee in those population who were under BMI of 18?
So this is because of prolonged walking. This population, although not all of this population performs walking, those who perform walking for a longer duration of time will be subjected to knee pain. So it is not just that BMI affects this. There are many factors involved. It is multifactorial.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, Malaika. Now I would
sir.
like to call the next participant, that is Avinash Kumar Boya, for his oral presentation on designing and testing basic protocol for medium fast bowlers to increase the speed and accuracy from RK University, India. Avinash.
Hello.
Yeah, Avinash. Yeah, you can
Yes,
hear
sir.
me.
My voice is audible?
Yeah.
Okay, I'm sharing my screen, sir.
Yeah.
So I hope PPT is visible.
Yeah, the PPT is visible, Avinash. You can start with the presentation.
Okay, thank you. My research topic is designing and testing basic protocol for medium fast bowler to increasing their speed and accuracy. So the aim of the study is to design a protocol which is relevant to their exercises, which going to improve their speed and accuracy. and also measure the kinematic measures. As we see, like there are few studies which suggest that the change in the knee angle will having an effect on their bowling speed. So like try to correlate with it with the others factors, which is going to be mostly relevant with the bowling speed. And to study the effect of the strength training, like the 6RM squat, 6RM bench press, and yo-yo intermediate, which is the endurance test, having an effect of my protocol on these variables. So in this, I have taken 60 state medium fast bowlers, age under 19, which is randomly divided into two groups. And before after like 6 weeks of training, I have given to them. And after that, I have seen that there is a significant change in that bowling speeds, where is the no change in the bowling accuracy. And there are a few changes in this, significant changes is found in the squat test, bench press test, and yo-yo intermediate test. So the introduction, like the ability of fast bowler to maintain their speed throughout the bowling spell or the days or to dismiss a batsman, it's a likelihood that if their speed is more, there's a more chances that the batsman will going to be out. So if you see that bowling action having a run up and front foot contact, which is the main factor which we have to see, and during the bowling release time was the angle of the knee and the follow up. So the common questions like during my practice, which I found from the bowlers is like, how can I be more effective either with their line or land? That's the accuracy, whether the bowling speed, if it's improved or decreased, there is a changes in the accuracy or not. Or will I bowl fast? Is it depend on that, like how they are going to be training, whether what training they will going to do so that they can improve their medium bowling speed, and whether like accuracy is going to be affected by it or not. So there are various factors which is going to be affect the medium fast bowler, like bowling techniques, their step length, their physical qualities, bowling kinematic, pace bowling skills, their lower limb biomechanics. The need of my study is the all cricketer who receive like physiotherapy or like training program, which is based on the strength and conditionings, having a variety of like ways. If they training in the district level and the state, there is a different program. There is a no fixed program, no basic program, which if they give it to them, and they will find it, okay, if you follow this program, we will going to get this much of improvement. So there is a no study in that field right now. At the present, there is no objective methods, no designing of that any program which we can directly give to the medium fast bowlers. So objective of my study to effect of the protocol is training of the strength and conditioning and the speed conditioning of the medium fast bowlers. In methodology, it's an intervention based study, randomized controlled trials design area, the Saurashtra Cricket Association. I have taken the samples, which is male under 19 medium fast bowlers, divided into two groups with this 30 in each group. So for that, like I have used the gym setup of the Saurashtra Cricket Associations only, and the bowling speed and accuracy is measured by the Doppler radar gun and vertical target. Inclusion criteria under 19 male state level players which don't have any injuries, and after like briefing about that intervention program and their commitment to that program, the volunteer players will chosen. Exclusion criteria, in the last 6 months and during the season time, whoever be injured and is not available for the training or the playing for more than 1 week are excluded from the study after musculoskeletal screening. And ethical approvals taken by the RK University and registration done in the CTRI. The methodology, like same, I have taken an informed consent, and after that, like started the study. And that's like I have chosen 2 exercises program, combined strength and the plyometric training, which are done by the survey, and after survey taken from the all over India who are working in the SNC field and the physiotherapy field, and the other doctors who feel that like whether they having some input or not. After that, we have got some feedbacks, like these are the exercises which is going to be mostly they are using, and after publishing it, I uses these exercises with the different only changes in that RM which I have changed, otherwise everything going to remain the same. So here I found that a significant difference in the bowling speed. There's no change in the bowling accuracy. So if we increase the bowling speed as well, like by this, the accuracy is going to remain the same, where the physical qualities parameters like RM squat, RM bench, and yo-yo intermediate, it shows a significant improvement. So these are the different readings of my study. Control group having no significant changes. So result that have seen a significant improvement in the bowling speed, their squat and bench press, the strength of the lower body, upper body, and the endurance have significantly improved. In other words, we can say that this type of training program improve the core strength and conditioning of the plyometrics of the lower body and the strength of the medium fast bowlers, which will see the result in their speed. So correctly designed and supervised training is a basic program which I have designed in the more if we can do in better in the future by designing like accurately for the tailor-made and to the specifically to that bowlers for the advanced level which exercises we can include it. So limitation of my study is like small sample size due to the COVID, like very few time I've got to get the samples from different states. I didn't able to get it. So like uncooperative players who having a few times like not available and having a commitment. So they are these are the limitation of the studies. Seasons and off seasons like is not decided by the BCCI at this time, like when the season is going to be start and not. So this is the limitations of the studies. Future recommendation by more sample size and the follow-up from the domestic seasons and from the like national level players, so we can get the accurate more accurately like whether this program is having an overall wide variety of results or not. So conclusion of the study is that like there is an improvement in the bowling speed of the medium fast bowler with no change in the their bowling accuracy, funded by the Saurashtra Cricket Association and Goilwal Gladiator, which is a team in the Saurashtra Premier League. And in my research, I acknowledge to the Dr. Ashish Kaushik and the Dr. Patrick Parat, which is the physio of the Indian cricket teams, and the Dr. Hitesh, with the coach with the BCCI. These are my references. Thank you. Hello.
Avinash.
Yes, sir.
I would like to ask the Shamit sir if he has any doubts.
Avinash, are there any meta-analysis or systemic review of similar researches of the same kind in different sports?
Sir, actually, like different sports they have, like in football and all these sports, like, but it's not on the state level. Like it's on a bigger level they have on a, and not covering the more players on in these sessions. So there are few researches which having like essence, but for cricket we don't find anything which will directly give to the players, which tailor made, and directly we can say them, okay, you can use it and you can find this much amount of result.
And is there any specific reason that you have chosen only medium fast bowlers?
Sir, actually, like the medium fast bowlers, when they're converting into a fast bowler, there's a high chances of injury. And due to that, if you see like in the past, Munaf Patel and all this have broken their career due to their back injuries. So there is a more chances if their speed is increasing, there is a chances of injury as well. So this is the topic like in the BCCI, they are discussing like a lot of times, like they are losing that fast bowlers like Bumrah, then Hardik Pandya right now, they're having an injury in the back due to that like frequent bowling. So load monitoring and all these things are the key concept in the BCCI which is going on. So I'm also in the setup from last 7 years. So I've chosen this topic. So like at least start something on the beginning state, and after that, like looking forward, like how we can take the next level.
Can I just see a references slide once, if it is possible? The references slide.
Yes, one second. Yes. During my masters also I have done like on few researches on the same field, so I have using the same thing.
Yeah, so this doesn't have recent study, 2015.
Which one, sir? This study? No, so this is a research, my PhD study, ongoing my PhD study. But like on the past, like in my masters, also I have done in the taekwondo, like of that strength training and their agility and improvement. But it's a far different sport. So in cricket, like I have go to the medium fast bowlers to seeing like whether having some changes or not. By for that, like they suggested to take the overview of the whole like SNCs and the physios and doctors who was working in the field to take their review and then after that choose the exercises. So like conducted the whole survey and after that whatever they have suggested, whatever the percentages came, we have taken only these that exercises and just try to intervention onto the players and see the result.
Thank you, Avinash.
Okay, sir. Thank you, sir.
Thank you, Avinash. Thank you, sir. Now I would like to invite Prachi Khandekar for her oral presentation on effect of high intensity intermittent exercise on neurotropic factors in sporting and non-sporting young adults from Department of Sports Sciences and Medicine in India. Prachi Khandekar.
Good afternoon, everyone. I was not able to unmute myself, therefore delay happened. I hope my screen is visible to you all.
Yes, it's visible.
So good afternoon, one and all. Myself, Prachi Khandekar. I'm PhD scholar at MYAS GNDU Department of Sports Sciences and Medicine, Guru Nanak Dev University, Amritsar. My topic of presentation is effect of high intensity intermittent exercise on neurotrophic factors in sporting and non-sporting young adult group. So talking about introduction, neurotrophic factors are chemical factors that are responsible for neuronal development. They play an important role in maintenance and regeneration of mature peripheral neurons and thus help in maintenance of cognitive response in day-to-day activities. The neurophysiological response to exercise on cognition is modulated through these factors, which involve brain-derived neurotrophic factor, insulin-like growth factor, and vascular endothelial growth factor. BDNF or brain-derived neurotrophic factor is a key component to regulate neuronal growth, repair, and neuroplasticity, and it is involved in several functions, including learning and memory and behavior. Peripheral VEGF mediates exercise-induced angiogenesis and neurogenesis, whereas IGF helps in the process of BDNF expression as well as it assists in neurogenesis. Previous literature has shown that secretion of these neurotrophic factor increases in response to high-intensity intermittent exercise, that is HIIE, but studies lack to show differences in acute response to neurotrophic factors in response to HIE between sporting and non-sporting sedentary population. Therefore, the purpose of my study was to evaluate the effect of HIE intervention on neurotrophic factors in sporting as well as non-sporting population. Talking about the methods, I took 40 samples, out of which 22 were sporting individuals and 18 were non-sporting subjects. The sample size was 40 and it was calculated using GPower software in which this effect size was capped 0.55 and level of significance was kept 5% and power of test was 80%. Age group which I selected was between 18 to 30 years. From them, written informed consent was obtained. The study was approved by Ethical Committee of Guru Nanak Dev University, Amritsar. The study is also registered with Clinical Trial Registry of India. Inclusion criteria was as follows. The males and females both were included. Young adults with the above mentioned age group was included. Sport participant with at least 3 years of experience in the same sports were included. And non-sporting participants were those who regularly not involved in any competitive or recreational sports. We excluded the participants on the basis of if they answered any questions which is mentioned in physical activity readiness questionnaire. had a history of cardiorespiratory or cerebral vascular disease, had a history of psychiatric or neurological disease, or had done any strenuous activity, or they had used tobacco, nicotine, or alcohol 24 hours prior to the test, or they had poor sleep, which was measured by Pittsburgh Sleep Quality Index, or they consumed 2 or more than 2 cups of caffeine on the same day, or a large meal 2 hours before the exercise. The exercise intervention involved 4 bouts of cycling for 4 minutes, that is 4x4, at 90% or to 95% of HR max, with 3 minutes of active recovery at 70% of HR max. The protocol was followed on load Corrival BV cycle ergometer. Heart rate and Ball's rate of perceived exertion was recorded at every stage of cycling. The assessment of outcome was done as follows. We used ELISA analysis, for which total 10 ml of blood was drawn, which was drawn by a trained medical lab technician, as you can see in this picture. And the 5 ml was taken before the exercise and 5 was taken after the exercise from antecubital vein into an anticoagulant-free tubes. And the serum level was evaluated for the level of BDNF, IGF-1 and VEGF before and after the exercise. Talking about stats, we did data analysis using SPSS version 21. The normality of data was assessed using Shapiro-Wilk test, and we found that our data was normally distributed. The data of blood variables were assessed as mean and standard deviation values. Two-way ANOVA was done in the repeated measure analysis, and it was done to examine the effect of acute HIE on the level of BDNF, VEGF, and IGF-1. These are my results, which shows demographic characteristics of participants, which showed that the age, BMI, resting heart rate, and PSQI, that is Pittsburgh Sleep Quality Index scores were similar in both the groups, and there was no significant difference, which was tested by independent t-test. Variation in the heart rate during various stages of HIE was recorded, and we found that during the warm-up, there was less heart rate, whereas it increased from the stage 1 to stage 2 up till stage 3, and it was decreased from stage 3 to stage 4, and it was decreased in the cool down period. Similar was the trend which was observed in rating of perceived exertion, which was measured using Borg scale. Neurotrophic factors to response to the HIE intervention included that there was a significant effect of HIE intervention on the level of serum BDNF, IGF-1, and VEGF in our participant. Two-way ANOVA results showed that there was a significant difference in the effect of HIE on these neurotrophic factors between sporting and non-sporting young adults. These are the graphs which shows our result. In the athletes, there was increment in BDNF level. Similar was the case in non-athletes, but as you can see, there was a greater increase in non-athletes compared to athletes. Similar was the trend in VEGF, whereas the concentration of IGF was found to be increased more in athletes as compared to non-athletes. So to discuss, the increase in neurotrophic factor was found in both sporting as well as non-sporting group. However, BDNF and VEGF levels were more increased in sporting group, in non-sporting group compared to sporting group. Therefore, this increase from pre to post session appears to be higher in non-sporting group, because there was a huge difference at the baseline as well. Therefore, the difference were found, and these findings were supported by the previous result of Caro et al. And Carball Santos et al. And in IGF level, it was also found that both the group showed increase after HIE intervention. However, increase was more on in sporting group. So to conclude, our study shows that there was increase in the neurotrophic factor after HIE intervention in both the groups. However, the groups differed in the response, and there was more increase in BDNF and VEGF level in the non-sporting group, whereas IGF levels were more increased in non-sporting group. These were the limitation. Only acute effect of exercise was seen and no control group was taken. And the study was funded by a grant which was received from Ministry of Youth Affairs and Sports, Government of India. So take-home message from my research is HIE provides enhancement to the body's neurophysiological response, and thus it improves function of the central nervous system. Hence, this exercise regime should be incorporated in daily life to enhance neural functions, both in sporting as well as non-sporting population. Being a part of rehabilitation teams, these findings help us to follow multidisciplinary approach to improve overall fitness of the general population. These are my references. Thank you.
Thank you, Prachi. Now I would like to ask Shamat sir for if he has any questions. Shamat sir.
Yeah, the mute button was not there. Okay, so can I just see the slide of the comparison between the sporting and non-sporting in the aspect of heart rate?
Sure, sure, sir. Just a minute. This one, sir?
No, the line graph.
This one?
No, the previous one, heart
This
rate.
one? Yes, sir.
Okay. So why do you think there is difference in the stage 2 where we can see it is almost near to same in all the stages other?
Because the sport condition varies in sporting as well as non-sporting population. However, the sporting group which we took used to walk here and there for their attending their department level classes. So some amount of physical activity they used to do. But if we talk about sporting group, so the heart of a sports player is made up of such that even with the help of exercise, even with higher level of exercise, the increase in the heart rate is not that much as compared to a non-sporting group or a person. So therefore, in this stage, we can see that there was a difference between both of these group in the increase in the heart rate, because the condition, the level of the heart conditional level of athlete is much. Therefore, the heart or you can say cardiorespiratory response of athletes are not that much elevated, even if the exercise level is increased from stage 1 to stage 2. So that's the thing, sir.
What was the device used to monitor the heart rate?
Sorry, I did not mention it my slides. The polar heart rate calculator was used to measure the heart rate response.
So does it display the real-time heart rate of an individual performing the exercise?
Yes, sir. We checked it with the smart watches, and the smart watches were not that much reliable. However, we checked the reliability of heart rate that recorder, that is polar heart rate recorder, and we checked it with HRV devices which are there in our department. So it showed the similar kind of results in the increase in the heart rate while doing the exercise. Therefore, we relied on these polar heart rate machine. I mean, the watch, sir.
Thank you, Prachi.
Okay, sir.
Thank you, sir. Thank you, Prachi. Now, I would next like to invite Ujjwala Sharma for her oral presentation on a literature review on the effect of yoga therapy in rehabilitation in orthopedic health conditions from All India Institute of Medical Sciences, India. Ujjwala Sharma. I can't see her in the participants. So moving on to Neha Yadav for her oral presentation on Effect of hold relax PNF technique combined with myofascial release therapy on episodic tension type headache in student population in Belgaum city, a randomized controlled trial from Kahir Institute of Physiotherapy, India. Neha, can you please unmute yourself?
Good afternoon, everyone. Am I audible?
Yeah, Neha, you can.
Can you see my screen?
Yeah, we can see it.
Oh, thank you. So may I start with my presentation?
Yeah.
Good afternoon, everyone. So the title of my study is Effect of Hold Relax PNF Technique combined with Myofascial Release Therapy on Episodic Tension Type Headache in student population in Belgaum city, a randomized controlled trial. So introduction. So as we all know, there are three categories of headache. So according to ICHD, that is International Classification of Headache, given by WHO, tension type headache falls into the category of primary headache. So the prevalence of tension type headache is around 38% globally. So it is the most, majorly it affects the daily living activities of a person in aspect of emotion, daily work, general life activities. So patients with tension type headache also exhibit increased tenderness in the and presence of myofascial trigger points in the occipital region. These myofascial trigger points may have various physical features, including tenderness, palpable tendon nodules within a taut muscular band, characteristic pattern of referred pain. So here, what we are trying to explain is that trigger points are present in the occipital region, as well as according to the studies, there is atrophy of the occipital muscles, which can also cause higher intensity of pain, and also repeated episodes of tension type headache. So here, proprioceptive neuromuscular facilitation, that is contract relaxed PNF technique, consists of stretching of the muscle and keeping it in the position while the patient isometrically contracts it and then relaxes in a pattern. Thus, it produces an effect of increased muscle strength, maintaining and gaining the joint mobility and better motor control. So methodology. The study design is an experimental study. Study type is a randomized clinical trial. Study duration was 6 months, and sampling technique was a CHIT method, that was random sampling, and the sample size was 36. So CTRI registration was done for this study, and ethical clearance was obtained from the Institutional Ethical Committee. As well, all the COVID precautionary measures were followed. The inclusion criteria was according to the International Classification of Headache Disorders, in which the subjects with bilateral dull aching frontal or occipital headache were included, with mild to moderate intensity, which was screened according to NPRS, that is numerical pain rating scale, which scored from 5 to 8, which is mild to severe kind of headache. So patients with at least 10 episodes of headache in a year, which last for more than 30 minutes, were included, and either one episode of photophobia or phonophobia were included. Other kinds of headache, such as migraine or any other headache which fell into category of other than tension type headache, were excluded, that is tingling or throbbing kind of headache, who experienced nausea or vomiting, that is with aura, and then which were the patients who were diagnosed with any other neurological condition, which acute illness or any vestibular condition or any other medical condition. So outcome measures were as follows, that is headache disability index, then headache impact scale, that is HIT6, then global rating change of scale, that is measured pre and post, and the numerical pain rating scale. Out of this, only numerical pain rating scale was used for outcome measure as and also as a screening tool. So 42 people were assessed for eligibility criteria, out of which 36 were randomized, an experimental group, which was myofascial release therapy as well as PNF therapy, a combined effect, and a control group in which myofascial release therapy was given. So in group A, PNF contract relax technique was given. This is the experimental group in a duration of 3 weeks, thrice a week, which was alternate days. 15 minutes of myofascial release therapy was given for the occipital region, and then which followed by 15 minutes of PNF techniques was followed. So assessment was done at the baseline level, that is day 1, then at day 5 and day 9. So total intervention days were 9, out of which 3-time assessment was done. Myofascial release therapy, that was a control group in which 3 weeks of intervention was given, similarly as group A, which lasted for 15 minutes, that is myofascial release therapy, and 3-time intervention, 3-time assessment was done, that is day 1, day 5 and day 9. Results. So here, as we can say, in group A and group B were homogeneously distributed, except for the weight, which varied. Here we can see that weight mean was 55, and in group B it was 67. So there was a significant difference in the weight, due to which there was significant difference seen in BMI as well. Other than that, duration of headache, episodes of headache in a month, and other factors were homogeneously distributed. Results. So here we can see that comparison of day 1, day 5 and day 9 of the treatment is done. So here in HDI, that is Headache Disability Index, we can see that there is significant change in group A, that is experimental group, where the mean of the headache disability index was 41 on 5th day, which significantly reduced to the on 9th day. Here, as we can see, the mean of 5th day and 9th day is not, there is no improvement, no significant improvement seen. Other than that, HIT6, GROC, that is Global Rating of Change Scale, and NPRS has showed significant improvement in both the groups. While comparing the group A and group B, that is experimental and control group, we can see both the groups showed a significant improvement. But comparing headache disability index, we can see that the improvement shows a significant difference in both group A and B. We also checked for correlation if between BMI and pain intensity, where we correlated the intensity of pain for group A and group B on all the days of assessment, but we did not find any significant difference in BMI and intensity of pain. Therefore, it concluded that there is no correlation between pain and BMI. Discussion. Our study revealed that the combination of PNF and MFR therapy results in marked reduction of pain intensity in patients with tension type headache. The study shows a significant decrease in pain and disability in HDI and NPRS scores in the experimental group. According to Wing Tang et al. And Ibrahim Ramazian et al., MFR shows a good improvement in pain intensity. But one drawback of the study was that many subjects had short-term pain relief and had recurrent episodes of pain even after being treated with myofascial release therapy. This issue was resolved in our study as a follow-up was done after 3 weeks, and the study and the results were persistent. Also, the subjects did not have any recurrent episodes of headache in our study. A study was done where the author determined the MRI of neck and extensor group in patients with episodic tension type headache. The study revealed that these muscle groups are undergone atrophy due to chronic non-use and faulty neck posture. Therefore, it was necessary to focus in our case that we had planned protocol of same as a study focused on PNF approach, which also did strengthening of the neck extensor muscles and occipital muscles by using a hold relax technique. Limitations. There is no objective assessment done for the subjects. Therefore, there is no better understanding of the objective aspect. No follow-up was done to study the long-term effects. And assessment for episode of photosensitivity and photosensitivity and phonosensitivity was not done. So that was the limitation of our study. Conclusion. The present study demonstrates the PNF and MFR resulted in significant improvement in pain and frequency of episodes in people with tension type headache, and this treatment approach is safe and without any side effects. Future scope. Studies should obtain an electrophysiological measurement, such as using USG of occipital muscles, so that we can see if it works on the atrophy part of the tension type headache, atrophy of the occipital muscles. Also, a subjective or objective assessment can be done to analyze the stress levels and effect of PNF on stress levels to validate the findings of our study. References. Thank you.
Thank you, Neha. Now I would like to ask Shamath sir if he has any questions regarding the study. Shamath sir.
Hello, am I audible?
Sir, your voice is breaking. Your voice is breaking, sir, a bit.
Am I audible now?
Yeah, sir, you are audible.
Yeah. So I have two questions here.
Yes.
So initial in your slide there were 4 outcome measures, right? You used 4 outcome measures, but then when accessing the patient at the end, you only used pain rating scale to quantify the significance of pain.
Yes, sir. So basically what I'm trying to tell here is the pain rating scale, the intensity of pain obviously decreased for both the groups. But in headache disability index, there is a point where we check for the episodes of headache within a week, within a month of period. So the episodes, the recurrent episodes of the pain that was experienced by the patient, that showed improvement in the PNF group, that is experimental group, whereas only the intensity aspect was seen improving in the control group. So in the headache disability index, that is what we checked. So we are commenting that the episodes of headache that is experienced by the patient, that reduced because there was we worked on by using PNF technique, we work on the strength part and the atrophy part of the muscle. So yeah, so that was the outcome.
And my last question would be, so you also talked about the MRI of cervical spine in tension type headache, right?
Yes.
So do you think there is any indications of doing MRI in patients with this kind of headache?
Yes, sir. So ultrasonography was done, like according to the mother article that I have taken for the study. So ultrasonography was done to see if there was atrophy of the muscle, and there was a positive finding. So based on that study, we made this protocol of using a PNF technique, wherein we have not done an objective assessment. So that is one limitation of the study. But we can, using the same technique, if we can do that objective assessment, then we will be able to quantify the results. So that will validate the findings of our study.
Thank you.
Yes, sir. Thank you, sir.
Thank you, sir. Thank you, Neha.
Thank you, sir.
So before, I would like to call once again, Ujjwala Sharma for her oral presentation. If Ujjwala Sharma is there. I can't see her in the participants list. So I would like to thank you all. Thank you, Shamath sir, and thank you all the participants. We will conclude the session for the time, and we'll meet after the lunch at 2:30. Thank you.
Hello. 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 Hello, good afternoon, everyone. I'm Dr. Amna, and I welcome you all again for this conference. So we'll start with the further presentations now. I'll be calling Vaishnavi Kokate for the oral presentation on the title of her presentation is Work-Related Musculoskeletal Disorders in Housemaids of Mumbai Metropolitan Region, a cross-sectional study. She is from Lokmanya Tilak College of Physiotherapy, India. Vaishnavi Kokate.
Hello. Ma'am, can you hear me? Hello.
Yes, Vaishnavi, you can proceed with your presentation.
Okay. Is my screen visible?
Yes, it's visible.
My topic is work-related musculoskeletal disorders, that is WRMSDs, in housemaids of Mumbai Metropolitan Region, a cross-sectional study. When the environment in which an individual works and the performance of that work has a direct impact on the development of musculoskeletal disorders, it's known as work-related musculoskeletal disorders. Basically, WRMSDs are associated with 4 work patterns, that is fixed or constrained body positions, continuous repetition of those same movements, considerable amount of force or tension which is concentrated on hand, wrist, ankles and knees, and also the speed of work that does not allow sufficient recovery time between those same movements. Individual factors out of all these 4, the individual factors, if performed continuously, would not result in WRMSDs, but a cumulative effect of all these 4 factors on a daily basis would lead to the development of work-related musculoskeletal disorders. In India, a large majority of women work as housemaids or domestic help workers. Since housemaids work in many households on daily basis, the exposure which their joints, the risk factors will have on their joints or their body posture will increases tremendously. They are prone to develop cardiovascular diseases due to their erroneous walking postures and the center of gravity changes. Such prolonged exposure to the current working conditions will bring about severe physical disability and a debilitated quality of life in them. Repetitive strain will lead to musculoskeletal symptoms and reduced work efficiency. And due to their lower economic status and not so much in the information which they don't have regarding their posture and how it affects them, these symptoms will usually be neglected. Considering the above facts, if the effect of these WRMSDs, which they have on housemates, if it can be checked in the initial stages only, and the initial warning signs of these musculoskeletal system can be controlled, and if treated sooner, then this would further prevent the workplace injuries in housemates. Hence, this study was conducted. The methodology of my study, it is a cross-sectional study of convenience sampling. The duration is 1.5 years. I included housemaids who are working in the Mumbai metropolitan region, who are aged between 20 to 60 years of age, who have a minimum work experience of 1 year or more, and who have a basic language proficiency in Marathi or Hindi, so that the communication is easier. Those housemaids who are not willing to participate are not included. Also, those who have any physical or mental impairments like amputations, neurological deficit, loss of cognition, or mental retardation were not included in the study. The instrumentation I used was Cornell Musculoskeletal Discomfort Questionnaire. This questionnaire has 3 sections: discomfort, severity, and interference. The procedure goes like a consent form which was translated in Marathi and Hindi language according to the participants' preference, which was signed by the participants prior to the study. The consent form included the purpose of the study and the signature of the participants. The demographic data was initially collected, that is age, weight, height, the number of working hours, and the number of years working, also the nature of work, what all work was included by that participant, and the government ID was checked for the proof of age. The participants were completely made understood about the questionnaire, and if they had any doubt, they had to approach me for it. Cornell Musculoskeletal Discomfort Questionnaire was given to each participant, and the demographic sheet was separately given, which was afterwards stapled together, and frequency, severity, and interference scores were marked. Each participant's demographic and CMDQ was stapled together and assessed. The musculoskeletal discomfort frequency, severity, and interference was analyzed thereafter, and the results were given. This is the CMDQ, that is the Cornell Musculoskeletal Discomfort Questionnaire. As we can see, there are various regions: neck, shoulder, upper back, upper arm, lower back, forearm, wrist, hips, thighs, knees, lower leg, and the foot. Then there are 3 sections into which the scale is divided. The first section, where they ask about if last week work, how often did they experience ache, pain, or discomfort, is the discomfort score, which is further divided into 5 components, that is never, 1 to 2 times last week, 3 to 4 times last week, or once every day, or several times every day. The next is the severity score, which asks experienced ache, pain, or discomfort, and how uncomfortable was that experience. So the severity score is divided into 3 subsections again, that is slightly uncomfortable, moderately uncomfortable, and very uncomfortable. The last section is the interference score, which asks if that pain or discomfort which they had, did that interfere with their ability to work in their working hours routine. So that is further divided into 3 subsections, that is not at all, there was no pain, or slightly interfered, or the most last one, which was most common, is the substantially interfered option. This study is carried out among housemaids of Mumbai metropolitan region by Cornell Musculoskeletal Discomfort Questionnaire to investigate the work-related musculoskeletal disorders. Majority of the participants reported discomfort in upper back, lower back, wrist, knee, and knee joints, and also the foot, with major interference in the lower back region. The nature of work has a direct impact or influence on the development of musculoskeletal disorders. Housemaids who do cleaning and brooming for long hours reported discomfort in lower back and knees due to their working posture and their daily activity. Also, who cook for long time or long duration reported discomfort in lower back and the dominant side wrist. Those who indulge in increased duration of work in a day showed the involvement of more joints that were affected. The study shows that increased years of experience of participant regarding their work reported an increased interference in the lower back. Also, bad working conditions and neglecting the right postures, lack of proper work conditions gradually cause disorders in people and create irrecoverable problems in the long run. These further lead to aggravated musculoskeletal symptoms, also result in sickness, absenteeism, and the degraded quality of life. In the results section, there was major interference of the lower back. Lower back was the most affected in all of the participants. That reported 25% who reported the interference as slightly interfered. 20% said there was no pain or no interference, but maximum of the participants, that was 55%, reported substantially interfered in their work routine due to their lower back pain or discomfort. As you can see the bar graph, 3 to 4 times last week was the option which majority of the participants reported as yes, followed by 1 to 2 times last week, and then once every day and several times a day was the least reported. Same, if we see the severity score of lower back, moderately uncomfortable was the highest reported option. Followed by a very uncomfortable option, and then that is followed by slightly uncomfortable option. If we see the right side knee, that is the dominant side of most of the participants, the discomfort score was not very substantial, as many of the participants reported no pain, but equal amount of participants did report 3 to 4 times last week. They did say yes for that, and 1 to 2 times last week.
Vaishnavi, can you try to conclude your presentation as you're running out of time?
Yes, ma'am. These are the scores for upper back and discomfort score for the foot as well, where the foot has reported majority in 1 to 2 times last week, followed by 3 to 4 times. The most affected region is the lower back, as we can see from all the results. It showed increased discomfort score. The interference in the lower back caused in the daily routine is reported high. So 55% reported substantial interference with 25% of slight interference. Participants reported equal discomfort in right knee, and for upper back, 20% reported discomfort, and for the foot, 80% participants reported discomfort score. The limitations of the study was the sample size was limited, due to which the results can be compromised. Also, the perception of discomfort, severity, and interference will be different for each participant. Hence, a quantified approach is more probably required for further study. These are my references for the study. Thank you.
Thank you, Vaishnavi. Now I would like to request Shamit sir, if he has any questions, we can proceed with that.
Should I stop the screen sharing?
It's okay. Shamit sir, can you hear me?
Yeah.
Yes, sir.
Yeah, I have no questions.
Okay, sir. Okay, thank you, Vaishnavi.
Thank you so much.
So moving ahead with our next presentation, I would like to call Fatima Shirgaonkar for a presentation on the topic Association of Pain, Strength with Disability among Physiotherapy Students Using Smartphone. She is from Lokmanya Tilak College of Physiotherapy, India. Fatima, are you there? Fatima Shirgaonkar. Fatima Shirgaonkar for the presentation of Association of Pain, Strength with Disability among Physiotherapy Students Using Smartphone from Lokmanya Tilak College of Physiotherapy, India. Okay, so we will move ahead with Mansi Rathi for a presentation on effect of prone traction, abdominal strengthening, and surge paradic current in lumbar canal stenosis, a case report from MGM School of Physiotherapy, India.
Ma'am, can you listen me?
Yeah.
Okay. Can I start sharing my screen?
Sure, sure.
Is my screen visible?
Yes, Mansi,
Hello?
it's visible. Yeah, Mansi, it's visible. You can proceed.
Okay.
You have time for the presentation you have. I'm just reminding you once, like for 8 minutes, you have the time to present.
Yeah, yes, ma'am.
Okay.
So can I start?
Yeah, sure. Proceed.
Okay. Good afternoon, everyone. The title of my presentation is Effect of Prone Traction, Abdominal Strengthening, and Surge Paradic Current in Lumbar Canal Stenosis, a case report. So, degenerative lumbar spinal stenosis is most frequent cause of low back pain or sciatic in the elderly patient. Among various problems with spinal aging, lumbar spinal stenosis is the most frequent indication for the spinal surgery in a people over 60 years old. Stenosis. There are the various reasons that can lead to stenosis, like aging, including facet joint hypertrophy. Then there can be the loss of intervertebral disc height, disc bulging, osteophyte formation, and hypertrophy of the ligamentum flavum. What is the hallmark indication of the central stenosis? The hallmark indication of the central stenosis is neurological claudication, which may manifest as lower limb discomfort, paresthesia, and decreasing strength. Walking or standing up cause these symptoms, and it is when the patient sits or leans forward. So, our case report describes the successful effectiveness of the prone traction phonophoresis core strengthening exercises in the patient with spinal stenosis. So here is the description of case. A 72 years old retired officer had a complaint of low back pain and neurological claudication since 8 months. He had visited the orthopedic department there. The investigations were done. He was given the medications for 2 to 3 months. He felt relief, but after that he experienced the same symptoms. So he visited the physiotherapy department. The investigation revealed the diffuse disc bulge and hypertrophy of the ligamentum flavum from L2 to L5 level, and at L3 and L4 level there was a compression of a thecal sac that we found causing a mild canal stenosis. So the examination that we took on observation, postural anterior pelvic tilting and increased lumbar lordosis, on palpation, spasm of the paraspinal muscle, tightness of the hamstring, gastrocnemius and soleus muscle, MMT grade 3 of the hip extensors, that to particularly gluteal maximus, and the strength of the abdominal muscle was also adequate. We found a decreased range of lumbar flexion. We have taken a pre-test evaluation. There we got a score of NPRS 9 out of 10 after 2 minutes of walking, and the patients caused the symptoms of neurological claudication after 2 minutes of walking. Then here are the intervention that we have given. First, we have explain all the treatment strategies to the patient. Then our treatment initiation with a 20 minutes of hot pack to the lower back, hamstrings and calf muscles, each with 7 minutes. We have given phonophoresis by using piroxicam gel for 6 minutes at a lumbar region from L2 to L5, and surge Faradic was also given as paraspinal muscle at the lumbar and thoracic region for 6 minutes each, and it includes 5 seconds on and 4 seconds off. After that, we have started with exercise that included a single leg knee to chest, double lower limb knee to chest, then spinal rotations. Each exercise were given for 10 repetitions. Dorsolumbar fascia stretch was given by the therapist itself. The abdominal contraction exercise with breathing exercise were given, and the patient was asked to hold the contractions for 5 to 10 seconds. The gluteal maximum strengthening was also given. The hamstring release was given by using a marble. Then we have corrected the anterior pelvic tilting of the patient, and finally we have given the prone traction to the patient for 10 minutes, and thus our treatment lasts for 1.5 hours. The result, the patient was able to walk for 15 minutes without experiencing any symptoms after following this 8 days intervention strategy, and the level of pain was also reduced to 4 on NPRS. We conclude that prone traction, abdominal strengthening, and surge Faradic current are effective treatment in patients with spinal canal stenosis, as patient pain has been reduced and improvement has been seen in the intermittent claudication. We have given prone traction to the patient as he has canal stenosis, and traction does separate vertebral body, and prone position gravity tends to pull annulus fibrosis insides and relieve the symptoms. We have given a surge Faradic to relieve the spasm of a paraspinal muscle, and phonophoresis was given at the region of hypertrophy of the ligamentum flavum. We have worked on the strengthening of the gluteal and core muscle because the imbalance in the muscle can lead to postural abnormality. Conclusion, we conclude that prone traction strengthening exercise of the abdominal is effective in patients with spinal canal stenosis, and it improves the quality of life of the patient. Here are the references that we have used. The last 2 references that we have used, in which the last one, the mechanical traction for lumbar radicular pain, supinal prone, they have done a randomized control trial on around 142 people, and they also got an immediate reaction with a patient in which they have given a prone traction. Thank you.
Thank you for your presentation, Mansi. I would like to request Shamit sir to proceed with the question answer session.
Hello.
Yes, sir.
Yeah, Mansi. So this is a case report, right?
Yes, sir.
So how many cases has been seen in this report? Is it a single case, or there are a number of cases that you saw?
Sir, it is a single case report.
So as you explained that you gave prone traction, right?
Yeah.
So what biomechanical changes do you expect to see in supine traction and prone traction, and what is the ratio of the weight that you gave during the traction?
Okay, so as we in the prone traction, we have given a static traction. So we have used a mechanical traction. So 1/6 of the weight of the patient is given. So the patient was around 80 kg. So around 22 to 25 kg, we have given a static weight, and the biomechanics around it, as I have explained in a discussion, when the patient is in prone position, the gravity itself will help us to to pull the annulus fibrosus. So a sort of gravity will also assist in the prone position.
And as you said that the patient had intermittent claudications, and also there is a severe stenosis in the lower lumbar region. Then you had pictures in your slide. We saw that the patient was given flexion exercises, right?
No,
The stretching.
it is a lumbar. Actually, we have given a dorsolumbar fascia stretch to the patient.
Okay. So will it not create the force on the segment of the lumbar where there is problem with this kind of stretch?
No, sir, not because we are just working on the fascia. So not exactly. The patient has found relief after that stretch.
What was the total duration of the treatment?
It was around 1 to 1.5 hours.
For how many days?
For 8 days.
Okay, and have you also checked that this with the patient doing traction in supine position with the same condition, comparative?
Yeah, first day actually we have done with supine position. Then he was not actually he has not got any sort of relief, and he was complaining of the same pain. Then we have researched, and then from the second day we have started with a prone traction, and after that we start. His pain, he started experiencing the intensity of the pain lower on the lower side. So we have continued with the same protocol for the 8 days, and we have got a result.
Thank you, Mansi.
Okay, thank you, sir.
Thank you, sir. We'll be proceeding with our next presentation. I would like to call Prachi Maheshbhai Thakkar for a presentation on the topic to find correlation between myofascial trigger points on the upper trapezius and severity of cervicogenic headache among college-going students. She is from Apollo Institute of Physiotherapy, College, India.
Good afternoon, ma'am. Good afternoon, sir. Am I audible?
Yeah, you're audible, Prachi.
Is my screen visible, ma'am?
Yeah, it's visible. Kindly proceed.
Okay. Good afternoon to one and all. My study is to find correlation between myofascial trigger points on upper trapezius and severity of cervicogenic headache among college-going students. Myofascial pain referred from hyperalgesic trigger points located in the skeletal muscle and its associated fascia. It is a common cause of persistent residual pain. Acute trauma or repetitive microtrauma may lead to development of stress on muscle fiber and lead to formation of trigger points. The International Headache Society defines cervicogenic headache, CGH, as pain referred from a source in the neck and perceived in one or more region of head or face. It can be triggered from various structures in the cervical spine, which may either be vertebral joint from occiput to C3 or fascial joint from same area. Mostly C1 and C2 are responsible in CGH. Yes?
अरे हो गया तूने कॉल किया उसके बाद की
Kindly mute yourself, Mansi. Please mute yourself.
Sorry, ma'am.
May I continue, ma'am?
Yes, Prachi, please continue.
The prevalence rate of CGH varied from 4.1% to 21%, and the most common presentation was found unilateral head pain without side shift, neck pain, and restriction of neck movements. Aims and objectives: to find out the correlation between number of myofascial trigger point on upper trapezius and severity of cervicogenic headache among college-going students. It is a correlation type study where the individuals with cervicogenic headache along with upper trapezitis were selected. Purpose of sampling was done. Following materials will be used. Inclusion criteria had having cervicogenic headache according to the cervical flexion rotation test, having myofascial trigger point on either side of upper trapezius muscle, college-going individuals, both male and female, knowing English language and willing to participate. Exclusion criteria, subjects with known case of any other type of headache, such as migraine or tension type, etc. Ethical approval was taken from the Institutional Ethical Committee. 30 college-going volunteers with complaint of pain in upper neck and head were selected. Return informed consent form was taken from them. Cervical flexion rotation test was performed, in which the cervical spine is fully flexed and it is rotated to right or left while noting the range of motion and pain. Range of motion is considered limited when the therapist determined firm end feel, and based on the therapist's interpretation was a minimum of 10 degrees. Along with that, myofascial trigger point on upper trapezius were palpated and subjects with positive result were taken. Headache disability inventory was taken to check the severity of headache. Results were calculated using SPSS version 26. Pearson correlation was calculated. The value was R is equals to 0.6, which signifies that there is a moderate positive correlation between the trigger points on upper trapezius and severity of headache. Following graph represents the following. It shows a positive correlation between total trigger points and HDI. This study focused on finding correlation between myofascial trigger point on upper trapezius and severity of headache in cervicogenic. Results showed a moderate positive correlation. Cervicogenic headache patients have high probability of having myofascial trigger points, particularly from overactivity of sternocleidomastoid, upper trapezius, and temporalis. Jaeger found 12 out of 12 cervicogenic patients had at least 3 myofascial trigger points on the symptomatic side, which reproduced their headache over 50% of the time. Also, Asif Fateh Siddiqui in 2017 aimed to compare the acute effects of superficial and deep dry needling into trigger points of suboccipital and upper trapezius muscle in patients with cervicogenic headache. They concluded a positive result and had greater effects. Limitation. The study was limited just to the college-going students and the sample size was also small. It can further be done on a generalized cervicogenic headache population with a larger sample size, and more research can be done by treating myofascial trigger points and assessing the severity of the headache. No funding was received from institution or subjects. This concluded there is a moderate positive correlation between myofascial trigger point and severity of cervicogenic headache. As the number of trigger point increases, the severity of cervicogenic headache also increases. Following are the references. Thank you.
Thank you, Prachi. Shamit sir, we'll proceed with the question answer session.
Prachi, what are the outcome measures that you have used for the finding the effectiveness?
So it is a correlation study. My study focused on finding the correlation between the myofascial trigger points on upper trapezius and with the severity of cervicogenic headache. And HDI was used as a outcome measure for checking the severity of headache.
Okay, thank you.
Thank you, sir.
Okay, thank you, Prachi. We'll be moving for our next presentation. I would like to call Sheetal Ben Bharatbhai Panchal. The title of her presentation is to compare the effectiveness of strong surge Faraday electrical stimulation and ultrasound in young individuals with upper trapezitis. Sheetal Ben Bharatbhai Panchal for the topic to compare the effectiveness of strong surge Faraday electrical stimulation and ultrasound in young individuals with upper trapezitis.
Ma'am, I am audible too?
Yeah, Sheetal, you are audible.
Ma'am, okay, ma'am, I continue my presentation.
Sure. Yeah, you proceed.
Ma'am, my title is to compare the effectiveness of strong surge Faraday electrical stimulation and ultrasound in young individuals with upper trapezitis. Introduction. Trapezitis is an inflammation of trapezius muscle which can cause neck pain, muscle spasm, tenderness, stiffness, and limitation of cervical movement. Neck pain is very common in the region of the upper trapezius muscle, and about 2/3 of the people experience of neck pain at some point of their lives. In middle age, prevalence is highest and women are more affected than men. Neck pain prevalence varies widely in different studies, with a mean point prevalence of 30% and mean lifetime prevalence of 50%. Strong surge periodic stimulation is a type of electrical stimulation resulting in improving joint range of motion and mobility with decreased pain. Ultrasound also reduce pain and increase functional ability of subjects. Aim of the study to compare the effectiveness of strong surge periodic electrical stimulation and ultrasound in young individuals with upper trapezitis. Objectives of the study: to find out the effectiveness of strong surge periodic electrical stimulation on neck pain, on cervical range of motion, on neck disability in young individuals with upper trapezitis. To find out the effectiveness of the ultrasound on neck pain, on cervical range of motion and neck disability in young individual with upper trapezitis. Materials and methodology: study design, a comparative study. It is a convenient sampling. Study duration 3 times per week for a 2-week. Study setting from various colleges of Ahmedabad. Materials used: consent form, universal goniometer, neck disability index, ultrasound machine, electrical stimulation machine, scale, paper, pen, pencil. Criteria: inclusion criteria: age 18 to 25 years, both male and female, subjects who are willing to participate in the study, throat bend palpable in upper trapezius muscle, and subject with unilateral trapezitis. Exclusion criteria: traumatic neck injury, fracture of cervical vertebrae, and cervical radiculopathy. Outcome measures: pain, cervical range of motion, and neck disability. Pain measured by visual analogous scale, cervical range of motion measured by universal goniometer, and neck disability measured by neck disability index. Procedure: obtaining permission and approval from an institutional ethical committee, explaining the purpose and procedure of the study, and written consent was taken. Study was started with subject who was meet the inclusion criteria. Pre-study VAS and cervical range of motion was measured and NDI was taken. Subject with upper trapezitis was randomly divided into 2 groups. Group A receives strong surge therapy and Group B receive ultrasound therapy. Passive stretching and MFR for upper trapezitis muscle and active neck range of motion exercise was given to the both group. Post-study data was measured and analysis was done. Result was it was analyzed by using SPSS version 26. Here the result is the table 1 shows that when were analyzed from pre-intervention to post-intervention within the group, there was statistical significant difference in VAS, NDI, and cervical range of motion within group A and within group B. There was a clinical significant improvement in both group 2. Here the table 2 shows that when the post-intervention means where the compare between 2 groups, the group A was statistical significant difference in means of the VAS. Okay, here the statistical significance is in group B. Discussion. Present study was conducted on 26 subjects with unilateral trapezitis to find out the effectiveness of the strong surge periodic electrical stimulation and ultrasound in young individuals. The result shows that in both groups, statistical significant on VAS, NDI, and cervical range of motion. But the comparison between these 2 groups, the ultrasound was statistically significant on VAS as compared to strong surge periodic. Thermal and non-thermal effect occur in tissue during the ultrasound treatment by using high frequency acoustic energy during the absorption of ultrasonic wave in the tissue and the reflection among the surface heat energy and provides deep heating. It has been found from ultrasound studies and that ultrasound causes significant increase in the intra-articular temperature. At the same time, ultrasound therapy has analgesic effect, increased nutrition, and also speeds blood circulation. In addition, the micromassage effect of the high frequency sound wave have been demonstrated. The surge periodic current is an application of the therapeutic electrical current to elicit the muscle contraction. Electrical muscle stimulation gives relaxation to the spasm. Increased production of the endorphin is believed to be a consequence of the electrical stimulation. This natural body generated analgesic is produced normally when the body detects a painful stimulus. Researchers has found that the body may be pulled into the increased production of endorphins by non-painful electrical stimulation. The circulatory stimulation is by the pumping action of the contraction musculature, and there is an enhancement of the reticuloendothelial response to clear the waste products. A study by the Service Inde found that both the strong periodic stimulation and self-stretching in less tense position given a clinical beneficial in reducing pain and improving range of motion. However, for improving range of motion, self-stretching in low tense position was found to be more effective. Umid Dunder that concluded that ultrasound therapy is effective in the management of the cervical myofascial pain syndrome. The Brit Sayag Reina concluded that ultrasound therapy are more effective than the TENS on decreasing pain and trigger point in upper trapezitis. Limitation of the study: the sample size was small, the study duration was less, and the regular follow-up was not taken. Future recommendation: future study with a large sample size, with a longer duration of intervention, and with take regular follow-up. Funding: no funding was received from the institute or subject. Conclusion of my study: the present study was concluded that both the intervention given are clinically beneficial in reducing pain, improving cervical range of motion, and decreasing neck disability can be used in the management of the subject with upper trapezitis. However, for reducing pain, ultrasound was found to be more effective than the strong surge periodic. These are my study references. And thank you.
Thank you, Sheetal. We'll proceed with the question answer session. I will request Shamit sir to continue with that. Okay, we'll be moving to our next presentation now. Thank you, Sheetal.
Thank you, ma'am.
I'll be calling Zohri Himani for the next presentation. The title of our presentation is Relationship of Kinesophobia with Physical Activity, Balance and Fear of Fall in Osteoarthritis Knee Patient.
Good afternoon,
From
everyone.
Apollo Institute
Good
of
afternoon,
Physical
ma'am.
College. Yeah, good afternoon.
Shall I start sharing my screen?
Sure, Zohri. You can start.
My screen is visible.
Yes, Zora, your screen is visible. You can start.
Okay. The title of my study is Relationship of Kinesophobia with Physical Activity, Balance and Fear of Fall in ONE Patients. Introduction. The prevalence of
Excuse
ONE
me.
increases with age.
Sorry. Yes, sorry to interrupt in between. I just lost the connection. I had one question to Sheetal. Is Sheetal there now?
Yes, sir. Sheetal, are you there? Sheetal, are you there? Hello?
Yes, ma'am.
Yeah. Okay.
Sorry, I just lost the connection at the end of the your presentation. I have one question for you.
Yes, sir.
So you have used TENS and then ultrasound, right? So did you also
sir. I use strong surge periodic electrical stimulation and ultrasound.
ultrasound? Okay. Did you also give any other exercises with that, or it was just you just gave that isolately?
No, sir, I give exercise MFR, basic stretching of trapezius muscle, upper trapezius muscle, and
Yeah.
active neck exercise.
Okay, so in your conclusion, how do you justify that uh, comparing ultrasound and the Faraday current? How do you justify that with the intervention of other that is involved in the treatment? It is just the effect of ultrasound and the Faraday current,
Yes,
because you
sir.
have because there are effects of the other exercises, the other intervention that you did on the trapezitis, right? So
Yes,
those
sir.
all those treatments are also helpful in reducing the pain. So when you are given combined intervention in all of that, how do you justify that to compare between the ultrasound and the Faraday current in trapezitis?
Yes, sir. I given the all are the exercises in the both group, but they are the more significant in the ultrasound receive subjects as compared to strong pulse periodic electrical stimulation.
Okay. Thank you, Sheetal.
Okay, welcome, sir.
Thank you, sir.
Yeah,
We'll be proceeding
I'm
with.
sorry to interrupt. Yeah, you can continue.
Yeah, no problem, sir. We'll proceed with our presentations. I would like to call Zohra Himani from Apollo Institute of Physiotherapy College for a presentation on relationship of kinesophobia with physical activity, balance and fear of fall in OA knee patients.
Good afternoon, everyone. The title of my study is Relationship of Kinesophobia with Physical Activity, Balance, and Fear of Fall in ONE patients. Introduction to the studies. The prevalence of OA increases with age. OA-related knee pain is leading cause of physical disability in elderly people. Kinesophobia is defined as an extreme fear of physical movement and activity resulting from a painful injury or re-injury. Pain-related fear of movement may cause a gradual decrease in physical activities. Pain affects the activities of daily life in individuals, which leads to severe disability and results in kinesophobia in individuals. Pain in balance and fall problems create kinesophobia, which leads to decrease in functional capacity. There is a strong correlation between the levels of kinesophobia and physical activity in different patients group. Aim of the study was to examine and correlate the kinesophobia with physical activity, balance, and fear of fall in ONE patients. Objectives of the study were to correlate the kinesophobia with physical activity in ONE patients, to correlate kinesophobia with balance in ONE patients, and to correlate kinesophobia with fear of fall in ONE patients. Criteria were the inclusion criteria are the ONE patients for more than 50 years of age and the knee pain lasting for more than three months. Exclusion criteria were knee operations, malignant disease, infectious disease, inflammatory disease, or any knee injection within last 3 months. The outcome measures in the study used were Tampa scale for kinesophobia, International Physical Activity Questionnaire, Buck Balance Scale, Fall Efficacy Scale, Knee Outcome Survey Activities of Daily Life. Materials and methodology. Methodology was cross-sectional study in convenient sampling. Sample size was 41 individuals were included. The study duration was 3 weeks. In general population, people were taken who had ONE. Materials were questionnaires. Procedure. Ethical approval was taken from Institutional Ethical Committee. The study purpose and procedure were explained to the individuals. Individuals who met the inclusion criteria were included in the study. The questionnaires were given to individuals to be filled. All the questionnaires and details were filled by the individuals. Then the questionnaires were collected and analysis were done. Results. The present study correlates the relationship of kinesophobia with physical activity, balance, and fear of fall. It was calculated by SPSS version 26 and Spearman's correlation was used as the data was distributed non-parametrically. Spearman correlation coefficient ranges from -1 to 1. A positive value indicates a positive correlation and a negative value indicates negative correlation. So the Tampa scale with correlation coefficient of IPAC, it was -0.019, which is negligible negative correlation. With work balance scale, it was 0.045, which was negligible positive correlation. With fall efficacy scale, it was 0.093, which was also negligible positive correlation. And with QoS, it was 0.103, which was negligible negative correlation. Discussion was the main purpose of the present study was to evaluate the relation between kinesophobia with physical activity, balance, and fear of fall in ONE patients. In some patients, the pain-related fear leads to general limitations of movement and a sedentary lifestyle because of idea that movement might increase pain or the severity of the disease. Having sensation of knee instability even in people who had no episodes of knee buckling in past 3 months was associated with increased risk of fear of falling and activity limitations in ONE patients. Patients with severe ONE not only were greater risk of falling as compared to the to falls in healthy older adults, but the risk was almost twice in in healthy older adults. This finding may have due to the fact that the most of the patients were suffering from severe ONE, and the most of them had highest level of pain, stiffness, and dysfunction, which made them more vulnerable to instability, muscle weakness, and finally falls. A fear of fall leads to disencouragement that he or she might fall or get injured and promotes himself to reduce the physical activity. The Domage J 2023 study on kinesophobia demonstrated that the moderate kinesophobia is associated with an increased intensity of pain and disability in patients with ONE. In Lavengers et al. In 2012 examined the frequency of fall in 35 patients with ONE and reported that the number of fall was preoperatively was 48.5%. Limitation and future recommendation. Limitations of the study where the sample size was small. Future recommendation can be the large sample size relative to the study. Future studies can be done on the variables like gait pattern, pain, stiffness, reduced muscle strength, buckling of knee, psychological well-being, social activity, and quality of life. Conclusion. The present study consisted of 41 individuals found that there is a negligible negative correlation between kinesophobia with physical activity and knee outcome survey, and there is a negligible positive correlation of kinesophobia with balance and fear of falls. These are my references. Thank you.
Okay. Thank you, Zora. I would like to request Shamit sir to proceed for the question and answer session.
Yes. Yeah, am I audible?
Yes, sir, you are audible.
Yes, sir.
So what are your inclusion criteria of osteoarthritis knee? Are there patients with osteoarthritis knee and other neurological problem, or is it just osteoarthritis knee patient?
It was just osteoarthritis.
Okay, then what do you think about the validation of using work balance scale in osteoarthritis knee? The balance scale
Sir, in some ONE patients, there are balance problem issues also create the fear of fall, and the balance is lost. Work balance scale can be used for ONE patients.
Okay, so the work balance skill that you have used also has patients who just have osteoarthritis knee, right?
Yes, sir.
Okay, thank you.
Welcome.
Thank you, sir. We'll proceed with our next presenter now. I would like to call Vedika D. Goj to present her paper on reliability and validity of Hindi translation on foot function index in patients with ankle and foot problems from MGM School of Physiotherapy, India.
Yes, ma'am. Good afternoon, ma'am. Can you hear me?
Good afternoon. Yeah, you can start with your presentation.
Okay.
Nice. काय नाही पूछ वो क्या स्केल यूज कर मैं किधर कराई बस.
Okay. So can you see my screen?
Yeah, Vedika. We can see your screen.
Good afternoon. So my topic is reliability and validity of Hindi translation of foot function index in patient with ankle and foot problems. So introduction, patient reported outcome measure provide assessment of characteristics of impairment experienced by patients that doctors are unable to investigate directly. Existing information on measurement qualities such as reliability, validity, sensitivity to change is used to assess the clinical value of patient reported outcome measures. Due to the importance of foot in locomotion, foot diseases frequently cause pain and are associated with a reduced capacity to conduct daily activities. Furthermore, there is an increased chance of walking obstacles, accidental falls, and further injuries. Hindi is the national language of India. However, the FFI has not been translated to Hindi, and this shows its need and importance for the population of Hindi speakers in India. Patients will be able to understand the severity of their pain and affected functional impairment, and therapists will be able to identify the areas affected and arrange the procedure accordingly if foot function index is translated into Hindi. The foot function index was created to assess how foot pathology affects the function in terms of pain, disability, and activity limitations. So the FFI is the 23 items self-administered index broken into 3 subscales. The scores are generated for both the total and the subscales. This questionnaire includes 23 items scored from 1 to 10 using the visual analog scale and divided into 3 subscales: pain, a score up to 90, function, that is score up to 90, and activity limitation, maximum score up to 50. So the total maximum score is 230. The FFI is designed to measure both current state, defined as the past week before taking the test, and change in the status. The FFI showed proof useful for both clinical and research purposes. So plantar fasciitis, the most prevalent cause of pain in the inferior heel, is thought to account for 11 to 15% of all adult foot complaints that require medical attention. It occurs in association with running and is widespread among military people. Reliable population-based incidence data are scarce. So the frequency is said to be highest in those between the ages of 40 to 60 in general population and among younger runners. Foot fractures are one of the most prevalent types of foot injuries seen by primary care doctors. They usually affect the metatarsal and toes. Patients usually appear with a variety of signs and symptoms, the most prevalent of which are discomfort and difficulty walking. So ankle sprain injury of the lateral ligament complex of the ankle joint occurs in about 1 in 10,000 people in a day, accounting for a quarter of the sports injury. These 3 are the most prevalent cause of foot pathologies that limit the function of the individual. So the aim of the study is to translate and validate the foot function index into Hindi version and assess its content on Indian population with Hindi speakers with ankle sprain, foot fractures, and plantar fasciitis. So the objective is to translate the FFI in Hindi language to test its validity and reliability. So the need of the study, majority of the people who come to the OPD are Hindi speakers. Only a few of them are able to communicate in English. So FFI has not been translated into Hindi. A Hindi version of FFI can not only provide a valuable assessment for practitioners treating Hindi speaking individuals with ankle sprain, foot fractures, and plantar fasciitis, but it can also help researchers track outcome across research trials, including this group. As a result, it is critical to create a FFI in Hindi to assess ankle sprain, foot fractures, and plantar fasciitis patients. So methodology, the study's place was MGM Hospital, Aurangabad. Study design was an observational study. Study area is tertiary care unit. So duration is 3 months. Sample size was 10 for the pilot study. Sampling technique is convenience sampling. Outcome measure foot function index in Hindi. Both study population, both the genders of age group between 20 to 60 years. Sampling method is simple sampling. Data type of data is primary data, and study material is foot function index, English and Hindi translated version. So inclusion criteria is both the genders are included, age from 20 to 60 years. Participants, those who are suffering with plantar fasciitis, ankle sprain, foot fractures. Okay, participants, those who are willing to participate will be included in the study, and participants who could read and speak Hindi language. So the exclusion criteria is systemic pathologies like rheumatoid arthritis, systemic lupus erythematosus, and multiple sclerosis. So the procedure was the copyright of the derived scale are well informed too with the consent with the respect to the original scale in English version. So the patient will be provided the scale material in the form of document, the chart, or a Google form. Demographic data like name, age will be noted. Outcome measure of FFI will be taken by self-assessment by the subject or individual therapist conducting the test. So the population fitting the required criteria will be approached as per the inclusion and exclusion criteria. The scale will be translated in local language, mother tongue of the study area, that is Hindi, facilitating to overcome the language barrier on both the ends and convenience of the population to understand the severity of the condition as a part of self-education. The scale will be in the form of questionnaire. The patient's level of self-tolerance to pain in relation with his or her pain, difficulty, and disability will be assessed based upon the questions in the scale depending upon the severity of the symptoms and conditions. So the outcome measure, English version of foot function index, is a broadly used scale in patients with foot pathologies. The scale consists of 3 components: disability, difficulty, pain. So the internal consistency range from 0 to 96 to 0 to 0.73. The retest reliability of FFI total and subscale scores range from 0 to 87 to 0.69. So statistical analysis, the purpose was of the study was to find the reliability of the Hindi version of FFI. For this purpose, the data was entered into an Excel sheet, tabulated, subjected to statistical analysis. The average is 34.566 and the standard deviation is 11.66. So the result on the present study, we did a pilot study on 10 individuals who had complaints of foot. We circulated the translated version of FFI Hindi to Hindi speaking patients to overcome the language barrier. So the result is yet to be calculated, and the discussion is we will be testing the reliability, validity of Hindi version of FFI in patients with foot and ankle disorders, including plantar fasciitis, ankle sprain, and foot fractures. So Dr. Shahnaz Basmi ma'am translated and adapted FFI into Hindi language for the patients with foot pathologies. That's study involved only patients with 3 conditions and not those with the other foot ankle problems. Our study will be investigating the reliability and validity of the Hindi version with a greater range of deformities and large number of patients. So future scope of the study's research should be explored in different setting where these issues must be conducted on large number of patients. The study will be working on 3 components, that is disability, pain, and difficulty experienced by the patient to better understand the foot complaint and to overcome the language barrier. So references are this, and thank you so much. Thank you, ma'am.
Thank you, Vedika. We'll proceed now with the question answer session. Shamit sir, I would request you to proceed with it.
So what was the conclusion of your study? This is not completed?
No, sir. It is still in process. We have done pilot study, but the result is yet to come due to some issue. Yeah.
Okay, so the reliability and validity is not out yet with the translation into the Hindi.
Yes, it is in process.
Okay, thank you.
Thank you, sir.
Thank you, sir. We'll be proceeding with our next presentation. I would like to call Pavan Solanki. for the topic prevalence of awareness about scapular dyskinesis in male Indian boxers, an observational study. He's from MGM School of Physiotherapy, India. Pavan Solanki. For prevalence of awareness about scapular dyskinesis in male Indian boxers, an observational study. Okay, so we'll proceed with the next presentation then. The next presenter is Prachi Pragnesh Shah. She will be presenting her topic on an evidence-based effectiveness of cupping therapy on hamstrings, range of motion and flexibility in young individuals. She is from SBP Physiotherapy College, India. Prachi, are you there?
Hello.
Yes, Prachi.
Ma'am, it may take some 5 minutes more as internet connection is poor here. So, will I get some time after that for that?
Sure, Prachi. I would again call Pavan Solanki to present his topic on prevalence of awareness about scapular dyskinesis in male Indian boxers, an observational study. Okay, we'll be moving to our next presenter now. Dr. Tejashwi Kumari Nathubai Patel. She will be presenting her topic on effect of scapular stabilization exercises on upper limb recovery in chronic stroke participants, an experimental study. She is from Savitriben Patel College of Physiotherapy, India.
Am I audible, ma'am?
Am I audible, ma'am? Yes, Tejashwi, you are audible. You may start with your presentation.
Okay, shall I share my screen? It's visible, ma'am?
No, your screen is not yet visible. Yeah, it's visible now. You may proceed with it. Yeah.
Good afternoon, ma'am. Good afternoon, all. My topic is on effect of scapular stabilization exercises on upper limb recovery in chronic stroke participants, an experimental study. Now the introduction is stroke. Is the interruption of the blood flow to the brain leads to the loss of neurological function, leads to the motor deficit like hemiparesis and hemiplegia. In that, upper extremity hemiparesis is a significant determinant of post-stroke disability and quality of life, which impairs the performance of many daily living activities like eating, bathing, dressing, etc. due to impaired shoulder joint complex. So due to the impaired shoulder joint complex, there is a secondary problem such as shoulder subluxation and pain, which suppress the functioning of the upper extremity due to paretic scapular muscles. So improving the scapular stability produces the distal stability and improve the control movement of the upper extremity, which also improve the functional independence. So the aims and objective of the study is to determine the effect of conventional therapy alone on upper limb recovery in chronic stroke patients, and second is to determine the effect of scapular stabilization exercise along with conventional therapy on upper limb recovery in chronic stroke participants, and the third is to compare the effects of scapular stabilization exercises plus conventional therapy with conventional therapy alone on upper limb recovery in chronic stroke participants. Now the methodology. Study design was experimental design. These are the study setting I have used. Sampling was the purposive sampling. Sample size calculation was done using G power 3.1.9.2 version, and the total sample size required was 30, and with effect size 0.9, alpha level 0.05, and power 0.65. Total sample size calculated was 30. And the outcome measure I have used, that is Google Mirror Assessment Scale of Upper Limb Extremity, and the action arm test.
The slide is not moving. It is just on the first page.
Oh, sorry, sir. It's moving.
Tejashwi, start the slideshow presentation.
Is it visible?
Yes, you proceed. You may proceed now.
Okay, I am continuing, starting from beginning or continue with ma'am? Hello, sir.
No, you can continue from where you were.
Okay. Now, inclusion criteria. The subjects with strokes are diagnosed with CT MRI or ascertained by medical reports by qualified medical professional. The subject age for 45 to 65 years. The subjects with 6 months post-stroke, mean mental scale examination was equal or greater than 24, and the Bloomstorm stage of arm recovery of stage 3 to 5. And the exclusion criteria is the subjects who are not able to understand simple commands, subjects who are already receiving scapular stabilization exercises, subjects who are already having any neurological disease other than stroke, subjects who are already having any musculoskeletal disorders, and the subjects with severe sensory and perceptual deficit, if it affects in outcomes. Procedure. After taking ethical approval from Institutional Ethical Committee, screening of the inclusion-exclusion criteria was done, and the 30 subjects were purposely selected, and then informed consent was signed by each participant. Then the subjects was divided into two groups. Group 1, who is taking only alone conventional therapy, and the second group was taking conventional therapy plus scapular stabilization exercises, and the pre-intervention assessment was taken at day 1. With Fugger-Meyer assessment scale of upper extremity and extended research arm test, and the 45 to 65 minute for 5 sessions per week for 4 weeks was done, and after 4 weeks last day post intervention assessment was taken, and the data was analyzed. So now the conventional exercises are stretching exercises for tight muscles, both upper and lower extremity. Active assisted training for subjects who were not able to perform full range of exercise activity. Active movements for subjects who were able to perform tasks, manual extremity exercises, and weight bearing training. And the scapular stabilization exercises, shoulder straightening exercise, shoulder retraction exercise, scapular retraction, and shoulder horizontal abduction, combined with external exercises, external rotation exercises, scapular upward rotation with equation exercise, scapular protraction exercise, scapular retraction with shoulder horizontal abduction extension exercise, external rotation with the shoulder position at 90-degree abduction, and the elbow flexion 90-degree exercise, full elevation of the arm above the head exercises, scapular depression exercise, corner press out exercise, T2Y exercise, and T2Y2W exercise. Now the results. Results were considered to be significant at p less than 0.05, and confidence interval was set at 95%. All statistical analysis was performed using SPSS 2021. After reading taken at for both group at day 1, that is pre, and after the 4th week last day, that is post, and the data analyzing for its normality with Sapro test were found not to be normally distributed. So non-parametric tests were used. In that, Wilcoxon sign rank tests were used to compare the difference within the group at 2 time period, that is pre and post, and the man between U test was used for comparing means between all the 2 groups. Now the comparison within group for group 1, that is the Fugger-Meyer assessment scale and extended research arm test score was significantly higher in the paretic upper extremity after 4 weeks of conventional therapy training alone compared to before the training. And the comparison within group for group 2, in that also the FMA and extended research arm test score was significantly higher in the paretic upper extremity after 4 weeks of scapular stabilization exercise plus conventional therapy compared to before the training. Now comparison between group 1 and group 2, in that revealed that group 2 had a greater statistically significant improvement than group 1. So there was a significantly greater improvement in the function of upper extremity in group 2 compared with group 1. So the discussion. In this study, there is a significant functional improvement after scapular stabilization exercise was performed by individuals with hemispheretic stroke. So some previous studies and some authors given supporting that Mendelitis and Obion suggested that it is important to strengthen the scapular stabilizers in order to restore the function of the distal joints of the upper extremity. And the Nestor et al. Suggested that the functionality of the glenohumeral and scapular muscles should be monitored in a clinical setting. However, evaluation of the scapular stabilizers have been commonly neglected in rehabilitation, despite previous studies indicating that strong scapular stabilizers are among the major factors contributing to functional restoration of the upper extremity. Now, the conclusion. It can be concluded that conventional therapy along with scapular stabilization exercise is more effective than the conventional therapy alone in improving upper limb recovery in chronic stroke participants. Now, the limitations. No follow-up of the participant after stroke, and the results of the study can't be made applicable to any respective population of stroke with at other specific brainstorm stage. And the future scope of the study are the large sample sizes recommended, follow-up of in order to evaluate the effectiveness that is maintained or not, and for what period of time it was maintained. Study can be done on specific brainstorm stage for generalizability at a particular stage. Study can be done on acute and subacute stroke, and in future, any approach for upper limb rehabilitation can be compared with the present approach. Now, these are the references. Thank you.
Tejasvi, can you just go to the slide where you have shown the exercises of conventional and the
yes, sir.
Okay.
Yeah.
So the scapular stabilization exercises, this almost says that this is an active exercise that the patient must do. So you have said that you are going to treat chronic stroke patient, right?
Yeah, sir. And I have taken the brainstorm stage 3 to 5, sir. So patient is started active.
Yeah.
So patient is started active movement, sir.
Okay, so you have only intervened to those patients who have chronic stroke, but then they can move their...
Brainstorm stage, yes, sir. In that also brainstorm stage 3 to 5. So the voluntary movement was started. With some...
Thank you.
Okay.
Yeah, that makes sense. Thank you.
Okay. Thank you, sir. Thank you.
Thank you, Tejasvi. Thank you, sir. We'll proceed with the next presentation.
This is Pawan Solanki from Indian School of Physiotherapy. There, sorry for inconvenience, ma'am. There was a poor connection. Due to this, I couldn't share my screen. Can I present now or later?
Sure. Pawan, you may proceed with your presentation on prevalence of awareness about scapular dyskinesis in male Indian boxers and observational study. You are from MGM School of Physiotherapy, India?
Yes, ma'am. Yes.
Okay, you may proceed with your presentation now.
Okay. Good afternoon, everyone. Myself, Pawan Solanki. My presentation topic is prevalence of awareness about scapular dyskinesia in male Indian boxers and observational study. Introduction. The shoulder function is heavily influenced by the scapula.
Pawan, sorry to interrupt. Please start your slideshow presentation. It's not yet started.
1 minute, ma'am. Ma'am, is it visible?
There is a slideshow option. Yeah, now it's visible.
Visible, ma'am? Hello, ma'am.
Yes, you may proceed with your presentation.
Okay.
It's visible.
It's visible, but then it is not on slideshow mode.
Sir, it is on slide mode.
Slideshow mode. You just
yes, ma'am. In my laptop, it's on slideshow mode. Can I proceed?
That is fine. You can proceed. That is fine.
Okay, sir. The shoulder function is heavily influenced by the scapula. During the humeral motion, it includes the synchronized scapular rotation. The scapular dyskinesia or alteration in dynamic scapular control is present in as many of the 67% to 100% of the athletes with the shoulder injury. The scapular dyskinesia is a general reaction to the painful shoulder condition, and rather than the specific reaction to the glenohumeral stability. The scapular dyskinesia can be commonly seen in boxers and hamper their functional activity in boxing and daily life. The syndrome like scapular dyskinesia has been referred to as a SIG by the Bucard, scapular malpositioning, inferior medial border prominency, coracoid discomfort, and scapular movement. Dyskinesias are all terms used to describe the scapular malpositioning. When compared to the non-over athlete, the overhead athlete had a high prevalence of the scapular dyskinesia than the non-overhead athlete, that is 61%. However, there is the lack of evidence about scapular dyskinesia in boxer, as well as attitude of the boxer toward the physiotherapy rehabilitation. Hence, there is need to investigate the awareness about the scapular dyskinesia in male boxers so that the proper prevention and intervention can be done and injury can be prevented. The aim of the study is to determine the prevalence about scapular dyskinesia in male boxers. In methodology, the study design is observational study. Study population are male boxers in India. Study setting are universal population of boxers from different institute of boxing in India. The sample size are 141. The study population are male boxers. Inclusion criteria is the male boxers, the age between 18 to 36, the boxer who have practiced regularly since more than 2 years, and those are willing to participate in the study. And exclusion criteria are the boxer the age between the below the 18 years. At the procedure, we made the questionnaire to assess the awareness among the boxers about the scapular dyskinesia. There is newly designed Google document administered questionnaire. In the present study, participant demographic data was taken under their name, age, gender, name of the institute, and mail ID. The questionnaire contained awareness of scapular dyskinesia containing 10 questions. The response scale were comprised of the two categories of the yes and no. The maximum score of the questionnaire was 10, and where the yes is interpreted by the score 1 and no by 0. The interpretation of the questionnaire where participants have inadequate knowledge of the score is between 0 to 4 and adequate knowledge between 5 to 10. In the result, there are the variables of the demographic data. We are taking the age, hand dominance, and the level of playing of the player. In the study, 141 boxers were completed an online questionnaire. Below online questionnaire. This is the result of the each questions by the pie diagram. The first question was the boxer doing practice regularly. These are the 87% people says yes by the percentile above the 141 population, and 13% show the no. Second is have a shoulder injury. There are 25% people have boxer have a shoulder injury and 75 has not injury. After the shoulder injury, they took physiotherapy treatment for the shoulder injury. They said 33% people, 33% boxer having yes response. After that, they completed rehabilitation protocol, yes or no. That is 59% are yes and 41% are the no. After that, the question is here about the scapular dyskinesia. 23% response are yes and 77% response are no. After that, aware of long-term complication of the scapular dyskinesia, the 32% of the boxers are saying yes response and 68% saying no. After that, there is weakness in upper back and shoulder during boxings. 58% shows no and 42% shows yes. Then the ignorance toward the exercise and rehabilitation linked to pain, weakness, and other symptoms like scapular dyskinesia. 30% says yes and other are 70 are no. Then do you think you can prevent the scapular dyskinesia? The 56% boxers show yes and 44 say no. Then awareness about the scapular dyskinesia is necessary. The 80% boxers show a yes response and 20% show no. After that, the we summarize each questionnaire of the each boxers, and then we see there is the 32% adequate knowledge about the scapular dyskinesia in the boxers, and 68% boxer has inadequate knowledge about the scapular dyskinesia. Then in discussion, in the present study, the 141 participants from all over the India were evaluated to see how they felt about the scapular dyskinesia in Indian boxers. The scapular dyskinesia is the part of the pathological cascade of the labral injury described by Bukat et al. And Myers et al. Reported higher incidence of the labral lesion in the throwing athletes who had the scapular dyskinesia. The altered scapular positioning or movement allow under stress to occur on the anterior shoulder structure and increase the posterior pill labrum. All the subject chose all the question, which revealed that awareness and interest in the learning about the scapular dyskinesia. After doing the survey, it was concluded that 25% of the boxer having shoulder injury, 33% of the population had received physiotherapy treatment for the shoulder injury related to the boxing, and 66% population of the had left the rehabilitation protocol in between. The boxer's negative attitude toward the physiotherapy Boxers' negative attitude toward the physiotherapy rehabilitation is influenced by lack of evidence on the topic as well as ignorance of the exercise protocol due to the break in the link and the practice. The conclusion, the current study concluded that there is a poor prevalence of the awareness about scapular dyskinesia in male boxers. In the research, 31.20% of the boxers have adequate knowledge about the scapular dyskinesia and 68.74% of the boxers have inadequate knowledge about the scapular dyskinesia. The future scope is the study at the future research can be done by recording the response in the players after the training period by focusing on strengthening on the scapular muscle that commonly go into the weakness due to the overuse, and the research can also be done to the study any significant variation between male and female boxers. These are the references. Thank you. Hello.
Thank you, Pawan. Pawan, we couldn't see your slides in the properly. Only the introduction slide is visible because the slideshow was not. You couldn't switch on the slideshow.
Yes, ma'am. I switched this.
Okay. I would like to request Shamit sir if he has any questions. We can proceed with that.
Hello.
Yes,
Am I
sir.
audible?
Yes, sir.
Yeah. So you said that you intervene the rehabilitation protocol to the boxers, right? So on what basis the rehabilitation?
No, sir. We are not into the protocol. We are seeing awareness about the scapular dyskinesia in the boxers.
Yeah.
Yes. We are not we are not doing any protocol rehab, sir. We are doing questionnaire. According to that questionnaire, we are seeing there the boxers having knowledge about the scapular dyskinesia or not, and having awareness about the scapular dyskinesia. That will help them to reduce these injuries.
Okay, so it was just awareing them about the need of the exercises.
No, sir. We are checking there is a prevalence of awareness. Means they people know about the scapular dyskinesia or not.
Okay.
The boxers.
So what was the conclusion result?
Sir, in conclusion, there is a poor awareness about the scapular dyskinesia in male boxers. That is 31%. 31.20% boxer have adequate knowledge only, and 68.80% of the boxer has inadequate knowledge in scapular dyskinesia.
So all those boxers were injured boxers, right? They were not.
Yes, sir.
Okay, fine. Thank you.
Yes, thank you, sir.
Thank you, Pawan. Thank you, sir.
Ma'am, ma'am, can I switch on now? Can I share my slides now?
Hello.
Yes, ma'am.
Yeah. Is this Prachi?
Yes, ma'am.
Prachi, you did not give your presentation?
No, ma'am.
Okay. Okay, you may proceed with your presentation. Your topic is an evidence-based effectiveness of cupping therapy on hamstrings, range of motion, and flexibility in young individuals.
Yes, ma'am.
From SVP Physiotherapy College. Yeah. Okay.
Is my screen audible? Is my screen visible? Hello?
Yes, Prachi, your screen is visible.
Just wait a minute. I'm just setting that virtual background. Ma'am, I couldn't able to set my virtual background. Is it okay? Hello?
You just have to share your screen. The slides you have to share. You don't have to open your video.
Okay. Is my slide visible?
Yeah, it's visible now. You may proceed.
Okay. So my topic is an evidence-based effectiveness of cupping therapy on hamstring range of motion and flexibility in young individuals. I'm an postgraduate student from SV Physiotherapy College, and thank you for giving me this opportunity. Okay. So the introduction of my studies, hamstring injury is a third most common orthopedic problem after knee or ankle injuries, and often have a long recovery time and chances of re-injury in sports. Hamstring inadequate extensibility is one of the leading causes for hamstring pathology and many other problems like low back pain, work and sport specific injuries. Ma'am, is my sound visible? Sorry, am I audible, ma'am? Hello?
Yeah, you are
Yes.
audible. Yes.
Hello.
Yes, Prachi, you are audible. You are audible. Hello. Yeah, we'll start with our further presentations for now. Prachi might be facing some technical issues. So we will proceed with our next presentation, which is an e-poster presentation. For that, I would like to call Sayyida Samiha Tartil. The topic is immediate effect of craniosacral therapy in a patient with non-specific low back pain, a case report.
Hello. Hello.
Yeah, Sayyida.
Hello,
Yeah,
ma'am.
Sayyida.
Hello. Can I share my screen, ma'am?
Sayyida, can you just wait for a moment? There has been some misunderstanding. Dr. Vrushi Bhatt, I'm so sorry.
Yeah,
I would
ma'am.
like to call upon Dr. Vrushi Bhatt for her
Yes.
presentation on the topic calf pain common differential diagnosis and its physiotherapeutic management, a narrative review. She is from Ahmedabad Physiotherapy College, India.
Ma'am, am I audible?
Yeah, Vrushi, you are audible. You may start your presentation now.
Yeah. So is my screen visible?
Yeah, it's
yes, it is.
visible.
Okay, yeah. So my topic is calf pain, common differential diagnosis and its physiotherapeutic management, a narrative review. So let's start by what is a narrative review. Narrative review is one of the type of review of literature, and its purpose is to identify few studies that describe the problem of interest. This type of study provides description of literature of review without using any quantitative method. So I've done likely introduction. There are many conditions which may have a common complaint of calf pain, which if not diagnosed properly, it may lead to problems with both the patient as well as the therapist if the cause is not found. So calf pain comprises of gastrocnemius as well as soleus, where gastrocnemius is superficial, median and lateral head arising from femoral condyle, while soleus is deeper, arises from upper fibula and medial tibial border. So moving on to the clinical perspectives, there can be injury to musculotendinous junction, intermittent episodes of cramping pain, delayed onset of muscles, that is DOMS, and biomechanical factor, greater subtalar pronation. Moving on. I've taken 4 differential diagnoses and accordingly new techniques, and I've quoted everything with the reference. The first one is the muscle strains, muscle contusion, muscle cramp, and myofascial structure, if any involved. Muscle strains. Calf muscle strain. According to the article published in 2017, calf strains are seen widely across the sports having high speed running such as football. So calf muscle strains of the highest tissue injuries incidences, that is 3 per season club, and reoccurrences in 16% in the Australian rules football. According to article which is published in 2009, which says gastrocnemius versus soleus strain. So it is very difficult to differentiate whether the strain is in the gastrocnemius or soleus. So the method by which we can do is the more common strain is seen in the gastrocnemius because it is a 2-joint muscle and is present with fast twitch muscle fiber, and due to its biarthroidal architecture causing excessive stretch and rapid forceful contraction of the 2-type muscle fiber results into strain. To identify, palpation method is used, strength testing is done, and stretching is required. Tenderness at the medial belly or musculotendinous junction typically shows gastrocnemius strain, whereas lateral tenderness shows soleus strain. So the new therapy which I have mentioned in this is the Tecart therapy, which is also known as capacitive and resistive energy transfer. According to article, multi-center study on Tecart therapy in sports pathologies, which is conducted in Milan, Italy. It consisted of 116 acute chronic musculoskeletal tendinous injuries in which objective was to measure reduction in the pain and Tecart system, which enables the production of an endothermic effect. So basically, it is a electrotherapeutic modality which has the concept of thermotherapy and thus causes the healing. It is believed that action depends on the deep endogenous hypothermia and probably on the increase of energy potential of the cellular membrane. So they concluded that with regard to the interference, with the return to the normal sports activity, majority of subjects, 9 acute and 6 chronic, were able to go back to the training sessions relatively quickly compared to the normal recovery time. Now moving on, muscle cramp. So another article in 2018, it is the muscle cramps on comparison between 2 hypotheses. So it is believed that there are two hypotheses. Muscle cramp can be due to dehydration, and the other one is that it indicates that action potential during muscle cramp are generated in motor neurosoma, likely accompanied by an imbalance between excitatory from muscle spindle and decreasing inhibitory driven from Golgi tendon organs, concluding that there seems to be the problem at the spinal involvement rather than the peripheral excitement of the motor neuron. So the cramps can only be prevented. So for that, we can give electrotherapeutic modalities such as TENS and IFT. So there is an article, Electronic Muscle Stimulation for Strength, Athletic Performance and Recovery by Derek M. Hansen, that giving modalities, it helps in cramp prevention, helps in settling down the spasm in 1 to 3 days, the low frequency of pulsing cycles that work the muscles to bring down the muscle tone, and the use of external electrostimulation gives us jump start to the healing process. Now moving forward to the myofascial structure. So the article suggests that overuse injury result of pathologically altered myofascial force transmission. It says that the body structural tissue continuity and existence of substantial force transmission in local abnormality results in excessive or reduced force transmission, which is compensated by symptomatic tissue region. The tight multi-level linkage between the structure and muscle and fascia explains the change of muscle mechanical behavior will always affect the fascia. Similarly, for that, I've taken a method which is ISTM, which is instrument assisted soft tissue mobilization therapy. It is used in physiotherapy nowadays. It's an article published in 2013. Case study, treatment of patient with postnatal chronic calf pain utilizing the instrument. So a lady, 35 years female, had calf pain during the last trimester of her delivery. And then she was given 9 sessions of this ISTM, and she had had good results after receiving the therapy. Next, moving on to muscle contusion. According to the article by Novel Muscle Contusion Therapy Model and Repair System by Daniel Corbin, Boston University in 2019, skeletal muscle injuries is recorded most often, and skeletal stem cells or satellite cells are mesenchymal cells which derive cells that exists between basal chymal lamina. After a traumatic injury, the satellite cells responds to influx of signaling from immune cells, tension and myogenic proteins, differentiation into myoblasts for repair of the tissue damage. And a very beneficial technique is kinesiotaping, which has an article itself. Effects of kinesiological taping on epidermal dermal distance, pain, edema, and inflammation after experimentally induced soft tissue trauma by Nihan Kafa in 2015. They concluded that after soft tissue trauma, it is histologically shown that kinesiological taping decreases epidermal dermal distance and may reduce the sensation of pain, edema, and inflammation for better, faster, and comfortable tissue healing with protection of soft tissue integrity. Kinesiological taping may be valuable treatment for after the tissue contusion. Thank you so much.
Thank you, Rushti. I would request Shamit sir to proceed with the question answer session.
So that's a narrative study, right?
Yeah, sir.
So where do you see narrative study in the level of evidence level?
Sir, it is a very low level study. It is the basic study. And from that study, these can be used in the review of literature. So they give base to the higher level of study.
So have you also gone through any of the higher level study on the same topic?
Right now, sir, for this topic, I have not gone through. Like we can go for the systemic reviews and all.
Yeah. Thank you.
Thank you so much, sir.
Thank you, sir. Thank you, Rushti. Next, I would like to call again Prachi Pragnesh Shah to give a presentation on an evidence-based effectiveness of cupping therapy on hamstrings, range of motion and flexibility in young individuals. She is from SBP Physiotherapy College, India.
Yes.
Prachi, you may proceed.
Yes. Is my screen visible? Hello?
Yeah, the screen is busy. Yeah, it's fine now.
Hello? Okay. So, from methodology part, from where I've stopped, I'm continuing from that. So this articles were selected using data. So Google Scholar mainly consists of random trial, experimental trial, pilot randomized control trial, published from 2017 to 2021. And in the study, we organized literature as follows: mapping of theoretical aspects of physiotherapy treatment,
for hamstring tightness, then some cupping therapy on hamstring range of motion and tightness. So the result of our study is in 2017.
Ma'am, your voice is not clear.
Author J. Kim study design.
Prachi, your voice is not clear because of
now
the
it is clear.
Yeah, right now it's clear, but it's in middle it's like breaking.
Yeah. Is it clear now?
No, Prachi, it's still not clear.
Okay. Hello? Now is it clear?
Yes. Let's proceed.
Okay, the study design is randomized control trial and it uses electronic data for motion, algorithm, and maximum voluntary contraction. For that, electromyograph was tested. And patient characteristics. Healthy 30 college subjects were selected, and which was voluntary agreed, and whose lower limb muscle pain and restriction in range of motion, backache, open wounds, this all should not be there. Such type of patient was selected and intervention was given randomly in crossover manner to receive static stretching and fire cupping. The results were cupping therapy has much more positive effect on flexibility, pain threshold, and muscle contraction as passive stretching. So both were effective, but cupping therapy shows more effects than passive stretching. Then in year 2020, pilot randomized control trial was it was studied by RJ, and the outcome measure which was selected was digital motion, perception of functional ability questionnaire for evaluating function, global rating of change for improvement in treatment effectiveness. Were 17 college athletes were mainly they have selected, which have pain, tightness, decreased strength, and flexibility, and which are voluntary participated. Intervention was randomly assigned to receive a self-myofascial release and cupping therapy. The results were, this finding suggests that both treatments are beneficial in increasing hamstring length, but patient felt an enhanced treatment effect using cupping over self-myofascial for perceived benefit to hamstring flexibility. And in year 2021, Tabassum Khan, he conducted a randomized control trial in which he have taken outcome measure like a passive straight leg raise test, active knee extension test, sit and reach test. And patient characteristic were 48 individuals were randomly allocated into 3 groups. Age range was between 8 to 30 years. Hamstrings are whose hamstrings are tight, and passive SLR range was between 30 to 70 degrees. And intervention was divided into 3 groups. First group was given static stretching, second group was given self-myofascial release, and third was given cupping therapy. And the results was, again, the cupping therapy is effective in improving passive straight leg raise. And so the discussion of my study is, according to my 3 articles which I've mentioned, cupping therapy is more effective as compared to static stretching, and as well as compared to self-myofascial release technique in improving range of motion and flexibility. So the conclusion of my study is, cupping therapy along with other conventional therapy is effective in improving hamstring flexibility and range of motion, but future study is required to check its efficacy in inactive and older individuals. These are the references of my study. Thank you.
Thank you, Prachi. Shamit sir, would you like to proceed with the question answer session?
Yeah, Prachi, what are the evidences of using cupping therapy in hamstring? Are there any recent advances that has positive impact of cupping therapy on musculoskeletal conditions? High level studies?
So high-level studies for cupping therapy are very. I've got very studies about cupping therapy, especially for hamstring tightness and improving its flexibility. Other studies are there for improving the low pain and for shoulder range of motion and all. But for hamstring, it is very scarcity, and other high-level studies like meta-analysis and statistic review also are not there for hamstring tightness.
Like as we all know that whenever we are doing passive stretching, there is elongation of muscle fibers, right? Which ultimately is going to increase the hamstring flexibility. That is general understanding. So what do you think cupping actually does physiologically in the muscles, which is going to create more range of motion or flexibility? Did you understand my question, Prachi?
These are muscle as a check. Can you repeat it for me? Hello?
Yeah.
Sir, I can't hear you.
Yeah. Did you understand my question, or should I repeat it again?
Sir, can you repeat it?
As we all know that the passive stressing technique elongates the muscle to the micro level, which is ultimately going to increase the flexibility of hamstring. Likewise, what physiological changes do you expect in muscular level with the cupping therapy?
It improves blood circulation, and it improves contractibility as well as the strength of muscle while stimulating the end products like the toxins like free radicals and another ionic imbalance are there that can be corrected, or it improves because of cupping.
Thank you, Prachi.
Okay, sir.
Thank you, sir. Thank you, Prachi. Now we'll be moving to our next session, that is the e-poster presentation. So the time allotted for this will be 5 minutes to each of the candidates. So I would like to call upon Sayyida Samiha Tartil to present her e-poster on immediate effect of craniosacral therapy in a patient with non-specific low back pain, a case report. She is from MGM School of Physiotherapy, India.
Hello.
Yes, Samia. Sayyida. Yeah.
Can I share my screen, ma'am?
Sure, sure. You may proceed.
Hello.
Yes, Sayyida.
Is it visible, ma'am?
No, not yet.
Is it visible now?
No, it's still not visible. There is a share screen option below. Try clicking on that.
Ma'am, is it visible now?
No, not yet.
Ma'am, can I get 5 minutes to do?
Okay, so now we'll be proceeding with our next presenter then.
Okay.
Okay. We will be proceeding with our next presenter. I would like to call Manju Bhashini for her e-poster presentation on the topic effectiveness of proprioceptive exercises of osteoarthritis for osteoarthritis knee patients. She is from Meenakshi Academy of Higher Education and Research, India. Manju Bhashini, are you available? Manju Bhashini for her e-poster presentation on the topic effectiveness of proprioceptive exercise for osteoarthritis knee patients. She is from Meenakshi Academy of Higher Education and Research, India. Okay, moving on. Manju Bhashini, are you available?
Yes, ma'am. Good afternoon, ma'am.
Good afternoon. You may proceed with your e-poster presentation.
Yes, ma'am. Yes.
Hello.
Yes.
Hello. Ma'am, this is Sayyida Samia Tartib. Can I start my presentation?
Sayyida, you have to wait. We are right now, there is another candidate right now.
Okay,
Wait
ma'am.
Manju Bhashini, are you ready with your presentation?
Ma'am, she can proceed, ma'am. I'll join up.
Okay. I'm calling Sayyida Samiha Tartil for e-poster presentation on the topic immediate effect of craniosacral therapy in a patient with non-specific low back pain, a case report. She is from MGM School of Physiotherapy, India.
Is my screen visible, ma'am?
Yes, it's visible. You may proceed. You have 5 minutes to present your e-poster.
Okay, ma'am. Good afternoon, sir. This is Sayyida Samia Tartil. I am from MGM School of Physiotherapy. Today, I am presenting the e-poster on immediate effect of craniosacral therapy in a patients with non-specific low back pain, a case report. So we'll see the case description. The subject of this case study was a homemaker who had been suffering from chronic intermittent low back pain from a year. She is 40-year-old housewife. She went to the orthopedic department with a recent recurrence of discomfort and was prescribed with NSAIDs as well as advised for the physiotherapy treatment. In the physiotherapy department, the examinations were performed and the patient had grade 3 tenderness at L4 and L5 spinous process. She had bilateral iliopsoas tightness, Faber test was bilaterally positive. The measurement for finger to floor test was 28 centimeter. Pre-therapy score for pain by NPRS for forward flexion was 8 out of 10 and for floor sitting was 5 out of 10. Now patient position for the treatment is supine lying position, arm by the side and neck in neutral position. Procedure. The therapist will usually treat you in a quiet room. Then after the proper history taking, the therapist will assess by proper history taking. The therapist will assess by information which is gained in motion testing and by the application of palpation method of fluid direction and tissue structures to assess the existence of possible disruptions and a restriction in a muscles. Then the therapist will apply just 5 grams of pressure on your lumbar vertebra and then on the paraspinal muscles, which is in the disturbed area of the patient. The result shows that the patient will feel relaxed and there will be the sense of softening in her back. The graph 1 shows that post-treatment pain score is 5 out of 10 for forward flexion and 3 out of 10 for the floor sitting. The discussion of this case report is Mrs. Syed had considerable benefits in terms of pain relief and spinal mobility. As we have started from L2 vertebra, the reasons is sympathetic nervous system because it is believed that the system which is responsible for flight, fight, fright of our body, which puts the body in stress. CST is based on the theory that controls movements at the cranial sutures of the skull, negatively affects the rhythmic impulses transported through the cerebral spinal fluid from the cranium to the sacrum. The hands of the therapist gives the piezoelectric effect to the patient's body. The central and autonomic nervous system are improved through the craniosacral therapy, which promotes the relaxation well-being. CST is used to improve the craniosacral rhythm by biological processes through boosting variant self-regulation, self-correction, and self-healing. The therapy combined with the home exercises and ergonomics counseling could be good for a housewife like her who cannot make it to the physiotherapy on a regular basis. Conclusion of the study is, for the immediate relief of persistent intermittent low back pain, craniosacral therapy can be utilized as an adjunct to traditional physiotherapy. CST is an alternative therapeutic method that aims to relieve constraints surrounding the spinal cord and brain, allowing the body to function normally again. The limitations of the study is the result of this case study cannot be extrapolated to a larger sample size because it is a case study. More research is needed to better understand how to choose the craniosacral therapy and how effective it is over the time. Here are the references at the end of this case report, and thank you so much for your time.
Thank you, Samiha. We'll now proceed with the question answer session. I would like to request Shamit sir. Shamit sir, are you there? We would like you to proceed with the question answer session. Okay, thank you, Samia, for your presentation. I would now like to call Manju Bhashini for a e-poster presentation on the topic effectiveness of proprioceptive exercise for osteoarthritis knee patients. Manju Bhashini, are you ready? Okay, proceeding with, I would now like to call upon Preeti Jasantha
for our e-poster presentation on the topic Effectiveness of Core Stability Exercise for Knee Joint Osteoarthritis.
Is it visible, ma'am? Good evening.
Yeah, Preeti, you can proceed with your presentation.
Okay. Good evening, one and all. My poster presentation is about effectiveness of core stability exercise for knee joint osteoarthritis. So introduction. So knee joint, so it is a weight-bearing joint that is often affected by osteoarthritis, which is a degenerative disease. So this disease, it is characterized by pain, joint stiffness, crepitation, synovitis, or without joint fluid effusion, and there is a decrease in functional activity. So the muscle atrophy will worsen the stability and function of the joints. So this muscle weakness, it is related to the pain, which lead to the physical dysfunction. So here we can see some statistics. That is a prevalence of osteoarthritis knee. It can be seen in India. So the core stability exercise. So the core means that it is a lumbopelvic hip complex. So the core, it maintains the proper muscle balance throughout the human kinematic system. So this core stability exercise, this is used to maintain a good posture in motion and be the basis for all the movements of both arms and legs. So it is an exercise to improve the neuromuscular ability. So the core, it is the source of force production and as the kinetic chain which transfer and control the motion to the distal part of the body. So here we can see some types of core stability exercise. So that is a seated abdominal contraction, then seated oblique twist, leg lift, bridge exercise, and lying spinal rotation. So the procedure of core stability exercise is, so the core stability training is intended to train the muscle, which is related to the balance of the core in our body. So it can increase the muscle strength. So it improve the postural balance. So specifically, it can be seen in elderly patients. So this exercise, it can be done 4 to 6 weeks. It can be given 3 times per week. So here we can see some evidence of core stability exercise in osteoarthritis knee treatment. So here the author, Dab Holkar, so in his study, he took the 19 patients with OA knee. So he has given some core strengthening exercise, which is assessed by using the pressure biofeedback apparatus. There is a significant correlation of core stability measures with functional activity level in OA knee. So next, Chebi Tikuna is the author. So he took the 20 female patients between the age group 16 to 40 years old. So he specifically he took the patellofemoral pain syndrome patients. He gave the additional core exercise strengthening. The duration is 4 weeks. Then he saw the significantly higher improvement in the intensity of pain and dynamic balance. And next one is Hoglund. He took the 10 females with patellofemoral joint OA. So then he gave the hip strengthening and core stabilization exercise for twice a week. They have reported that they can see the improvement in pain, then aerial activities, sports activity, and quality of life all improved within the 6 weeks. So the effect of core stability exercise in knee, so it improves the coordination and stability of the trunk, pelvis, hip, and knee by stimulating the crucial muscles of the lumbopelvic hip complex and periarticular muscles of the knee. Then it developed the work of dynamic muscular with occurrence. So that is coordinated and concomitant concomitant contraction of these muscles. So it provides the rigidity, so which support the trunk. So it has been resulted in reducing the intradiscal pressure and will reduce the work load of the lumbar muscle and lower extremity. So here the conclusion is by giving.
Sorry to disrupt. Your time is over now.
That's all,
Can
ma'am.
you conclude
Conclusion.
it?
Yeah, ma'am. Conclusion, ma'am. So here the conclusion is by giving the core stability exercise, we can see the significant in reducing pain and improving functional physical functions in patients with osteoarthritis of knee. Thank you, ma'am.
Thank you, Preeti. We'll proceed with the question answer session. I would request Shamit sir to proceed with it. I would like to request Shamit sir to proceed with the question answer session. Okay, thank you, Preeti.
Thank you, ma'am.
Okay, moving on. With our next presenter, I would like to call again Manju Bhashini.
I'm sorry, ma'am. I had some network issues, ma'am. That's why.
Manju Bhashini, are you ready with your e-poster presentation?
Yes, ma'am.
Okay, I'm calling Manju Bhashini for her e-poster presentation on the topic effectiveness of proprioceptive exercise for osteoarthritis knee patients. She is from Meenakshi Academy of Higher Education and Research, India.
Ma'am, is my screen visible, ma'am?
Yes, it's visible. Can you zoom in your screen or turn on the auto rotation of your phone?
Yes, ma'am. Yes, ma'am.
Manju, your time starts now. Can you start with your presentation?
Good afternoon, everyone. My topic is on effectiveness of proprioceptive exercise for osteoarthritis knee patients. Introduction. Osteoarthritis is most common in the knee joint, which leads to degeneration of the joint cartilage and changes in the soft tissue. It is characterized by pain, stiffness, swelling, crepitus, weakness of thigh muscles, reduced joint motions, and proprioceptive deficits. Older age joint injuries, repetitive stress on the joint can be the risk factors for osteoarthritis. Also, overweight, obesity are well known to increase the risk factor of risk of osteoarthritis by mechanical load on weight-bearing knee joint. Proprioceptive exercise training. Proprioceptive training improves knee functions in osteoarthritis. The types of proprioceptive exercises includes one-leg balance exercise, toe walking, hawk squat, straight lunge, and side lunge. These exercises can be done for 6 weeks with a frequency of 3 times a week. Proprioception and knee osteoarthritis. Proprioception derives from the proprioceptors in skeletal muscles, ligaments, tendons, and joint capsule. Helps in stabilizing a joint during static and dynamic functional tasks. With the progression of knee osteoarthritis, proprioception could also be reduced. So, generally, reduced proprioception in patients with osteoarthritis have weak thigh muscles, and also they have limitations in walking and dynamic balance. Additionally, impaired proprioception could be a cause of knee joint pain or activity limitations in knee osteoarthritis. Effect of proprioceptive exercise in knee. Proprioceptive exercise training could prevent impact loading of the joint, and it could also prevent improve strength and balance at the same time. Improves the joint position sense with patients in patients with knee osteoarthritis. So the conclusion is proprioceptive exercise is effective in reducing pain and improving joint function in patients with osteoarthritis of knee. So these are the pictures of the exercises, which includes one leg balance exercise, toe walking, hop squats, straight lunge, and side lunge. So there are also evidences for this, but I'm not mentioned here. And that's it now.
Thank you, Manju, for your presentation. I would request Shamit sir, if he is here, to proceed with the question and answer session.
Samit sir is joining right away. Just a second. Moderator, how many presenters are still remaining? Moderator. Who is the moderator here?
Yeah. Hi, Amna. So how many presentations are there?
Sir, at least 4 more poster presentation are there, and 1 video presentation will be there.
Okay.
Sorry, sir, not 4. It's 3 poster presentation and 1 last video presentation.
Okay. Okay. Thank you.
Next e-paper presentation can be started. Those who are remaining for the e-paper presentation, you can start now.
The students who are okay. Starting with the next e-poster presentation.
I would like to know, did Fatima and one more, what is her name? Fatima and did Fatima present today?
I'm Swati from Meenakshi College of Physiotherapy presenting e-poster presentation.
No, I'm asking, did Fatima present today? She was present today in oral presentation.
No, she did not give a presentation today.
Okay, fine. Okay, proceed with the e-presentation and finish it up as soon as possible.
Just a minute. Starting with our next e-poster presentation, I would like to call upon Swati.
Yes, ma'am.
For an e-poster presentation on the topic vibration therapy in management of DOMS. She is from Meenakshi Academy of Higher Education and Research, India.
Is it my slide is visible, ma'am?
Yes, kindly proceed with your presentation now. You have 4 minutes further.
Yes, ma'am. I'm Swati from MPT second year, Meenakshi College of Physiotherapy. My topic is about vibration therapy in management of DOMS. So what is DOMS? It's delayed onset of muscle soreness. It's an exercise-related muscle pain and stiffness occurs several hours to days develops after excessive unaccustomed exercise. So what causes DOMS? DOMS usually caused by excessive lengthening exercise due to increased intensity or due to volume of training or first time of training or alter the exercise schedule, new physical activities is implemented. Then what are the mechanisms of DOMS after exercise? So DOMS cause, particularly if the exercise prevalent to eccentric component can result in follows, like muscle ruptures, microscopic lesion, actic myosin separation, and reflex theory. Then effects of whole body vibration in DOMS. It enhances neuromuscular performance. It is effective in flexibility and explosive muscle power, and it increases the muscle strength, range of motion, and blood flow. It also reduces the joint pain. So the result of this is the vibration therapy is more effective in management of DOMS. Yes, ma'am.
Are you done with your presentation?
Yes.
Okay, thank you, Swati. We'll now proceed with the question answer session. Shamit sir is available with us now.
I think problem with the connection. Can I just see the conclusion slide of Swati?
Yes, sir. So this is my presentation, sir. Conclusion is the vibration therapy is more effective in management of DOMS.
I'm still not able to see the slide.
Slide is visible, sir. It is vibration therapy in management of DOMS. It's an e-paper presentation, sir. E-poster presentation.
Poster, right? But then I'm not able to see any.
Give my cell phone.
अठरावाला वो है ना कविता शिरोल पे कविता शिरोल
My slide is visible now.
So can you see her slides now, Shamit sir?
Okay, now you can stop your presentation and next poster presentation can be started. Moderator,
Thank
please
you.
call the next presenter.
Thank you, ma'am.
Sure, ma'am. Now calling upon the next presenter, Payal Prajapati, for an e-poster presentation on the topic Prevalence of Upper Cross Syndrome in Physiotherapy Students, a cross-sectional study. She is from Ahmedabad Physiotherapy College, India.
Yes, ma'am.
Payal, you may start your presentation.
Is it visible, ma'am?
Not yet. Yeah, now it's visible. You may start.
Okay, myself Payal Prajapati from Ahmedabad Physiotherapy College, MPT second year student. So the title for poster presentation is Prevalence of Upper Cross Syndrome in Physiotherapy Student, that is cross-sectional study. So the introduction, as we can see in figure, it is characterized by muscular imbalance between tonic and physic muscle, which is the main reason for developing this syndrome. It was invented by Dr. Valmadri Zanda. It is becoming more dominant in students due to poor posture leading to over-facilitation of pectoralis major and upper trapezius.
Payal, you are not audible.
Hello.
Yes, you are not audible.
Can you keep your speaker near your mic if you are using your headphone?
Hello.
You are not audible, Payal, properly.
Hello.
Keep the speaker near your face, near your mouth.
Now am I audible?
A very low voice is coming. That's why I'm saying.
Hello. Now, ma'am.
Payal, you may proceed.
Okay. So the introduction, upper cross syndrome is characterized by muscular imbalance between tonic and physic muscles, which is the main reason for developing this syndrome. It was invented by Dr. Valmadri Zanda. Upper cross syndrome is becoming more dominant in students due to poor posture leading to overfacilitation.
Payal, this is last chance for you. Kindly put your mic near you. You are not audible.
Hello.
Yes, keep your mic.
Hello.
Yes, keep your mic near to you.
Hello. Now it is audible.
No, it's not audible.
Hello. Hello.
Moderator, I request you to ask the next presenter with the e-poster.
Hello.
Payal, we'll stop your presentation. Since your voice is not audible, we are moving to the next presenter now. Now I would like to call upon Aditi Dashwandi for a video presentation on the topic Effects of Ballistic Six Exercise Protocol on Throwing Performance of Overhead Athletes and Evidence-Based Study. She is from Government Physiotherapy College of India. Aditi, are you available? Aditi Dashwandi from Government Physiotherapy College of India. Effects of ballistics exercise protocol on throwing performance of overhead athletes and evidence-based study. She'll have a video presentation on that.
હેલો ના બ્લૂટૂથ છે જોડે જ છે માઇક જોડે રાખીને જ બોલું છું અને એકદમ અહીંયા બહાર જ બેઠી છું હું હજી
Payal, can you mute yourself?
Moderator, if there is no presenter, am I audible? Moderator, if there is no presenter, we can proceed further with the keynote speaker.
Sure,
so
ma'am.
we'd like to wind up with the presentation, and everyone is requested to join in the main room. All of them can break out from another room and they can join the main room. The last keynote speaker will be presenting over. After that, we'll announce the winners. Thank you.
I would now like to call upon our keynote speaker, Dr. Diksha Singh. Dr. Diksha Singh is a women's health physiotherapist and a PFM specialist at Perfect Teen Maternity Rehab and Pelvic Floor Physiotherapy Clinic. She did her Masters of Physiotherapy in the field of Obs Gynec at Medical College Bhubaneswar, certified in diet, mental health and nutrition by Deakin University. Her area of interest are aerobic exercises, antenatal, postnatal exercises, author, blogger, constipation counselor, diet plan setter, dry needling, gynecology sessions, etc. She was awarded with Young Physiotherapist and Physiotherapy Phoenixes.
Yeah, can I join?
Yes, ma'am. Sure, ma'am.
Yeah. So, hello everyone. I'm Dr. Diksha Singh, author of book It's All About Pregnancy and It's All About Periods. And sorry for this inconvenience due to network issue. So, without waste of time, we'll start with my topic for today is role of physiotherapy in female reproductive cycle. So when we talk about the female reproductive cycle, what is our main intention? First to know about what is like going with the muscle, and as a physiotherapist, what is your chief concern? We have to deal with the pain management and the strength part of the muscle. So basically, you can see this model. This is like pelvis is the most central part of the body here, and here it comes the second model. Here comes these muscles. These are your pelvic floor muscle. Basically, they help in your organ support, your sexual activity, your sphincter. So these muscles, you are not leaking. So these are the muscles which supporting your female reproductive organ, that is your uterus, ovary, and fallopian tube. This is inside it. So as you can see, these lining, endometrial lining. Each month, every month, a woman from menopause to menopause, like developing dead shedding off if you're not getting pregnant. Hello. Hello. So when we talk about the female reproductive cycle, this is the 4-stage cycle. We start with your menstrual phase. Excuse me.
Sure, ma'am, you continue. Somebody was unmuted actually.
Okay, actually. So, sorry. So this is like the 4-phase cycle is there of the female, in which the first phase cycle is a menstrual phase cycle, which is everyone is aware about the menstrual cycle in common term. Then there comes the second cycle is your follicular phase. In the first phase, you are like shedding off your endometrial wall and everything is declining from your hormones to your pelvic floor muscle. This muscle is due to shedding of your muscle and due to declining level of your pituitary hormone, that is FSH and LH. These are become weak. The tone of the muscles is become weak, due to which overcontraction and due to this help in evacuation of your menstrual fluid. These muscles will create cramp in your core muscle. This is your transverse abdominis and your pelvic floor muscle including. So this pain, for this pain or this cramp, the women is seeking a physiotherapy help. So how you can help? We just in case of menstruation, when she is like having low tone, and when comes the luteal phase, the 4th phase, there comes the muscle. The graph is like this. It is like declining, then rising again in the luteal phase. So from declining to rising, you have to work on the strength of the muscle. From the first phase, the muscle is at lowest level, and in the next phase, it is at the highest level. So when you are menstruating, a woman is menstruating, we have to work on the strength of the muscle. Means we have to go for more Kegels. And when she's like not menstruating, she's preparing for the next cycle, then we have to go for more relaxation. So these are the two conditions we have to work as a physio. We have to like correlate. And as a therapist, as a standard therapist, you can just ask your every woman around you to have your MMS card, that is your monthly menstrual cycle card. That is basically you can just cover up with your how much the duration of your menstruation is going, how the strength of the muscle is there, how the cramp and the color of your that menstrual fluid, and the amount of days. If you're bleeding from 2 to 7 days, or only for 2 days, or more or less than 2 days, the amount of flow, are you heavy floating is there or the low floating is there. So we have to seek a card and just track your menstrual health with the help of apps, or you can just use the Excel sheet or your calendar, home calendars you can use. Just seek for with the help of smartwatch too, you can just seek the calendars when your menstruation is next is going on, after 28 days, after 30 days, or after 42 days, or is it regulatory or not. So as a physiotherapist, what is your introduction in a women's health? So in a women's health, basically, because we are talking on your menstrual part, your female reproductive cycle, that is your menstruation, follicular, your ovulation, and your luteal phase. The 4 phases we are talking about. So this is the 4-phase cycle. You can see in the first phase, we started with the low cycle, low muscle, then the rising level is there, and again dropping if you're not getting pregnant. So as a physiotherapist, we are having a key role in the strengthening and the relaxation of your pelvic floor muscle, your subsidiary muscles like piriformis, your obturator internus, externus, your glutes muscle, and basic number of muscle depending on the shape and size of the female body. Which shape and size she is having, or is she obese or is she lean body. So it will depend totally on as every woman is different. So her cycle is similar in some manner, but it can fluctuate according to the physiological demand of the body. So this all is going on because of the lifestyle we are seeking and the hormone changes. So we have to, as a physio, we have to just counsel them, educate them, and we have to tell them, okay, is it normal or is it common? Or if it is common, but it is not normal, we have to clear this data. So as a physio, we have 2 roles. First is your general role. You can just work on the strengthening part only. And in the second part, we have to work from electro to the pain management. You can just choose for TENS on the required area, required surface. If she's having the pain on the lower abdomen, you can just go for TENS, or you can just go for castor oil pack too if she's having too much cramp. And third and most important part, the pelvic floor rehab. We have to work on this muscle, this hammock shaped muscle. You can see we have to work on this muscle, basically contraction, then relaxation, contraction. So this Kegels can be your quick contraction can be there and can be the relaxed one, then hold, then contract, then hold. So there are two types of Kegels. Basically, first is your normal Kegels, you are doing contraction, then relaxation, then your quick contraction. You have to just seek this. So basically, we are working on the journal management, your second, your pain part, pain management, and cramp management, and third is your pelvic floor rehab, which is most important as a physio, as a pelvic floor rehab therapist in a life of women. And if she is like moving to pregnancy, if she's like having any dysfunctions in her pelvic floor due to pelvic floor or due to hormonal changes, there can be a lack of your menstrual cycle, that is amenorrhea. There's pain, the cramp-like pain, that is dysamenorrhea, and PMS symptoms due to hormone low level of serotonin. So basically, if there is any dysfunctions is going on, we can we have to work on the seek for the muscle strength part first. Then second, just know about the hormone level with the test. And third is your mood swing. Just work on the mood swing, because whenever we are going for the exercise, endorphin releases, or endorphin will definitely help you in feel good hormone and will make you happy, and it will help you in release of the muscle too. So this is it, because I think there's a lack of time, as I already told by the moderator. So this is all about. If you want to ask anything, you can ask.
Thank you so much, ma'am, for your wonderful
Yeah,
speech.
and if you wanna get more data or women health, so this is the book. It's all about pregnancy, and this is the second book. It's all about periods. So you can just get the more data on these books. And sorry for the morning time.
Thank you so much, ma'am, for this wonderful information. Definitely, it must have benefited a lot of people in this room right now. So now I would like to call upon Dr. Pooja, who is an assistant professor of MGM School of Physiotherapy, Aurangabad, India, to announce the winners.
Thank you so much. Within 10 minutes, we are going to announce the winner for all the presentations. So we can take a break for 10 minutes.
Okay, thank you so much. Hello, everyone. Now we'll, hello, am I audible?
Yes, yes, you are audible. Go ahead.
Okay, okay. Good evening, everyone. Now I would like to call upon Dr. Pooja Mutar, who is an assistant professor at MGM School of Physiotherapy, Aurangabad, India, to give the prizes to the participants.
Thank you, moderator. Good evening and greetings to everyone from Dr. Pooja Mahaset and Dr. Pooja Motar. Thank you for everyone for joining our international conference Rehab Econ virtually. And thank you for your patience. Now I would like to announce the result for all the presentations that happened yesterday and today. Due to a lot of abstract submissions, there is way too many ties between the participants. Now, it's our honor to announce the winner from the domain cerebrovascular disease. I'm giving the mic to Dr. Pooja Motar to announce the name for the academicians.
So, for the session cerebrospinal disorder academician category, first prize goes to Dr. Sumitra Shekhawalkar and Yogeshwari R from Sri Ramachandra Institute of Higher Education. Second prize goes to Dr. Pallavi Palaskar, MGM School of Physiotherapy, Aurangabad. On the third place, there are two participants, Dr. Sneha V. Kinney, MEHS College, and Dr. Pooja Mahaset, MGM School of Physiotherapy, Aurangabad.
Huge round of applause for all the winners.
Thank you, ma'am. Then, second category for academicians were integrated category. In that, the first prize goes to Dr. Veronica Godwin Aju from Columbia College of Physiotherapy, India. Second prize goes to two participants, Dr. Gaurav Bhatnagar, Maharashtra Institute of Physiotherapy, India, and Dr. Suman Sani from Chaurusat University, India. Third prize goes to Dr. Maraswati, Columbia College of Physiotherapy, and Dr. Ravindra Kaur Marwaha from Mayor's College of Physiotherapy, India. Huge rounds of applause.
Thank you, ma'am.
Moving forward to the students category, we have first category, integrated category. In that, the first prize goes to Sabha Sheikh from MGM School of Physiotherapy, Aurangabad. Second prize goes to Ponimathi P from Srihar College. And third prize goes to Maliha Fatima from MGM School of Physiotherapy, Aurangabad. Second session is cardiopulmonary disease category. In that, first prize goes to Prachi Nakhade from Dr. Vittal Rao V.K. Patil College of Physiotherapy, Ahmednagar, India. And Komal Agarwal, Sakra World Hospital, India. Second prize goes to Kavita Kumari, ISIC Institute of Rehabilitation Sciences, India. And the third prize goes to Heli Shah, Shri Swami Narayan Physiotherapy College of India. Moving forward to the third session, that was community wellness. The first prize goes to two students, Kanshi Vetekar and Saurabh Mahajan from MGM School of Physiotherapy, Aurangabad. Second prize goes to Janisha Gohil from Charusat University and Vidhi from Kaher Institute. Third prize goes to Mansi Gavare, Lokmanya Tilak College of Physiotherapy. Next session track was musculoskeletal student category. The first prize goes to Apurva Nale, Kaher Institute of Physiotherapy. Second prize goes to Tejasvi Kumar Patel, Savitri Bhai Patel College of Physiotherapy. And third prize goes to Rutuja Pahadke from Kaher Institute of Physiotherapy. The last category was cerebrospinal disorder student category. And the first prize goes to Arshi Shah from School of Physiotherapy, RK University. And Kavita Shirodkar, MGM School of Biomedical Sciences. Second prize goes to Hita Shirin from Kempegowda Institute and Disha Shah from Dr. APJ Abdul Kalam College of Physiotherapy. The last prize, that is third prize, goes to Medhavi Himanshu from University of North Texas. Thank you to all the participants for participating with great enthusiasm.
Those participants who is not here to listen, all of you will get your winner certificate through your mail. Kindly download it.
Thank you so much.
Thank you so much.
Ma'am, participation and presentation certificate will also get on the mails.
Get the participant certificates, winner certificates through mail only. There will be a link you have to download from there.
Ma'am, I would like
to thank you very much, ma'am.
For
Hello,
victory speech.
till when it will be till when it will be uploaded on mail? That link will come on mail.
Sir, within 2 to 3 days, sir.
Okay, madam. Okay, madam. Thank you, ma'am. Thank you. Yes, ma'am. Thank you.
Thank you all for attending this conference. I would like Dr. Pooja Mahaseth to come up and give the valedictory speech and end this session today.
Thank you so much for calling me out. Okay, greetings of the day to everyone. It was such a wonderful day and it was such a successful conference which happened. This is me, Dr. Pooja Mahaseth, Assistant Professor from MGM School of Physiotherapy. I'd like to welcome everyone on the behalf of MGM School of Physiotherapy. And it gives me a great honor and an immense pleasure to deliver this vote of thanks for this event to all the dignitaries who assembled over here virtually. First and the foremost, I would like to thank our chief patron, that is Sri Kamal Kishore Kadam sir. He is an honorable chancellor from MGM University, MGM Trust, India. Our patrons, Sri Ankush Rao Kadam sir. He is an honorable secretary, MGM Trust, India. Dr. Sasank Dalvi sir. He is an honorable vice chancellor from MGM IHS, Navy Mumbai, India. Dr. Praveen Suryavanshi sir, he is a Deputy Dean from MGM Medical College and Hospital, Aurangabad, India. Dr. PM Jadhav sir, he is a Honorable Vice Chairman, MGM Trust, India. And to our Dr. R.B. Bora sir, he is a Dean from MGM Medical College and Hospital, Aurangabad, India. I would like to thank the convener. Those are Dr. Rinkal Manali, she is a principal from MGM School of Physiotherapy, Aurangabad, India. And Dr. Pooja Motar, she is assistant professor from MGM School of Physiotherapy, Aurangabad, India. To the steering committee chair, our respected principal ma'am, Dr. Rinkal Manali ma'am, and our respected administrator and a deputy registrar, Mrs. Prerna Dalvi ma'am from MGM University, India. Moving forward with the main pillar, that is our keynote speakers, I'd like to thank Dr. Rahman Khan. He is a faculty of Medical Rehabilitation Science, Department of Physical Therapy from Saudi Arabia. Dr. Ken Ware, he is the head of research and development from Neurophysics Therapy Institute, Australia. Dr. N.S. Senthil Kumar, he is a Chief Operation Officer and Executive Director from Association of People with Disability India. Dr. Sikha Singh, she is a women's health physiotherapist and PFM specialist from Perfect 10 Maternity Rehab and Pelvic Floor Physiotherapy Clinic, India. To Dr. Chance Christian, he is a General Secretary from IOSHA and Assistant Lecturer from Department of Physiotherapy, University of Rwanda, East Africa. Dr. Sri Kanti, he is from Mental Health Professional, Psychiatric Social Worker, India. I'd like to thank Dr. Rajkumar Yadav. He is the Associate Professor from Department of Physical Medicine and Rehabilitation from AIMS, India. Dr. Geeta Seth ma'am, she is the founder of Geeta Seth Nutrition and Dietitian, Indonesia. Dr. Snehal Dharmat ma'am, she is Associate Professor and a Head of Department from Kahir Institute, India. Our role model and motivational speaker, Subhajit Bhattacharya from India. Dr. Todd Robert, CEO and co-founder from Assistive Technology Development, United States, and Dr. K. Vadivelan sir, he's a professor of SRM College of Physiotherapy, India. Moving forward, I would like to thank the judges from bottom of my heart for evaluating and spending their most precious time. The judges I would like to thank are Dr. D. Malhar ma'am from SRM College of Physiotherapy, Chennai. Dr. Itini, he is a CEO of IOSHA, Rwanda. Dr. D. Anandi ma'am from SRM College of Physiotherapy, Chennai. Dr. V. Selva Ganapati sir from Nimhans Hospital, Bangalore. Dr. Motimat sir, he is Associate Professor from Keli. Dr. Jubair Ahmed sir, he's Associate Professor from Royal College of Physiotherapy. Dr. Samet Khatila, he's the General Secretary of Nepal Physiotherapy Association, Nepal, and Director of Orthoplast. Dr. Jyoti Parle ma'am, she's a professor and HOD from Lokmat Tilak College of Physiotherapy. Dr. Pooja Agarwal, Assistant Professor from Lokmanya Tilak College of Physiotherapy. Dr. Sugasri Suresh Kumar ma'am, she is an assistant professor from Meenakshi Academy of Higher Education and Research, Chennai. Dr. N. Ramesh Kumar sir, he is a professor and HOD from YMT College of Physiotherapy, India. Dr. T. S. Muthu Kumar sir, he is a principal of Rivati Institute of Physiotherapy. And Dr. Sarfaraz Nawaz Sa, he is an associate professor from Krishna School of Physiotherapy and Rehabilitation, India. I would like to thank the moderator, the team from Neuro Department, MGM School of Physiotherapy. They are Dr. Nawaz Pathan, Dr. Pallavi Palaskar, Dr. Namrata San, Dr. Serin Paulos, Dr. Pooja Motar, including me, along with some other students. Along with that, I would like to thank, and it's a great honor that MGM School of Physiotherapy and ACNM combined together and organized this conference. So I would like to thank the Association for Clinical Neurology and Mental Health for giving opportunity for all the researchers out there. The academic partners, SPV Physiotherapy College, Lokmanya Tilak College of Physiotherapy, the scientific partner, Bioleagues, the research partner, and the media partner. Lastly, I would like to show my endless gratitude for the audience for making this function as a grand success. Once again, I would like to inform this to everyone. We have more than 160 paper presentation and abstract we received and more than 300 participants. I would like to thank them and I would like to show them my gratitude and I would like to appreciate all of them for participating in this conference. Once again, thank you and appreciation for everyone and thank you for giving your attention. Thank you so much for listening to us.
Thank you so much, ma'am. Thank you so much, ma'am, for this wonderful valedictory speech that you gave. I would like to thank all of you for joining us for the International Multidisciplinary Rehab Econ 2022. We look forward to see you again. Thank you.
Thank you so much. All of us can leave the meeting.